keeping up with the spirit even on the last day of the conference, let us start today our very first session of invited guest lectures. I would like to call upon stage Dr. Sribas Mohapatra sir to present on the topic Innovations in Surgery, with the chairpersons to grace the dais, Dr. Inuganti Gopal and Dr. P.K. Patnaik. I would request the very first speaker, Dr. Sribas Mohapatra, to present on the stage to speak on the topic Innovations in Surgery.
हाँ सर सर ऑफ करवा देता हूँ कर दो सर
I am not the first. Okay, good morning to all the distinguished delegates and good morning to the chairpersons, distinguished chairpersons. Really, I am grateful to the organizers of this 2024 OSASICON and the prestigious Institute of All India Institute of Medical Science. Well, we have discussed yesterday in details about the tips and techniques of different minimal invasive and methods. But today this is a little out of the way, some innovative methods. So with innovation, there is some enthusiasm in innovation. When you repeat things, it may not be enthusiasm. Now, experience of working on innovative methods, I started in SCV way back in 2007, 2006. Then I got transferred to as professor to Burla in 2008, and I continued there with certain other departments cooperation. And now also I'm working as a senior consultant at Vikas Vinayak Hospital after retirement last year. Now a dream doesn't become a reality through magic. It takes sweat, determination and hard work for the dream to achieve. So I must acknowledge this Department of Surgery of SCV, VIMSA, Department of Pathology, Department of Anesthesia, Sickle Cell Institute of VIMSA, NIT Rourkela, my colleagues, students and of course my patients, without whose cooperation I would not have been able to achieve these innovative methods in teaching and research and treatment. So two innovations. And skill, treatment in skill. I'll just briefly, I have not included in the slide, but teaching innovation, treatment innovation and skill innovation. So three parts, in the two slides we have two parts. Now, this is called cricketing approach to abdomen. It has come in the e-journal of the association yesterday released. So you will have the pleasure to go through this cricketing approach to abdomen. This is for teaching innovation, because now the students are not going through books. They are going through Facebook, WhatsApp and YouTube. They are not coming to class. So they don't go. This has come in textbook of surgery and method in a clinical method book. But they don't read. If I ask my undergraduate, postgraduate, do you know what is cricketing approach? They say no, we don't know. Well, very good. But when I go outside as examiner to Guwahati, to Manipur, and ask them, they say, yes, we know this. So they are reading. Our students in Burla, when I assess their undergraduates, don't read. So this, if you ask who scored 6 in fast over, they will say, name six cricketers, international, national cricketers who have scored fast over 36 runs. But if you want ask these 6 runs, they will not. What are the 6 runs here? The abdomen is a cricket field, the stumps and the crease line and the pararectal lines and the periphery center. We know 6 runs we get when we first catch the ball in the periphery. So in the periphery we have supraclavicular lymph node, inguinal hernia, testis, and the scrotum, and the spine and the flanks. So testis is very important. It can give an abdominal problem like tumor or pain, torsion. Supraclavicular lymph node related to abdomen problem. Hernia related to abdominal problem. So in Then inside the abdomen, one should think of the lumps and the lump. If there is lump is there or not, or lumps, liver, umbilicus, moving dullness, and palpating, guarding, rigidity, tenderness, rebound tenderness, all these are scored. Has scored 6 runs. And then come to abdomen for lumps and lump. And then diagnosis become easy. These things are forgotten. In emergency and in OPD also, I find patient presenting with epigastric lump, the candidate, the PG student or the undergraduate don't know, are not examined the testicular tumor. Patient present in the emergency with abdominal distension, he has not looked to the hernia. So if you score the 6 runs in the beginning of your clinical examination of the abdomen, because we play over abdomen, it will be very easy for a diagnosis. And if you find a lump in the abdomen, it is a surgical abdomen. It is not a medical abdomen. So that is so details are there in the e-journal. This time I am thankful to the organizer to include this in the journal. Second is the triple ABC technique for breast disease evaluation. This is clinical breast evaluation. Everybody know for early detection of breast cancer, cell breast at the family level, but at the outdoor level or survey level, when you go for survey, clinical breast examination is very important. These can be module, a model or a package, a triple ABC, axilla for A, breast for B and C for cervical area. So you need to examine 3 ABC. At least this, all undergraduates and postgraduates can apply this formula and they will not miss a localized disease or a regional disease or a distant disease. The axilla, breast, neck, axilla, breast, neck of the opposite side, and abdomen, bones, and chest, ABC. So if these 3 ABC, once remembers in the concept wise, the diagnosis of breast cancer and localized cancer, regional spread, distant spread will not be missed clinically. And clinical breast examination has been given top more priority in breast screening programs now. So all the nurses, paramedics can be taught this program, not the undergraduates and postgraduates for their examination. Now this is another, so this is also there appeared in textbooks of surgery and clinical method book, appeared already. And this is stethoscope sign in appendicitis. Another beautiful concept to detect appendicitis at peripheral level. We have ultrasound, CT, MRI, ye kar do, wo kar do. But we never apply the classic McBurney's test of releasing sign because novice don't know where to put the hand, how to release the hand. It is not for the surgeon. It is for the peripheral doctors who are working. They will put here hand, there hand, press deeply. But if you use the stethoscope over the right iliac fossa and listen to the bowel sound, whether peritonitis has started, that will be absent, and slowly depress the diaphragm deep, and patient will complain of tenderness. So slowly release. You suddenly release the stethoscope, patient will, wow, so that will rebound tenderness. This is easier because you are doing an instrument. Direct hand method is the fast lever. If you are using an instrument like bell of the stethoscope, it is a device like a screwdriver. It is easier to elicit the sign, physics behind that. So added, the child, give the stethoscope, let the child play. And as the young girls, if you put your hand directly in the lower abdomen, it may be offensive. So give stethoscope. So these are the innovation in the teaching and in cell therapy innovation in the treatment that I have already talked elsewhere. Belly loves short practice of surgery has chapter 4, tissue engineering and regenerative therapies have come. So I have applied in different conditions. These are the conditions I have applied. Complex fistula, incisional hernias for mesh coating with stromal cells, in carcinoma breast following MRM to the breast bed, in chronic diabetic ulcers, sickle cell ulcers, Borges disease and peripheral vascular disease, in Hansen's ulcer, and in complicated bones ulcer, I have applied autologous stromal cells with good result. So these are the material methods. Who are interested, I will let them know. And we have compared and found that the result is very good. And I presented this paper recently in Cambridge. This was presented in my association. I got the first prize, our experience with cell therapy. Then this has come in textbook of orthopedic rheumatology. This innovative treatment has come in textbook of orthopedic rheumatology, edited by one Manish Khanna, orthopedic surgeon in Lucknow. And this is the modified Trendelenburg procedure for varicose veins. This skill innovation. Usually in Trendelenburg operation, we ligate the saphenofemoral junction and the 5 tributaries. But a novice, a beginner, when he goes to junction, he finds difficult. He may cut the saphenous vein, lung saphenous, he may cut the femoral. So what do? You just catheterize like venesection, you pass a feeding tube below so that the junction becomes very easily detectable, and you can approach and ligate the 5 divisions by 5 tributaries there. So this has come in Indian Medical Association Journal, Journal of Indian Medical Association, modified Trendelenburg procedure for varicose veins. And lastly, this is the University of Cambridge. In September I presented, and you see they are appreciating, there's very good research they have commented. So I am proud to present before most of the chairs are vacant, but distinguished persons are here. They may disseminate knowledge along with the chairman. Here are the appearances. My time has a wonderful way of showing what really matters. Thank you.
Hello. Thank you so much, sir. You are always an inspiration to the younger generations, because at your time, students usually follow books and all, but yeah, as you are one person who shows a path to, there is still scope for innovations in all fields of surgery, and really we're very proud of you, sir. Thank you so much. And I think he needs a good clap for this.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you so much, sir. Next, I would like to call upon stage Dr. Banbihari Mishra, sir, to speak on the topic unusual hepatic mass.
Esteemed chairpersons and the 10 esteemed delegates sitting in the audience. This is a memorable moment, and it will remain as a memorable event for me to present to this intellectuals. So I'll be very careful in my presentation. Innovation should take the priority. So I don't give a fate, even though I was the speaker, innovation has taken the priority, and the surgeon scientist of the state, Professor Srivastava Mahapatra, has presented first. I will just present before you a surgical case. This is an unusual hepatic mass. So whenever you say hepatic mass, probably you think of so many, classify them, congenital, traumatic, all those things, cystic swelling, solid swellings. You know of hepatocellular carcinoma. But I'll be presenting a case of a hepatic mass, which is really unusual. And maybe that at the end of this, my presentation, you will also feel that it's definitely unusual. I'll be very brief. If you see, I'll not go to the details. Presented with a lump over the lower quadrant of the abdomen for last 3 months. If you see, there was no associated symptoms, and to start with, notice a lump which was slowly growing, not associated with any constitutional or any symptoms at the local sites like whatever I have mentioned, and also no GI symptoms, even though it was in the right iliac fossa. First history, if you see, there is nothing suggestive. Family history, also nothing suggestive. So this is the personal history, and on general examination, everything was found to be normal. Local examination, I will just say that abdomen on inspection, everything was normal. On palpation, there was a well-defined intraperitoneal globular non-tender lump of 18 to 10. palpated over the right lower quadrant of the abdomen, uniformly formed, smooth surface, freely mobile, and liver is not enlarged. This is a point to be noted that there is no hepatomegaly. There are no other organomegaly. All these findings are nothing. If you see, auscultation didn't reveal anything, DRE didn't reveal anything, no systemic findings. With this, since it was a mobile tumor sitting in the lower quadrant of the abdomen, the clinical diagnosis was probably a cyst. Second diagnosis was a mesenteric cyst. We subjected to all the routine hematological biochemical tests, normal, so, and just these investigations routinely done to rule out any associated malignant lesions, normal. Then ultrasound said that it is a well-defined solid heterogeneous hypoechoic mass with internal vascularity and foci of calcification in right left fossa with radiological diagnosis of benign soft tissue tumor, mesenteric dermal tumor or a cyst. So the hallmark of investigation of is the CT. If you look at the CT, probably you will see a lesion here. Here is the liver, which is normal. And if you see, I will go back again and show you. You just try to see it. So if you see, the lesion is almost uniformly present, and the borders are very clearly defined. It is a soft tissue lesion. We are lucky that MRI can be free with us. So we have done a MRI also because it was looking peculiar. The same impression was there, including the differential diagnosis of cyst, subcellular cell fibroid, everything. Chest X-ray was normal. We planned for a diagnostic laparoscopy and next proceed. So with everything optimization, we did a standard 4-port plus vent and we went for the diagnostic laparoscopy. Our finding was surprising that it was a plunging pedunculated hypervascular mass of size approximately 10 to 7 originating from the anterior liver margin, segment 7. If you see, I will show you the picture that this is the gallbladder and it looks hypervascular.
वीडियो करा
Just listen.
वीडियो करा
See, this is the liver
वीडियो करा
and this is almost a
वीडियो करा
pedicle and this
वीडियो
is
करा
also looking like
वीडियो
a
करा
second.
I don't know what is the pathology
Just
of this
looking like a
specimen.
second liver.
This will
And
be
once
the
you see
seeing it
this,
for the
there is
first
no doubt
time.
that this is nothing other
Hela
than the
वीडियो बढ़िया
hepatitis.
गया
And this is
है
the
ये देखो gallbladder
pedicle. So this is the picture. Now, when you go back to the city, immediately I went back to the city, that what I had missed in the city, why my diagnosis was difficult. See, even the radiologist had missed, and I should have behaved like a surgeon radiologist. I had missed this. This is the lesion, this is the liver, and this is the connector. So if you go back to the picture, probably the same thing. Now, whatever I had thought, my surgery became very simple. So I just came out with the resection. I just divided from here. So in summary, if you see, clinical was confusing, radiological and confusing, diagnostic laparoscopy yielded the diagnosis. The treatment was very simple. It appears to be of hepatic origin and almost clinically it looks like the liver tissue. This is the specimen and this is the cut section of the specimen and the histopath, and this specimen was removed with a separate small incision because the aim is never to disturb the architecture of the lung. The histopathology report is also very important. We had removed the gallbladder also because it was in close vicinity to that and it was hypervascular. There was little bit injury. If you see this, the histopathology report confirmed at two places the biopsy report was a hepatic steatosis, focal hepatic steatosis. The course in the hospital was satisfactory. This is a repeat X-ray. CT, post-operative CT done after 2 months. You see, everything is normal. So the diagnosis, final diagnosis is a focal hepatic steatosis. I will ask a question to the audience that anybody has come across a focal hepatic steatosis presenting as a lump, because I went through the literature, the number of cases reported are very few. So focal hepatic steatosis can present sometimes with a mass. I had never thought. So, in conclusion, non-alcoholic fatty liver disease can present in different forms. It is more often diffuse, but can also present as a focal lesion. It must be differentiated from the other hepatic mass and intra-abdominal tumor containing the fat. I think the only thing I had committed the mistake is reading the CT. If I would have seen the pedicle interpreted in the right way, I would have thought that probably it is of hepatic origin. Because of the pedicle, it was a freely mobile swelling. Thank you very much.
Thank you, Bono. Nice case. You see, you stand in front of a sea beach, a huge wave comes. You are scared, but it just melts down and washes your feet and goes away. Similarly, a surgeon goes inside the abdomen with trepidation and palpitation, and he is lucky he comes out with just a clipping or excising very easily. This has been the case because you have been a sincere and indulgent surgeon.
But not innovative.
Okay?
Why not, sir?
Sir,
So-
you reminded of a Odia movie. Actually, I'll take 30 seconds. When you think of the sea and the wave, see, Odia re kahithile, jetebale wave asuchi, ta agare au ego temper dekhebeni, sidha thiya hebeni. You just bend your head like this. The wave will come and pass away. You will enjoy this scene. Thank you very much.
Okay?
Sir.
Thank you.
So I have a small question, sir. Sir, yes, we missed the CD for sure. But sir, I just wanted to know what are the clinical findings, because this type of lesion, I'm sure clinically also would not have made sense, but just for my curiosity,
Yes,
what are the
yes.
clinical findings, sir? Will we be able to reach the upper limit of the swelling? Number one. Number two is, was it moving with the respiration? And number three is, was it side to side mobile? That's three questions. sir.
Fine. I have told few things that the perimeter of the swelling was clearly palpable. Number one, it was freely mobile. There was no hepatomegaly. Three
Okay.
things.
But it's not moving with the respiration.
They're not moving with respiration.
Okay. And the
Because it had
upper-
the pedicle.
And upper limit was reachable.
Upper limit clearly, perimeter was clearly visible. That is why there was a
It
diagnosis.
was quite visible, sir, because the pedicle on the
Yeah.
stalk was so thin, you'll not be able to make sure for sure.
That is what my message to all surgeons is, that we must behave like surgeon radiologists, surgeon pathologists. Then only we can improve, because the radiologist might miss. Thank you again.
Except brain, lipoma can occur anywhere. Steatosis, what is steatosis? And it got hepatoma, which can come down, some serosal sometimes may come down. So it's a very wonderful case, very, rarely seen. Thank you very much for good presentation.
Thanks for your comments, sir.
So it is a liver tumor away from the liver.
Thank you so much, sir, for your informative insights. Next, we have Dr. Hemant Kumar Nayak, sir, who will be presenting on emergency endoscopic intervention.
Respected faculty members and respected eminent surgeons, And thank you, the Odisha Surgical Society, Dr. Sanjay Giri and his team to giving us the opportunities. I am a gastroenterologist. I am the odd man out in this eminent surgeons conference. So my presentation is on emergency endoscopy intervention. So we know, any patient who required an endoscopy within 4 hours of presentation is defined as emergent endoscopy, whereas if the requirement of endoscopy is within 12 hours, it is defined as emergency endoscopy, and you may extend the duration up to 24 hours. Emergency endoscopy has utility in various diagnostic and therapeutic GI diseases. For that, we need a good set of uh, things, that is experienced endoscopists, experienced technicians, anesthetic supports, good ICU backup, and also good surgical and IR backups. We need a good endoscopic suite for performing all these advanced endoscopic procedures with good set of good endoscopes and also accessories. So coming to the indication, what are the scenarios where you need an emergency endoscope, like GI bleed, foreign body removal, a luminal perforation, anastomotic leak, that is a nightmare for both gastroenterologists as well as surgeons. Post cholecystectomy bile leak again is a nightmare for surgeons, where you may require an emergency ERCP. Cholangitis, any form, be it a benign or malignant cause. Then infected valvo-pancreatic necrosis, post-surgical fluid leak. These are the conditions where you need an emergency endoscopy. So coming to the first esophageal variceal bleed, we know one of the common GI emergencies, resuscitation should be done in first 4 hours. After resuscitation, endoscopic variceal ligation should be done. Endoscopic variceal ligation is the standard of care for esophageal varices, and more than 90% of times you are able to control the bleed. This is a case scenario with massive hematemesis. On endoscopy, it was found to have large esophageal varices, underwent endoscopic variceal ligation, so hemostasis achieved. Then second category is gastric variceal bleed. It has less propensity to bleed compared to esophageal varices. If we inject the cyanoacrylate glue, the hemostasis will be achieved. So this is a case of our own patient of large gastric varices with bleed, received 3.8 ml glue injection, hemostasis is achieved. Then third category is that is non-ulcer bleed, non-variceal bleed, that is peptic ulcer bleed, where that extend from spotter, oozing, variceal bleed, that is also non-variceal bleed. You may need injecting adrenaline, applying mechanical clip. Okay, then next category is foreign body, where the emergency endoscopy is needed urgently. Foreign body is GI foreign body is less dangerous compared to respiratory foreign body. The most of the time it passes spontaneously, but there are certain situations you need an emergency endoscopy. For example, if the foreign body impacting the esophagus, if it is a sharp pointed foreign body, if the disc battery is impacted in the esophagus, you need immediate endoscopic intervention. And in other conditions like non-sharp objects, esophageal foreign body with partial luminal obstruction, you may require an urgent endoscopy within 24-hour period. So the next categories of emergency endoscopy requirement in cases where endoscopic closures in luminal perforation. Luminal perforation occur usually following iatrogenic cases like post endoscopic submucosal dissection, and sometimes in also in following the endoscopic therapeutic endoscopy. So these are the conditions where you need an endoscopic closure, like esophageal perforation, gastric and duodenal perforation, colonic perforation. So you need some gadgets, like you need a covered metal stent, as well as you need a clip which is able to close the defect up to 2 to 2.5 centimeter. So you apply the clip by using the standard endoscope, just like endoscopy variceal ligation. So I am just discussing few of the our interesting cases which was managed by endoscopic maneuver. So one meat impacted in the mid esophagus. After endoscopy removed, after removed it endoscopically, we detect a defect in the mid esophagus, which was sealed by placing a covered metal stent. And subsequently, after 8 weeks, we removed the covered metal stent. The leak sealed. Another patient of achalasia cardia who underwent pneumatic dilatation. Post pneumatic dilatation, what we observed, there is a rent in the distal esophagus, which was sealed by using a covered metal stent, which was removed after 8 weeks, which completely showed the sealing of the perforation. Then it is our own case, neuroendocrine tumor. We have done an ESD from the D1 D2 junction with the presumption of there is probably a perforation in the D1 D2 junction. We placed an OTSC clip. After 4 weeks follow-up, we found there is no obvious leak or no perforation at this site. Then there is coming to the next facilities, that is emergency ERCP. These are the conditions where you need an emergency endoscopy like bile duct injury, cystobiliary communication with cholangitis, both malignant and benign biliary obstruction with cholangitis, where you need an emergency ERCP within for 24 hours. Here is a classic case of post-cholecystectomy bile duct injury. What you get, there is a large biloma in the lesser sac with right hepatic artery aneurysm, DSA coil embolization done. Then we do an endoscopy. What I found, there is a large gastric bulge bulging into the stomach. We have done an first we place an US guided lumen opposing metal stent which drained around 4 liters of infected bile. Then subsequently patient underwent ERCP. We found there is a leak in the hilum. Then we placed multiple stent. Patient developed benign biliary stricture, kept on stent exchange program, and the stricture opened off after 18 months of endoscopy therapy. The next case, in a hydrated liver case, underwent cystopericystectomy, post-operative day 2 developed severe cholangitis. What we find, there is school legs inside the CVD. We do an EPT, remove all the hydrated cyst membrane, stenting done, cholangitis impressed. Third case, benign biliary disease with choledocholithiasis with severe cholangitis. We do an good EPT, stone was cleared. Then in case of malignant biliary obstruction like CHOP, CA pancreas, CAGB and hilar cholangioCA, patient present with the cholangitis. So first case is a distal cholangiocarcinoma with cholangitis. We place stent after doing ERCP. Second case, CAGB with hilar block. All the 3 systems get blocked. So we place 3 plastic stent into all the 3 systems. And fourth case, another patient of hilar block with cholangitis. By placing multiple stent, we are able to control the cholangitis so that the patient is fit in next 4 weeks for surgery. Then US intervention in emergencies, there are few indications. We need an urgent US like infected Waldorf pancreatic necrosis, post-surgery fluid collection, post-ERC fluid collections. So one patient of infected WPN with severe sepsis, hypotension, we just place an lumen opposing metal stent, drained around 1 liter pus intraprocedural, and the patient improved subsequently. Another patient of post-Whipple's developed some collection in the lesser sac, not amenable to ultrasound or CT guided drainage. We just placed in 7 French plastic stent to US guided, and the drain was the collection was completely drained. Another patient developed after post-ureteric intervention, developed some prostatic abscess, pelvic abscess, not amenable to ultrasound or CT guided drainage. So we just from the rectal station, we just do an US intervention, drain all the pus, and the patient improved subsequently. And also in gastric varices, by using US intervention, you may place coil and glue into the gastric varices, and that was taken care of. Sometimes in splenic artery aneurysm with massive bleed, patient may not have the adequate finance to do an DSA and coil embolization. In that case, we have US scope. You can target the splenic artery aneurysm, coiling it, glue it, and you can able to achieve the hemostasis. So emergency endoscopy is a life-saving many times. It is complementary to surgery and IR procedure. But for that reason, we need a good team and setup. Emergency endoscopy procedure is helpful in many patients, and it should be individualized. Thank you for your kind attention.
Thank you, Dr. Saab. Tell me, in a variceal bleeding Dulafoy, bleeding DU, you have everything in your armamentarium. In what sequence you proceed?
So in bleeding Dulafoy, I will first place and clip.
Okay.
So many times, in 90% times, you are able to achieve the hemostasis after applying the clip. Sometimes if it is re-bleed, you are unable to control the bleed after applying clip. In some occasions, we just use our US scope. We inject, because it is a submucosal lesion. we by using our FN needle, we inject the glue into the submucosal vessels, so the bleeding will control. So first is definitely clip with adrenaline injection to the base. This is the first. Then if it is not controlled, then we may plan for an US intervention. If that will not control, then for DSA higher intervention.
For varix,
For varix, more than 90% times we are able to, 95% time we are able to control it. So
by clip or injection.
normally for varix by varicose ligation, if it is esophageal varices, EVL is sufficient. If it is gastric varix, more than 99% time we are able to control it by injecting glue. If it is not controlled, then we plan to do an US guided coil and glue. If it is not controlled, then we may require a higher intervention in the form of BATU or PATU or TIPS. But it rarely required.
DU,
Duodenal ulcer. Duodenal ulcers are nowadays it is easy to control because of advent of OTSC clips. Even if it is not controlled with conventional clip, we can apply our OTSC clip because it has large jaw of opening diameter of 2.5 centimeter. So even if it is a big varix, big ulcer base, we are able to control it by applying OTSC clip.
thank you. Any other question?
Sir, yeah, first of all is that you're not out of this lot, you're a part of it. My question is a simple one. Like I am now a department of MKCG Medical College, we have our own endoscopy unit, the full unit with ERCP also, but we are not yet started ERCP. I am in charge of the department. My simple question is, do you advocate surgeons taking up endoscopy? Surgeons taking up endoscopy, like you told you're a gastroenterologist, so you're out of this lot. No, but do you advocate surgeons taking up endoscopy? Because I am training my postgraduates, my assistant professors, SRs and all for upper and lower GI. We are slowly entering into therapeutic procedures, but do you advocate?
Yes, no problem at all, sir. For their own patient, it will be more beneficial.
Thank you.
Thank you.
Thank you, sir.
It's a watershed line, sir. It is difficult to tell that gastroenterologists or surgeons should take over. It is only for the benefit of the patient. So if you can take over or they can take over, it's not a question. It's a branch. It's a good branch. So my question is that there are no intervention in emergency in lower GI. You haven't told that.
Yes,
so what are those things? Second things, nowadays we have come up with enteroscopes. So is there an intervention which can be done in enteroscopes? Because nowadays we are having.
Yes.
So those can be taken.
Yes, sometimes after colonoscopy also, sometimes colonic perforation. So if it detected early within 4 hours, so we can apply the OTSC clip. Then in case of malignant colonic obstruction, so patient is very unfit for malignant colonic obstruction, patient is moribund patient unfit for surgery. So in that case, we may place a colonic stent to decompress. Third, in case of small bowel lesion, sometimes small bowel bleed, small bowel polyp, we can do an enteroscopy and enteroscopy guided therapy, just like upper GI and colon. We may do an FPC for Dulafay lesion in the small bowel. You may apply a clip. You may do a polypectomy. That can be done with this small bowel enteroscopy. Thank you.
Thank you.
Another question. Yeah.
Last, sir. In case of intestinal obstruction.
Yes, we have done once only. Gastrojejunostomy, US guided GJ for pyloric obstruction or D1, D2. Yes. Thank you very much.
Thank you, sir. Thank you.
Next corner.
Thank you, sir, for that enlightening presentation. Next, we have Dr. Satyajit Sahu, sir, who will be presenting on basics of pediatric cardiac surgery.
This is the last paper, right?
Chairpersons, good morning all. First of all, I would like to thank the organizers, Dr. Sanjay Giri and team, for this opportunity. So today I'll be speaking on something which is very close to my heart. I am Dr. Satyajit. I am working as a senior consultant CTBA surgeon. I do both adult and pediatrics, but I have inclination towards pediatric cardiac surgery. So first of all, we'll decide what is pediatric cardiac surgery. Pediatric cardiac surgery focuses on basically the surgical interventions for the congenital heart defects and the acquired heart defects. So in a way, it affects the growth and development of a kid. So before venturing into the subject proper, let's see what is the burden disease in Odisha. So if you look at, if I had a median birth rate of 17.7 per 1,000 persons and a live birth of around 8 lakh kids per year, the expected incidence, there is no concrete data in anywhere, could not find, but the expected incidence is around 5 to 6 per 1,000 live births. So the calculated number of babies born with congenital heart disease is 4,000 to 4,500 per year in Odisha. And if you look at the infant mortality rate, the congenital heart disease accounts for around 15 to 20% of IMR. So the crux is, if you don't operate these babies, these babies keep on accumulating to the patient pool. So ultimately, you get a huge patient load. So what happens if you don't treat this congenital heart disease? Basically, they have recurrent respiratory infections, they have easy fatigability, and it's basically a burden for the family, loss of work days and earning for the patients, school dropout, and most of these kids in congenital heart disease, cyanotic heart disease, they have early death. So this is basically the chart to see how you detect, how you direct, and what is the ultimate destination therapy. So basically, for any disease, you need the diagnostic tools, the basic diagnostic tools like ECG, echocardiogram, and if you are planning for a surgical planning, then cardiac aspiration. In some cases, we need a MR or CT angiogram, and in some cases, we also need a cardiac MRI or a cardiac CT. So basically, it's an overlook. If you look at the congenital heart disease, basically it's two types, the cyanotic and the acyanotic. The acyanotic, the main types are atrial septal defect, ventricular septal defect, or PDA. And if you look at the cyanotic, it's a tetralogy of Fallot, or it's a DURV, or a transposition of great arteries or truncus kind of thing. So when a kid comes and we plan the surgery, so there comes what are the pre-operative considerations. First is a assessment. You need to assess the child. You need to have a comprehensive evaluation of the cardiovascular function, and it's a team approach. So basically it involves the pediatric cardiologist, the pediatric cardiac surgeon, the pediatric cardiac anesthesiologist, pediatric intensivist, and the pediatricians. So basically the pediatric cardiologist who makes the diagnosis, and he helps a lot in the surgical planning. And if you consider the pediatric cardiac anesthesia is one of the most difficult and challenging branches of cardiac anesthesia. When you're putting a line in a 2 kg kid, sometimes it takes hours to put a line in a 2 kg kid. So it's a unique challenge in case of infants and neonates. Monitoring is most important, whether it's a pre-operative or intraoperative or post-operative, because these cuts have a very low margin of safety. And there has to be tailored anesthetic protocols different for different kind of patients. So if you discuss the common things, the most common is atrial septal defect. Basically, it's a communication between the right and the left atria, the blood shunts. And if you don't treat these kind of patients, they don't really die, but they normally present in the first decade of life. After that, become asymptomatic, and they again become symptomatic in the 4th or 5th decade of life when the PEH or the pulmonary arterial hypertension takes over. So basically, we get lot of patients, adult. Sometimes I've operated even 70 years of patient with atrial septal defect. So basically, it's asymptomatic in infancy and childhood, but basically 4 to 5 years of age is the ideal time for elective closure. That's just a preschool going. So this is one of my operative videos. On the left side, you can see the hole, and this is the pericardial patch closure of the atrial septal defect. The next comes the ventricular septal defect. This is somehow more clinically, it's more significant because the severe pulmonary hypertension usually develops by first decade of life or even earlier in case of large VSDs. So when to wait and watch if the patient is asymptomatic or well-controlled symptoms on medications, or small perimembranous VSD or muscular VSD when the patient is less than 1 year of age. But In this category, we should always advocate an early surgical closure. All the apicanal defects, the subaortic VSDs, the subpulmonary VSDs, because these kind of patients usually land up in heart failure. And when they develop severe pulmonary hypertension, if you operate, the mortality really goes up because they get stuck on the ventilator. So this is one of the patients where I'm operating for a surgical closure. So basically, you put the patient on cardiopulmonary bypass, where the bypass machine takes the function of both the lungs and the heart. That's why it's called a cardiopulmonary bypass machine. You arrest the heart, then you open the heart and close the defect. So it's this case is a right atrium approach. It's a bicable cannulation, and we operate the patient on mild hypothermia. And this is PDA. PDA is nothing but the patent octocytosis. The blood shunts from outward to pulmonary artery. In this case, also severe PH develops by first decade of life. So now PDA can be ligated safely via left thoracotomy, and now VATS. They're also putting clips through VATS. This is one of my surgical where I'm about to tie the PDA. In PDA surgery, the most important is you should protect the recurrent laryngeal nerve. Among the cyanotic group, this is the phyllodes, where there are 4 defects. That's called the tetralogy, and it's curable if it's operated early at the proper time. Around 50 to 70% need surgical intervention around 1 year of age. The indications of early intracardiac repair is repeated cyanotic spells, and these kids are really sick, and persistent hypoxemia when the room air saturation less than 70%. So there are 2 modes of treatment. One is palliative shunt, where you operate for severe cyanotic, but the pulmonary artery physiology is not good, so you do go for a BT shunt. But in most cases, we'll advocate a intracardiac repair. But still, in the best centers of the world, the operating mortality still stands at 5 to 10%. Now comes the most important part, the post-operative care. When you operate a 2 kg kid or a 3 kg kid, you do a good surgery, but basically it's the post-operative care which determines whether the child goes home or not. So basically it's a stringent ICU monitoring, the pain management and the respiratory support. Suppose the kid is on a ventilator, the tube gets kinked, the kid dies. The tube gets blocked, the kid dies. So basically pediatric cardiac nursing, the nurses are the end caregivers, and they are the most significant for this thing to succeed. And in the long-term follow-up, importance of cardiac rehabilitation and ongoing assessment. Complications can happen, infections, arrhythmias, and residual defects. So how do you manage? So if you have any residual defect, you take up the patient as early as for another surgery and do it and correct our mistakes. So early detection and early surgery give the best results. Surgery is curative and permanent. This is the most important. It's a permanent cure. Delay in diagnosis leads to inoperability. And over the period of time, we have improved outcomes. So what do you require for early diagnosis? You need to educate the public. You need to educate the caregiver. So many times you get patients who are VSD, but by the time they come to us, they're already the shunt reversal is there. VSD is such a curable disease, but the patient don't know. The patient don't get actually diagnosed. So we need more number of pediatric cardiologists. We need echocardiogram and lab in all the district headquarters, because most of the time these kids don't get diagnosed. And by the time they're getting diagnosed, they're inoperable. So it's a very sad story. So what do you require for a good surgical outcome? The most important is pediatric intent is based. It's the surgeon at the last, because surgery is hardly 20-30%. So it's the post-op care. How do you manage the kid post-operatively? Ultimately determines the outcome. And to support these kind of things, there are so many schemes running. I think OSTF, RBSK, BSK, and right now they are planning really change the pediatric cardiac surgery scenario in Odisha. My journey, I started as an independent surgical practice from 1st January 2016. Till now, I've operated 602 patients, male 389. 78% of my patients are in 1 to 5 years of age. This is the ideal age where the patient should get operated. And in my, that's acyanotic is 418 and cyanotic is 184. I had mortalities. In the acyanotic, I had 4 mortalities. And if you consider the cyanotic group, I had a little bit more mortality, 17 out of 184. The mortality now has decreased. In my last 2 years, I have not had a single mortality, not because I have refined my surgical skills. I have now decided which one to operate and which one not to operate. Because sometimes our setup is not ready to handle those kind of sick kids. So I would like to refer them to higher surgical centers rather than taking up the surgeries myself. And when pediatric cardiac surgery is tough. It's a tough branch. It drains you surgically, it drains you mentally, it drains you emotionally. But when these kids come back in the OPD and I see them having a normal life, it's worth the pain. Thank you so much.
Thank you so much, sir. That's the message that is taken. And I should congratulate you for taking up such a tremendous task over at Odisha at least. Probably the future is much brighter.
Yeah.
Slowly we shall take up. So I think we are late by this session for another half an
Thank
hour
you so
already.
much.
I
Thank
think
you
we
so
should
much.
do. Thank you so much.
You should project yourself and data in different forums.
Yeah, I'm already doing that.
Okay, so that people in Orissa, they stay in Orissa for this kind of treatment rather than going away and spending money and family disturbance. Okay?
Yes. Thank you so much. Sir. Thank you so much.
Thank you. Thank you.
Thank you.
Thank you for that insightful presentation, sir. I would like to take this opportunity to thank our distinguished chairpersons for the thought-provoking discussions. For our plenary sessions today, we have an incredible lineup of speakers and discussions. For our Sushruta oration, I would like to invite Dr. Sanjay Kumar Giri, sir, Head Department of Plastic Surgery, AIIMS Bhubaneshwar, and Dr. Bonabihari Mishra, sir, Professor in HOD, Surgery, SCB Medical College, Cuttack, to chair the session. I would like to request Dr. Satyaswarup Tripathi, sir, Professor, Department of Plastic Surgery, PGIMER, Chandigarh, to present the oration on the topic Demystifying Plastic Surgery. Requesting the esteemed chairpersons to kindly felicitate the speaker and read out the citation.
Dr. Satyaswarup Tripathi completed BBS from BSS Medical College, Burla, and Masters in General Surgery in 2005 from SCB Medical College, Cuttack. Thereafter, he attained his super specialization in plastic surgery in 2009 from the prestigious JNMCH, Aligarh Muslim University, UP. After serving as a consultant at Max Institute of Aesthetic and Reconstructive Surgery, Dr. Tripathi joined as an assistant professor in the Department of Plastic Surgery at PGIMER, Chandigarh. Through his hard work, sincerity, and unwavering dedication to his profession, Dr. Tripathi steadily advanced to the roles of associate professor and subsequently additional professor, and is currently professor of plastic surgery at PGIMER, Chandigarh. A distinguished expert in the realms of plastic surgery, Dr. Tripathi performs close to 400 surgeries per year, ranging from post-traumatic limb reconstruction, tendon transfers, contracture release, surgery in burns, post-oncosurgical reconstruction, pedicle and free tissue transfer. Apart from these, he possesses expertise in brachial plexus injuries. He has successfully executed a variety of intricate surgical procedures, including soft tissue tumor of upper limbs and brachial plexus tumor. Beyond his clinical expertise, Dr. Tripathi demonstrates a strong passion for academics, actively engaging in research and training. With several publications, his name in various journals of national and international repute, he has contributed significantly to the growth of surgical literature. He has attended numerous conferences as a guest lecturer and has authored chapters in several textbooks, imparting his knowledge and skills to the next generation of surgeons. In addition to this, he has been a part of the panel for faculty recruitment in several institutions. Despite his busy schedule, he remains actively engaged in various social initiatives. He firmly believes in the transformative power of spirituality in the healing process and has taken initiative to organize satsang and meditation sessions, fostering a holistic approach to wellness and personal growth. He has successfully organized and participated in many of the health camps, providing free medical services to poor and needy patients from remote areas. Mr. Chairman, I now present Dr. Satyaswarup Tripathi for delivering the Sushruta oration of ASI Odisha State Chapter for the year 2024.
It's really a pride for of all of us that Dr. Satya, who is going to deliver the Susruta stories, and happens to be our student. From the days he was here, we had seen his sincerity, and also you had, and as Dr. Giri has mentioned, he was in a spiritual world also, and now he is a very successful plastic surgeon in the country. All our blessings to you, Satya. Now you can start the oration.
Thank you, sir. Thank you for the kind words. I'm with deep sense of gratitude to all my teachers, starting from my parents who had taught me the values, to all my teachers and gurus who are present here, who had taught me those baby steps which had made my journey smooth from my village Paljam to reach at PGI, to my spiritual guide and Guru Sri Sri Thakur Uncle Chandraji. The journey has been quite smooth and he is always with me 24/7. As the oration is named after Susruta, let me tell a few words about the great surgeon who has been called as the father of surgery. This is the statue which he found at the entrance of the Royal College of Australia at Melbourne. And the citation reads, he is the founding father of surgery and first ever recorded surgeon in the history of humanity who has established the code of medical ethics. And his vast expertise is documented in the treatise of Susruta Samhita, which is a monumental thesis with comprehensive information about medical practices during his entire lifetime. He coined the profession of doctors as a noble profession, possessing outstanding qualities like eminence, dignity, commanding excellence of mind, character, high ideals or morals. And he told the term doctor commands respect, and moreover the term surgeon, it commands greatness, it demands greatness from all. His approach to surgical practices include emphasis on cleanliness, sanitation and sterilization, importance of learning the basics of medicine, that is to learn anatomy before doing any surgical procedure that will lead you to the practical application in the surgery with cadaveric dissection. See before you operate. And the basics of anesthesia and analgesia, these are the fundamental principles of modern surgical practice which has been coined long ago by him. And as per his words, a bungling surgeon is a public danger. And theory without practice is like a one-winged bird that is incapable of taking a flight. So, coming to the oration, there is a little bit of confusion. When I was initially contacted, I was told to tell about the ethical practice in surgery. When I got the written communication, it was told to tell about topics of your own choice. But later on, I came to know that Susutta oration is meant for ethics. So, there are 3 case scenarios before us. First case, as we see, is a case of post-burn contracture. The patient has survived the initial attack of the burn. He has survived, he is living a life, but he is mentally depressed. What to do next? Next case is a 2-year-old child. We can say the standard of care is you can go for amputation. 2-year-old child came in the middle of the night in odd hours. But can we give it back? Third patient, you can guess, the audience can guess. They are not 2 different patients. They are the same patient, showing other side of the face. One of the face is normal, other side half of the face is totally disfigured, looks grotesque. Patient is remaining depressed all the time. She had a blemish of childhood hemangioma scar over the entire other of the face. So, what next? So, our surgical approach will be guided by surgical ethics. Surgical ethics, the ethics word comes from ethos, that means character, which is a branch of philosophy that defines what is good for the individual and the society. The nature of obligations or duties that people owe themselves and to one another. It includes morality, principles, honesty, right, fairness, responsibility, conscience, choice, honor, value and integrity. We are fortunate to have our guide, Lord Krishna, who took the side of few, that is Pandavas, who are with the righteousness, not took the side of the hundreds of Kauravas. And he had taught us the values of righteousness, what is right and what is wrong. Hippocratic oath, as you know, we were earlier, while inducted into medicine, we are given the Hippocratic oath, coined by the Greek healers in 4th century BC, which prescribed regimens for the good of the patients according to the ability and judgment of the physician and not to do harm to anyone. Now the National Medical Commission has come out with Mahasi Charak Sapath. Mahasi Charak, the father of modern medicine, who has coined the same principles and in a way which everybody can understand, to give respect to all while treating the patient. Patient is allowing you to be treated by you. Ethical practice, first published medical ethics for 1849 by Percival Thomas, and in the Helsinki meet, there is a declaration of Geneva. While you conduct any research, we follow the International Code of Medical Ethics, and with these principles will guide us to avoid medical jousting. A patient comes to you and has already been treated by someone else. Don't tell like that, आपने ये क्यों कर दिया, ये इतने इन्वेस्टिगेशन क्या कर दिला, से तुमको खराब ट्रीटमेंट कर दी, you should not tell all these things to the patients. It will be guided by the principle of ethics, which based on 4 pillars, that is pillar of autonomy, beneficence, non-maleficence and justice. One by one. Autonomy is the ability of the patient to give the choice to him to make own choices about the different modalities of treatment, allow him to give freedom of thought, to take decisions, to decide about his procedure after learning everything from you in his own words. You tell everything to him and give the freedom of taking second opinion from others also. Beneficence, you should act in the best interest of the patient, and the procedures to be done with the intent of doing good. A patient of 85-year-old female came to you with CA breast and lots of metastasis. Should not go for a radical procedure. Rather, you do conservative so that the patient has a better quality of life for the rest of the time she is living. Non-maleficence, the very first principle guides each and every one of us is do not harm to the patient while doing any surgical procedure. And if you have done any procedure, you should be able to take all the complications faced by the patient rather sending here and there. And most of the surgeons, as surgeons, we have been taught when to operate, but we should learn when not to operate. That is very important in the practice. Then the principles of justice, the fourth pillar, that is equal care to each and everybody, irrespective of caste, creed, and his socioeconomic status. Give equal care to those who have and those who do not have. And you should develop confidentiality. Patient, whatever confides with you, do not tell each and everybody. And you should have informed consent. Informed consent in the form of doing particular procedure, in consent for photography, consent for publication, everything you should take. You should, and consent should not be like that patient going for surgery and you are taking just before the procedure on table consent. This should be avoided. So, what are those applications in my particular field which I am following and in any surgical practice? Patient came with this sort of presentation with hypertrophic scar with the anterior part of the neck extending up to the chest and partly involved with the beard region. He has survived the initial burn, has a new life, but he is not happy. He is depressed. Man of Punjab, every Punjab youth, as they plan to go to Canada, there is no treatment available here, no job here. I want to go to Canada. That is the presentation the patient has. Standard of care is release of contracture foot grafting. Patient is not at all happy. With allopathic patch over the beard region, what next? Next, how far we can extend what we can offer. Whatever best possible in the world, we should go and offer him. So, the part of the skin which is normal on either side of the neck, we thought of putting tissue expanders, expanded the skin, brought back those healthy skin to the anterior part of the neck. That is not the end game. This is from where we started. On the extreme left, the neck skin has almost come to normal after a few G-plasty here and there. But for the scar in the beard region, alopecia patch, we thought of doing follicular extraction in the form of hair grafting. This is the post-operative picture you can see. Patient is happy, confident, stayed back in India, helping his elderly parents, and now got married, leading a happy life. Another patient, child, survived the attack of burn. And you see, he's left with a cripple, post-burn contracture of the knees, and he's walking like this. It's difficult. It's difficult for the child to lead this sort of life. So, release of the contraction and grafting is not the end treatment. You should allow him to walk on his own feet. So, we thought of putting skin traction and we apply traction. The muscular tendency units which got shortened, they get lengthened. Then we put grafting and with gradual traction and grafting, release of the contraction, he is able to walk and he is a normal life, going back to school and back to the society with normalcy, like any other normal child. Here is a lady presented with hanging paniculus, 65-year-old female, totally depressed on antidepressant medications. Whenever she goes anywhere with this hanging paniculus, she is totally unhappy and not interacting with anybody in the society. So we thought of doing that lipoabdominoplasty, remove the extra hanging paniculus, did liposuction, and this is the amount of tissue which is removed, and with this tomitoc procedure you can see the post-operative result. Patient is happy and off antidepressants, leading a normal life. Fat is always not bad. You should not always remove the fat. Here is a patient, 13-year-old female, came to us with features of depression because half of the face is not developed. That is the hemifacial microsomia. We thought of doing structural fat grafting and we did that structural fat grafting. Fat is autologous tissue, autologous implant we can say, In hemifacial macrosomia, not only the skin and subcutaneous tissue, all the layers of the half of the face, that is including from the skin, subcutaneous tissue, mimetic muscles and the bone, everything is deficient. And fat being pluripotent material, we harvested fat, did multiple stages of fat rafting, and now another patient which I had shown in my introductory slide, that is a 17-year-old female. Half of the face completely normal, other half of the face healed hemangioma scar, and this half of the face looks quite grotesque. Disfigured, she is totally unhappy, remains depressed. You can see this is a curious case of two faces. What we can offer? Removing the scar, putting a skin graft is not the solution. We thought of putting a anterolateral free tissue transfer, but putting a bleb of tissue is not the end game. Multiple stages of surgeries to give the eyebrow, to reconstruct half of the nose, to give the oral commissures, and with lot of flap thinning, you can see the smile back on her face, and she got married and now leading a normal life. Another case of massive gigantomastia. This is the lady who presented to us. She has visited many surgeons. Everybody had advised breast amputation and free nipple graft, but she wanted her breast back, and with all sensation and lactation intact, and she wants to get married. So what is the solution? I studied the literature. Thorough study of literature revealed we can plan a supremedial pedicle with at least the pedicle has brought its own blood supply while it has come up to the groin. It has brought its own blood supply. So we thought of doing a pedicle supremedial pedicle breast reduction, that we removed almost 9 kg of breast tissue, 5.5 kg and 3.5 kg from the other side, and we tried to give symmetry. We have achieved breast symmetry, and she got married and now leading a normal life. From here to here, it's a long journey. And another patient with adult brachial plexus palsy, post-traumatic, in Punjab, everybody wants to tie their own turban on their own hands. With paralyzed limb, they can't do that. We try to do nerve transfer. In the post-operative follow-up, you can see the patient has almost brought back to the normal life, and now the patient is tying his own turban. This is the aim and goal of each of the Punjab people. They want to tie their turban. This is the matter of pride, and they have a sense of pride if they can tie their own turban in their own hands. This is what we can offer by doing timely nerve transfer procedure, and this is a complex set of movements which the patient has to perform, and he is doing it perfectly, and we have already seen with a turban head, and she is doing it perfectly to the picture perfection. So another patient, this patient presented to us with a complex defect over the thigh. Such a defect we can see with a complex tissue loss, muscles they are lost, somebody has grafted it, the bone is jetting out, and in a battle-scarred field, he came out with a stretcher and attended the OPD. Doctor Sahab, I want to walk on my own foot. And with a complex defect like this, where people have offered amputation, above knee amputation, we thought of doing something in a battle-scarred field. We did a CT angiography, find out the vessel. If you do a free tissue transfer, where are the vessels where you can plug in the free tissue? So from the other thigh, you took a big, huge anterolateral thigh flap, and we anastomosed to the site, and we can see the bigger defect is covered. And after this, when the tissue is there, orthopedic people, they did destruction, osteogenesis, and with some bone grafting. Now you can see the patient is able to walk on his own. Little bit of shoelace, he is walking, and he is leading a normal life and brought back to society with a smile in his face. So this is the child, the photograph which I had shown initially presented 2-year-old child. The challenge is the age, 2-year-old child, and presented with traumatic wrist amputation, playing with a Toka machine, which is the agricultural state of Punjab. They presented with this in the middle of the night, and the standard of care is you can go for division amputation. This is easy to do, but to carry out this replantation procedure is a tough and challenging task. We did that, and with this you can see the patient has the normal hands and utilizing the hand. No sort of physiotherapy required. Once you give back the hand, child plays and does all sorts of activities. Whatever things available at home, he does these things, opens that, close that, do all sorts of complex activities, and the normal natural physiotherapy is done, and child is brought back to normalcy with all sorts of activity. Parents and society, they are all happy. This is another case of child. This is slightly older. You see, traumatic amputation, an 8-year-old female child, and we undertook this replantation. Replantation is done, successful, gone back home. This is not the end game. End game is the child developed post-traumatic stress disorder, PTSD, and we undertook almost 20 sessions of child psychiatry consultations, sessions, so that the child is able to utilize the hand, doing all sorts of activities, holding a glass of water, holding half bucket of water, holding the school bag, and goes back to school with a smile on her face, helping her mother in the day-to-day activities. So this is what we can stretch ourselves once you do, and all sorts of things, giving a holistic care so that the child is got back to normalcy. So to conclude, surgery, God has given us a knife, and it is a planned assault on the patient. Using a knife will benefit to the patient, which has been proven scientifically across the years after the informed consent from the patient. But ethics guide us at the crossroads, what to do, what not to do, and how far we can extend. And the extension from standard of care with that extra effort to bring the patient back to normalcy and to integrate the patient back to the social life is our end goal. I thank you for giving patient attention. I thank to all my gurus, because of them I am here to speak before you. Thank you all.
Thank you, Satya, very much. It's really a wonderful talk on ethics. Even though you have depicted the different surgical scenario, but it is done with ethics as the major component. Thank you very much.
I would like to take this opportunity to thank our distinguished chairpersons for this thought-provoking discussion. For our next MS Gharanga oration, now I would like to call upon stage Dr. Shijoy Patnaik Sir, Director, Robotic, Bariatric and Metabolic Surgery, and Dr. Jayan Biswal Sir, Head of Department of Surgery, SCB Medical College, Cuttack. For this session, I would love to invite Dr. Pratap Kumar Pani Sir, Senior Consultant, Brain Hospital, Bangalore, to speak on the topic Brain Stroke, its Medical and Surgical Management. I would request the esteemed chairpersons to kindly felicitate the speaker and read the citation. Dr. Pratap Kumar Pani Sir, Senior Consultant, Brain Hospital, Bangalore, to speak on the topic Brain Stroke and its Medical and Surgical Management for our MS Gharanga oration. I request the esteemed chairpersons to kindly felicitate the speaker and read the citation.
So I have the privilege now to read the citation of Professor M.S. Gharanga oration for the year 2024. Dr. Pratap Kumar Pani completed his MBBS in 1982 and Masters in General Surgery in 1985 from SCB Medical College and Hospital, Cuttack. Thereafter, he received his super specialization degree in neurosurgery from SCB Medical College and served as a consultant neurosurgeon in Odisha for 5 years. He started his career in teaching as a lecturer in neurosurgery at St. John's Medical College and Hospital, Bangalore, and steadily advanced to the post of Associate Professor of Neurosurgery in the same institute in 2001. During his tenure of 9 years in the institute, he has performed several complex spine surgeries for the first time in India, few of which include anterior odontoid screw fixation, percutaneous vertebroplasty, and kyphoplasty. He has served as the head of the Department of Neurosurgery in several renowned institutions of the country, including the Rabindranath Tagore International Institute, Kolkata, BGS Global Hospital, Bangalore, SS Pulse Hospital, Bangalore, People Tree Hospital, Bangalore. Currently, he is a senior consultant at Brain Super Specialty Hospital, Bangalore, and is also visiting surgeon at Manipal Hospital, Bhubaneswar. Dr. Pani demonstrates a strong commitment to academic and research, continually seeking to enhance his knowledge and acquire new skills to stay at the forefront in the growing realms of neurosurgery. His passion for learning drives him to explore innovative approaches that can benefit the patient at large. He is trained in gamma knife, stereotaxy, and functional neurosurgery under renowned Professor Chihiro Ohai of Japan, the ex-president of the World Congress for Functional Neurosurgery. Having 32 years of experience in the field of neurosurgery, he has performed about 800 surgeries, out of which more than 200 procedures include advanced spine, navigation-guided macroscopic brain, and vascular surgeries. He has performed over 100 functional procedures, which include thalmotomy and pallidotomy. With several peer-reviewed national and international publications under his name, Dr. Spani's commitment to mentoring the next generation of neurosurgeons is commendable. He has guided countless students in the field of neurosurgery and has delivered lectures as a guest faculty in numerous national and international conferences. One of Dr. Spani's most notable achievements is his successful operation on one of the world's largest brain tumor in a 7-year-old child, a reflection of his exceptional skills and profound expertise. Mr. Chairman, I present Dr. Pratap Kumar Pani for delivering the MS Khananga oration of ASI, Odisha State Chapter for the year 2024.
Pointer is there. Pointer.
So now it's time for the oration. And before that, I would like to introduce Professor Pratap Pani sir. I remember him since my student days. He was senior to me. When I actually got admitted in MKCG Medical College in 1980, wanted to transfer to SCB in 1982, and he was the college union president at that time, what I remember. That's how I got introduced to him. It was a very difficult transfer, so I managed with his help. And secondly, his wife is my classmate, and nothing more to say. Over to Professor Pani to start your oration, sir.
Thank you, Dr. Patnaik. Respected chairperson, my respected teachers, my dear friends and colleagues. Before start my talk, I would like to say that I'm really honored to speak this August gathering. I was 85 Joint Secretary of this association, and that is to Professor Khadanga oration. Professor Khadanga was my undergraduate and postgraduate teacher. He was my guide also. Not only that, when already Dr. Patnaik has told, when he was principal, now we call dean of the SC Medical College, Cuttack, I was student president. So this is my relation with Professor Khadanga. Only one thing I'll tell you, in our time, which I have heard from my senior colleague, in our time, gingivectomy in general surgery was very common surgery in medical, at least in medical college. In periphery, maybe hydrocele hernia. Do you know who has done first? Who has popularized this vagotomy, gingivectomy? It is Dr. Khadanga. Dr. Khadanga went to Kharial Road. That time, Dr. Ellen Lown was only doing vagotomy in this state. He, with Dr. Sahadev Sahu, went to Kharial Road and learned the vagotomy. He himself did 6 cases there, and Dr. Sahu did 2 cases there, and came to Cuttack and popularized this procedure. Many of you may not be knowing this thing. Anyway, in fact, when the association Dr. Sutar called me, sir, Dr. Das and Sutar called me, give a choice of subject. Though spine is very close to my heart, and I have trained in fact, the first spinal instrumentation in this state we have done, and that is in Ideal Nursing Home, Dr. Patnaik place, because there is no C-arm anywhere. He has a C-arm, and that is to my own sister. And in same 2000 November, I did 2nd class in Kalinga Hospital. And I have been trained in functional neurosurgery, one of the best functional neurosurgeons of the world. In spite of that, I thought, let me speak on stroke. Before going to my talk, I'll just put a audio which is shared by one of my friends, and I'll just put, please carefully listen. Thanks. This is telecast nowadays in FM. Anybody has listened or not? Anyway, one of my friends recently has shared, surgeon friend, and I just showed you. Anyway, let me come to my topic. I have little bit changed my topic, looking to this thing, same content. This is optimizing brain stroke care, management strategy, and accreditation to standard for primary and advanced stroke center. Introduction. Very few low number of brain stroke patients get treatment within golden window period. A few people are aware of the golden window period 4.5 hours after an attack. After this time loss is equivalent to brain loss or damage. Definition: stroke is a Germanic term. It was accepted in 1100s by the English people. The brain stroke or brain attack, it is a poor blood supply of the blood to the brain. Maybe ischemic, hemorrhagic, TIA, transient ischemic attack. Total recovery occurs within few minutes to 24 hours. I will not emphasize all the signs, symptoms written in the book. The main why this message should go to the public. It's not limited to the doctors. First, it is formulated by the World Stroke Association. First, FAST, face, drooping of the face, weakness of the arm leg, difficulty in speaking, and last but is time. Risk factor, high BP, high cholesterol, cardiovascular disease, carotid artery disease, peripheral artery disease, diabetes, obesity, sickle cell disease, and recently exposure to COVID-19. So, lifestyle, smoking, physical inactivity, poor nutrition, alcohol consumption, drug addiction, and stressful life. Let me speak regarding TA. Though TA is a reversible effect, within 24 hours it will be back. But importance is like that. It lasts for 24 hours. Same symptom but mild. Confirmed by done by CT and MRI. In TIA, no CT MR changes. Very important here. 1/3 of the TI leads to stroke in lifetime if not treated properly. And this has happened to my family also. So diagnostic, there are certain neurological examination, all these things. Most important is here CT and MRI, and this is the most important. This management. As usual, aspirin, clopidogrel. Once the TI happens, you start the treatment so that he will prevent further stroke. And if there is arterial fibrillation, you can consult cardiology and surgical procedure like if there is a carotid block, you can go for carotid endarterectomy or angioplasty. And in a Western country, they put especially in the USA, they put the filter till it is solved. The primary cause is solved. But in India, it is not practiced. It is very costly. Then management of ischemic stroke. Thrombolysis is standard. The thrombolysis, it should be done within 4.5 hours. Everything should be. The dose is that 1 milligram per kg body weight. Maximum 100 milligram you can go. 10% in a bolus infusion in 1 minute. Rest 90% in 1 hour. This is some pictures. This is MR perfusion test. Then contraindication of TPA. Unless you know, now the message will go from me that stroke can be treated not only by neurologists, it can be treated by any doctor also. Majority of stroke. So there is a chance of, if there is a bleeding in the brain, recent brain surgery, had brain stroke or head injury within 3 months, you should know when not to put current medication, not compatible with TPA, and complication, brain hemorrhage, and incomplete clot removal. Then surgical treatment is thrombectomy. It should be done within 24 hours. Goal is to restore the blood flow to minimize permanent brain damage and disabilities. Done by stent retrieval. And if there is a carotid blockage, carotid endarterectomy or carotid angioplasty can be done. This is the thrombectomy. We put a catheter and pass the catheter through the thrombus and make a basket and take out the clot. And it should be done within 24 hours. After that, I don't think it will help much. Already brain damage is there. This is the superficial and deep ICH and management of hemorrhagic stroke. It could be ICH or SH. Symptoms are more severe depending upon the site and size and nature of the clot. Etiology, high BP, majority, aneurysm bleed, AVM, bleeding disorder, drugs, sickle cell, and liver disorder. Management of ICS, I can tell you, this is 2 types. One is superficial and one is deep. Superficial, it can take out the clot. In deep ICS, the earlier concept was not to do surgery. medical management, whatever they are. And we tried in St. John's, basing on a Japanese publications, CT and stereotype guided placement of the catheter in the center of the clot and put urokinase 8 to 10,000 units. And every 8 hourly, you have urokinase will resolve the clot and it will aspirate out so that the amount of whatever the clot will come out. But the present concept, in 2009, I had attended the International Neurosurgical Conference in San Diego, USA. It was a very eye-opening talk by the president of the Chinese Association of Neurosurgeons. He presented a guest lecturer with a multi-centric study of 6,000 cases from USA, Canada, UK, Germany, China, and Japan, and concluded that surgical evacuation of hematoma is a gold standard if hematoma is more than 30 ml. Now, presently, people have gone to 20 ml. What happened? If you don't remove the clot, the toxin liberated from the clot, it will cause the edema and further damage, secondary brain damage can happen. Now it is possible because of improved microscope, endoscope, surgical skill of the surgeons, and proper hemostatic agent. Now, what you do very shortly, I cannot go detail. This thing, decompress you cannot do with or without hematoma evacuation. These are the some few photos. And one more thing, this is the brain stem hematoma. Now also nobody operates. This is an intraventricular bleed. In this case, we can put what happened? It will lead to the hydrocephalus because there's a blockage of the CSF flow. We can put a catheter, aspirate out the CSF, and in this case, now also we can put urokinase and aspirate out the clot. This is the SS, subarachnoid hemorrhage. Then we go for CT angio or DSA. This is the angiogram picture. Then what about the aneurysm? I'll tell you. It is a very vast subject. I cannot put only things I will tell you, sir. Aneurysm, earlier, this clipping started. It is the Nandi who started, but it was popularized by father of modern neurosurgeon, Professor Yashar Gill and Paksh, and in Japan by Sujita. In 75, they published it, the procedure of clipping. And in India, it came little late, whatever may be. Now, that is the standard treatment procedure for the aneurysm. But presently, that is another thing is a clipping and coiling. There is a law, in 1990, in USA, started the coiling. Till 2000, it has not practiced in India. I have seen actually in 1999, December 14th, in Madras NSI conference, Professor Mehta from New York presented and told that coiling will replace the clipping. There is a huge debate by the Indian neurosurgeon who could not tolerate. But presently, I can say it is the now not choice of the surgeon, especially in the metro where endovascular procedure is available. It is the choice of the patient, if patient unconscious, choice of the family member, whether they will go for coiling or clipping. Why? Because coiling is a very easy procedure, but there are some advantage and disadvantage. You have to explain to the patient, these are the advantage, these are the disadvantage. Sometimes patient will come. This has happened to me also. One giant aneurysm I saw in ICA. Then I planned for clipping. The son from USA came, in Singapore came, told, no doctor, I want coiling. Then I called my coiling colleague. He could not cannulate the ICA and coiling was failed because most probably the circulation was happening from the contralateral side. Then I did the clipping next day because he was taking a lot of heparin. So next day I planned. Anyway, it is the personal choice, but you have to explain the patient what is the advantage, what is the disadvantage, both procedure, coiling and clipping. Nowadays, I think in metro areas, coiling has taken the advantage of the clipping. These are the some. Then AVM, surgical excision and a radiation. This is the deep-seated AVM and this is the superficial. Now you can excise, if you deep-seated, you can go for radial surgery. Again, there is advantage and disadvantage. This is my talk actually. I want to concentrate on this to the Augusta gathering. World Stroke Organization action plan guidelines of accreditation of brain stroke center introduced by Center for Quality and Accreditation Institute in collaboration with the Indian Stroke Association with guidelines from the World Stroke Association to enhance the stroke patient care and safety. It started in December 2022. QIA provides accreditation program to both government and private center, and that is primary stroke centers and advanced stroke centers. But I'm sorry to say that till now, none of the center in Orissa is affiliated to forget the advanced stroke center, not even the primary stroke center. Sorry. So, requirement of the primary stroke center. I'll just silent point, there is 17 points they have mentioned. Minimum 72 patients per year or 6 patients per month. Minimum 6 patients for thrombolysis, compliance with the statutory requirement, acute stroke team personnel available 25/7, neurologists available 24/7 in person, another very interesting, or in telemedicine. This is very important, I feel. I'll tell you later on why. And designated stroke beds, in-house diagnostic service, 24 by ECG, CT scan, echo, CBC, INR, serum this is minimum requirement. Then carotid Doppler, thrombolytic agent available in-house, not in market. Designated medical director, designated nurse stroke coordinator, written protocol for acute stroke triage and diagnosis, written emergency stroke management protocol, neurosurgical coverage plan, remember, this is coverage plan, telemedicine, tracking, monitoring, and reporting the performance measures. In advanced stroke, all the whatever I told, in addition, serve 120 patients per year or 10 patients per month. Minimum 6 thrombectomy endovascular procedure or 12 thrombolytic to apply for the accreditation. Availability of neurology, they are telemedicine. This is availability for neurology 24/7. Neurointerventionist is available, should be available. Designated neuro bed care 4 beds. CT angio, MR, MRA, MCT, MR perfusion. In that case, only CT scan. Cath lab, either single or biplane. Dedicated neurosurgical cover plan. Assessment team will visit like your NABL or NABH audit, emergency department, imaging location, surgical intervention suites, ICU, designated patient care, rehab centers, and other facilities. Sir, without is most important. Without rehab center, stroke management is incomplete. Please remember, rehab is not part of is not your physiotherapy. Rather, physiotherapy is part of the rehabs. In CMC Vellore, the first institution who started MD in rehab long time back, because my friend was there, he has already retired. So it's a long time back. Next year, AIIMS started. Now, so many centers like St. John's, their regular MD course. And recently, one of my junior colleagues has joined in AIIMS, Rishikesh. I don't know whether in Odisha they have started or not. I don't have any idea, sir. This is the key indicator for clinical structure, process, and outcome. For primary stroke center, see, door, when patient entering the gate, door to physician, less than 10 minutes. Physician should present before 10 minutes. Door to stroke team, before 15 minutes. Door to CT and MRI initiation, before 20 minutes. Door to CT and MRI interpretation within 30 minutes. Door to lab result within 30 minutes. Connecting telemedicine 20 minutes. And door to IV thrombolytic bolus within 40 to 60 minutes. For advanced stroke center, mechanical endovascular therapy within 120 minutes. So, to conclude, accreditation of brain stroke center, ensure quality care, demonstrate adherence to national standard for stroke care and management, enhance the patient outcome through evidence-based medicine, improve operational efficiency, streamline process of a rapid diagnosis and treatment, foster collaboration among the multidisciplinary team, build a trust and recognition, encourage continuous improvement. Achieving accreditation is not the end point, but a commitment to sustain excellency in stroke care. Sir, this is my last slide. Before that, what I have observed, I want to share. In Odisha, you can have advanced stroke center at least in 4. You can try. You should be optimistic to start in 5 centers like this AIIMS, SCB Medical College, BHUBANESWAR, MKCG, even if a capital hospital, the new capital hospital, you can start it. If you have a vision, if you have a desire, you can do it. Only lacuna is here, one thing, this endovascular. We don't have a trained people, but it is not a great job, sir. I am happy that Professor Sahu here has started the program last year, but unfortunately he could not get the candidate, 1-year program. Anyway, I don't know what is the present status. You can have advanced stroke center at least in 5. And the primary stroke center, you can have all other medical colleges plus district hospital. Only thing, you have to put a CT scan. What is there to get a CT scan? Government has a lot of funds. It is not like earlier. If you say the CT scan story, I think Dr. Sadhu might be knowing. In 1978, first CT scan was installed in AIIMS, and that was donated by one NGO from South Africa. The second CT scan was installed in it came from Chennai. Professor Ramurthy put it in 80 and in 81 by Professor Rath in SCB. Can you imagine those days? The financial capital Bombay didn't have, CMC Vellore didn't have, Niemann's didn't have, and no other place. But we are able to install the CT scan, 3rd in the country. So if you have a desire, you can do it. One more thing I'll tell you, why I told this thing. Not necessarily neurologist is there, because the incidents, you have seen the video, audio, how incidents are increasing day by day. Problem is that here, in what happened in cardiac heart attack or stroke, patient morigala, torigala. Kintu, but what happened in stroke, brain stroke, that will be a disability. It is now problem for the society, problem burden to the, this is a very bad language, I should not use, it's not, but it's a liability, but you have a responsibility for the society and your family to, as far as possible, to avoid the stroke. Let us join hands and let us do something so that we can, let us pressurize. The association should pressurize, all AIIMS should pressurize the government. We can have primary center, primary stroke center in district level, so that the misery, and all the district headquarters, within 1 or 2 hours, patient can be shifted, even in periphery, with the present infrastructure. But this awareness should go. People should know that stroke is like this, the plastic, they should report as soon as possible. With this, I thanks to you all. Thank you everybody for giving me an opportunity to speak this August. Thank you, sir. Thank you, everybody.
Thank you, sir. Professor Pani. As I am friend of CJ, I also know you when you were so dynamic and our student leader. And I remember those days. You were very popular. I remember most of our classmates remember you still today. And this talk is an excellent talk. A few days back, we lost our very dynamic person in our campus in SCV, Dr. Bhuban Maharana, in stroke. He was suffering from that disease for 3-4 days. He went to a private hospital and then again brought to SCV and operated also. And evacuation of the clot was done, but he could not survive. Stroke is, as you said, is so common, sir. We want you to, because you have served so much outside Odisha, you can utilize your talent and experience for the people of Odisha.
No, sir. Yes, sir. Thank you, sir. Thank you. Sir, that is the reason I put this subject, because spine is close to my heart. But why I told like this? This message should go, and I am trying my best to popularize this message. It should go. And I'll tell you, you told one Dr. Bhuban Maharana, I know he is a very close friend of mine, 1-2 years senior to me.
Sir.
Recently, 1 year back, one very VIP ex-minister came to the hospital. He has come within 2.5 hours. A private hospital. They called me somehow in the next day. That time hasn't gone. This is a stroke, ischemic stroke. This treatment should have been given to him. I don't know he will survive. I'm not telling he will survive. Recently, if anybody has listened in Arnab Goswami debate, Mr. Rajgopal, who is a very senior journalist, when Arnab said, sir, why are you there for the last 3 months? He told, I had suffered brain stroke. Because why I'm telling his name? Because already he has told in public. I had suffered from brain stroke and I went to hospital within 2 hours. I got a 70,000 medicine. I got cure now. So many incidents are there, but it is my scope and time is very limited. I cannot go detail.
Thank you very much for your excellent presentation, and it is really an eye-opener. I think the message is very clear, and we all should create this awareness among our friends, colleagues, as well as the public. Thank you very much.
Thank you, sir. Thank you to everybody.
I would like to take this opportunity to thank our chairpersons and speaker for this enlightening session. Moving forward towards guest lectures, I would like to call upon stage Dr. Amya Charan Janamani, Senior Consultant Surgery and Ex-Secretary ASI Orissa, Dr. Rajkumar Barpanda, Consultant Surgeon, Sparsh Nursing Home, Sambalpur, Dr. Santosh Kumar Behra, and Prashant Kumar Patru to ace the dice as the chairpersons. As the first speaker, I would like to call upon stage Dr. Ramya Behra to speak on the topic Difficult Gallbladder, the Escape Route.
Very good morning. Start. Very good morning, my respected teachers, my seniors, and my junior colleagues. Greetings from Manipal Hospital. I am Dr. Ramya Ranjan Behra. I am going to give a talk about the difficult gallbladder and the escape route. So, gallstone disease is the most common disease of the biliary system. The incidence is around 6%, and female incidence is more than male incidence. We have been taught 4F, like female, fertile, 40, and fat are the most common diseases associated with gallstones. In 5 to 10 to 25% of the asymptomatic gallstones convert into symptomatic gallstones. And laparoscopic cholecystectomy is the gold standard. So this is the photograph of Professor Strasberg, who described the critical view of safety. The critical view of safety, when we are doing a laparoscopic cholecystectomy, we dissect the gallbladder from the lower third of the cystic plate, and after the dissection, we find only two structure are going to the gallbladder, that is the cystic duct and the cystic artery. So now this is the gallbladder. Everybody wants to operate, but how about this? Patients with obesity, mucosal, gangrenous, contracted, and with cirrhosis. These are difficult gallbladders. But we are not the choosers. We have to fight on. We have to go and fight these diseases. So, what is a difficult gallbladder? A difficult gallbladder is a gallbladder that is more challenging to remove than the routine gallbladder and may poses hazardous risk. In nutshell, it is the difficult in getting the critical view of safety. So, what are the causes? Inflammation, difficult exposure, cirrhosis of liver, mirigi, empyema gallbladder, gangrenous or necrotic gallbladder, chronic cholecystitis with fused Carlos triangle, and gallbladder perforation. So these are the predictors of difficult gallbladder. So from history, male gender, age more than 65, the more than 4 days of presentation of acute cholecystitis, previous multiple more than 10 episodes of biliary colic, history of acute cholecystitis, upper abdominal surgery, and prior attempt of cholecystectomy, including cholecystostomy. And in physical examination, patient having fever, that morbid obesity, TLC more than 18,000, and palpable gallbladder. And in imaging, we found the thick walled gallbladder more than 4 to 5 mm, this small contracted gallbladder, gangrenous or GB perforation, gallstone impacted in the neck, the mirigi, and a cholecystoenteric fistula, and cirrhosis and extrahepatic portal vein thrombosis. And intrahepatic, you will find that small shrunken gallbladder, and there is a fatty and firm liver, and the liver is related with fissure, depression occurring near the funda. So these are the conditions where we expect that there is a difficult cholecystectomy. So what is our aim? Our aim is to do the cholecystectomy, but we have to avoid the bile duct injury. So how we will proceed? First, in the access, we should have a fast, safe access. The access can be made by varus, open entry, and optical trocar. Nothing is 100% foolproof, but we generally go with in these cases, we generally go with an open entry. If there is a scar, we should go away from the scar, and there is a Palmer's point, which is the most common site where we can go into the access. Next is the exposure. So we have to expose and see the gallbladder. So we have to divide the adhesions, the perihepatic adhesions and the adhesions to the adhesions of the omentum to the liver, so that we can have a good vision. There is no hard and fast rule how we can put the port. Even if we, after putting the first port, we can put the lateral ports also, so that to get the good exposure. We can divide the falciform to get a good exposure. We can put an extra port for retraction. Extra port is required when there is a heavy left lobe of liver, and in case of obesity, we have to push the bowel down to get the good some exposure. And in case of distended gallbladder stone impacted at the neck, we have to aspirate the gallbladder so that we can hold it and proceed. During the dissection is the most important part. We have to divide the omentum. The division of the omentum can be done by harmonic or by cautery. We have to use minimal use of cautery at the carlots area. So during the carlots, you should be very slow. There should be the liberal and anterior and posterior dissection, so that you can hold the gallbladder, you can flip the gallbladder easily from anterior to posterior side. Try to keep these sides bloodless by using a gauze. Generally, we use a radiopaque gauze and a saline wash. If there is a bleeding, don't get panic. Give pressure. Unless until otherwise you are hitting the portal vein, rest of the bleeding, I think, can be managed laparoscopically. Most important point is the rubeus sulcus. The rubeus sulcus, I think it is a lighthouse in case of a cholecystectomy, because it gives that you should not go below that line, imaginary line. And in laparoscopy, slow is fast. There should not be any forceful. So in this picture, these are the green area. So this area we have to dissect, and these are the red area. So we should avoid to going down this area. So this is the imaginary line, so where the rubeus sulcus is going, so that we can stay above that line. If there is a frozen callots, so we can use an intra-op cholangiogram, ICG and intra-op ultrasound. Among these, ICG is readily available here. We should do ICG in normal cases also, to get into how it looks the common bile duct, how that looks the cystic duct. And we can use the IOC and intra-op ultrasound. We can go for a top-down or a fundus fast method. For the fundus fast method, we are very much convenient in doing an open surgery. We are doing it for hundreds of years. But in laparoscopy, fundus fast is difficult, and in this difficult method, it will be difficult because there will the liver. We don't have anything to push the liver for a exposure. So next bailout is a partial or a subtotal cholecystectomy. So better to do a 95% cholecystectomy rather than doing a 105% cholecystectomy. We leave some part of the gallbladder fundus, and it can be done by two methods. It can be a reconstitution, where you can direct suture it, or fenestrating. Fenestrating, we can suture only the cystic duct opening in the gallbladder. And we can fire a staplers also. If we can make a tunnel behind the gallbladder, we can fire a stapler also. So next is cholecystectomy, cholecystostomy, convert to open and back out. So next is a teamwork, make a good team, ask for a help. Asking for a help, whenever our first thing is a primum non serie. Don't give any injury to a patient. So ask for any surgeon, senior or junior colleague, for a help. So this is the bailouts method: open conversion, subtotal fundus fast, fenestrating and reconstituting. So this is a small video I want to show. So this patient is a 76-year-old man who was having a cholecystitis, and a pictal catheter was put, and he has come to us for a cholecystectomy. The pictal catheter was done around 3 months ago. After 3 months, he has come to us for a cholecystectomy. So after getting initial access, we divide that part. Now while we going to the liver, we did not find the gallbladder. The gallbladder is covered with the omentum. So gradually, we have to cut it. We have to cut it and dissect it to just for a look of the gallbladder. So now some part of gallbladder is visible, but we carry out our dissection slowly with blunt and sharp dissections. Now we can find there is a little bit of gallbladder. We want to hold it with a hook, with a tooth grasper, and try to separate the adhesions, the omentum, the stomach, and the duodenum from it. So here, this is the total of the gallbladder we found it. We did a posterior dissection, and this is the anterior dissection we are doing. We are doing with a blunt, and we are doing giving a liberal posterior so that we can find a tunnel in between it. So here we are dissecting in the posterior dissection so that we can find a tunnel. So there is a adhesion in between. We divide it so that we can get a good more exposure. This is the artery we are getting. Now, this is the artery. We got the cystic artery. We clip the cystic artery. We make a tunnel. Then we put a ligature at the neck. We put an extracorporeal suture and put it at the neck. And we divide the gallbladder. After that thing, we divide from the gallbladder by a scissor so that we should know what we are cutting. So this is the now the surgery is done. So this is the amount of gallbladder. This is the shrunken, contracted gallbladder. So we go to Sage's cholecystectomy guideline. We have to find a critical view of safety. We should always be aware there is a potential aberrant anatomy in all the cases. Intraoperative cholangiography and ICG, other methods be always be taken whenever there is a difficulty to image the biliary tree. You should take you should have a timeout before intraoperative momentary pause prior to clipping, cutting, and transecting any tubular structure. The dissection is approaching a significant risk. Then, if you are going through a significant risk zone, then stop there. Get help from another surgeon. So, concluding, gallstones are a bread and butter of the surgeons, but this is an ungrateful surgery. No one will praise you if you do a very good cholecystectomy, but you will be talk of the town if there is something happens. One thing again, the critical view of safety. You should start dissection up and hug the gallbladder. Suturing skill is mandatory and never hesitate to get a help. So thank you. This is Dr. Udbadia. He was my mentor. In surgery, there is no retake, no rewind. So ease should be your best one. Thank you.
Thank you, Dr. Ramya. Very nicely you have described the methods and different procedures of difficult gallbladder. Yesterday we had also very good session of safe cholecystectomy by Professor Banbihari Misra. So in the demonstration, video demonstration, you should have tried ICG, I think. You are in a bigger center.
That day we don't have the ICG.
Okay. The subject is open for discussion. Any question from floor?
So, Dr. Ramya, actually nowadays we are seeing more complicated cases is because of this BHUBANESWAR era. Everybody is giving death 6 months, 1 year, like that, and within this period patient is having multiple episodes. So we are definitely going to see and operate the complicated cases. So is there any pre-op assessment before doing like MRCP you are advising?
I described that where the clinical diagnosis from the clinical or the ultrasound grind, we found that this is a difficult gallbladder. We are going to be difficult to drop. Suppose there is a MRCP we generally do when there is a dilated common bile duct, or we are suspecting a choledochordional fistula or a Mirigi type of things. Then we do a MRCP. Generally, we don't do a routine MRCP.
Large stones, old male, large stones. Suppose more than 15 mm or 20 mm like that. Then more than 1 centimeter stones, old age.
If the ultrasound said this is a contracted gallbladder, then we can go ahead with and do an MRCP.
Okay, thank you, thank you.
Thank you so much, sir. Next, I would like to call Dr. Shakti Prasad Sahu, sir, to present on the topic Role of ICG in laparoscopic cholecystectomy. Is it worth the hype?
Respected chairpersons, my seniors and friends, I am just here to fill the blanks. Why ICG? We talked about yesterday and today because of the bile duct injury. So this helps in identifying bile duct and the common duct junction. Thus, it prevents or reduces the incidence of bile duct injury. I am not going to detail the procedure about it. Normally, I personally give 5 milligram of ICG 1 hour before to surgery. There are 4 modes. In the ENB mode, you have green. The dye is stained green. And in overlay mode, exactly with the normal mode, the green mode is overlapped. And the contrast mode, the dye looks white. And in CSF mode, that is color segmented mode, the red indicates 100% dye and the blue indicates 0% dye. Instead, I'll go for a video. Ramya did a nice surgery without ICG. And I think if I am operating that case, probably I am looking a black speck and operating. And you see without that. It's a dense adhesion, laparoscopic cholecystectomy attempted twice. Entire upper abdomen is fixed. Now the dissection of adhesions from the gallbladder should be reversed, not from above downwards, because in that you might come across injuring the colon. You push the duodenum, this is the duodenum, you push the duodenum down, then dissect it up. Push it down, again dissect up, till you find the calyx. So duodenum goes down, nothing will come up. Now this calyx area is seen. You can see the bile duct. Then you start dividing it. Then you are almost sure that you are not going to have injury to the duodenum or even the colon. This is the best way of dissecting adhesion from the fundus, not directly tearing down from the fundus, because in that you may not be able to know whether there is colonic adhesions or duodenal adhesions or cholecystodiodinal fistula or anything. This is how is preferred method of dissecting that. So every time you see where is the lever and where is the adhesion, you go precisely exactly from the lever and the adhesions are turned down without damaging any of the two. So that's a contracted gallbladder. You can see this bile duct. This is the bile duct. No energy, just separating above it. So the main advantage is once you see the posterior, I always see the right portal pedicle. You see the right hepatic duct and the lower down is the portal vein and up this is the portal vein. The white one is the right hepatic duct and above is the artery. So you see completely. This is the cystic artery you can see and you can dissect on ICG. Nothing blind. You see that this black one because the dye cannot stay in the vessel. No? So that looks black. You can dissect clearly the cystic artery under ICG fluorescence. Once you get the artery done, then you are almost sure that your duct you will dissect and it will be over. That's the artery. Then you clip it and divide it. Once this is done, then you dissect the cystic duct and the bile duct is separated. There is little bit of adhesion there. You have seen already the left duct, bile duct and the right duct. Then you make a tunnel and clear all the gallbladder adhesions to that porta area, then it becomes free. So the main advantage of ICG, you can get the right plane between the gallbladder and the tissue, or the gallbladder and the liver as well. So once you put the clip, you can also decide the length of the cystic duct. See, this is almost gallbladder is arising from the confluence of the right and the left hepatic duct. This is how the rest part is next. This is another case, gallbladder contracted, acute empyema was there. You can see the CVD bile duct there. You can dissect away from the bile duct. So most of the times you can see the bile duct nicely. The same thing you can also dissect. This is a duct I am dissecting away from the bile duct. That's the artery appearing. That's the artery. This is how you make the tunnel above the bile duct. Then you clip the cystic duct. After dissecting, this is cystic artery being dissected. Then you make a tunnel and divide it. So very clearly you can find out the junction between the bile duct and the cystic duct. This is very important. This is another case, failed laparoscopy. The surgeon has seen a portal cavernoma and left it. Then I have attempted it. In this I can see the vessels and above I can see the gallbladder, but the actual calyx is not seen. See, this is one of the places where you may not be able to find the junction of the cystic duct and CVD. But you can still proceed away from that. Now you have seen this is the right portal pedicle above, this is Rubeus sulcus. Above that you have to go, that's the portal vein. Then go on dissecting only to, see, this is green, this is blue, means only vessel is there, nothing else. So then you go for a posterior dissection. This is a modified fundus first. It's not exactly fundus. It's quite in between the gallbladder and the calyx, fundus and the calyx. You dissect completely posteriorly, then little go down. This is what I am dissecting from the liver. I am making a tunnel posterior to the gallbladder. This is a vessel sealer. I am dividing the vessel. I am sure there is no biliary structure in that because I have seen it the ICG. So I'll make a tunnel from doing a posterior dissection, and from the anterior dissection, the tunnel is made. So this is the vessel. There is nothing else. I have seen it in ICG. I can jolly well divide it, and that becomes the cystic duct. For the completion cholecystectomy to achieve, whether it is there or any stone left, or is in little doubt, I divided and both ligating on both the ends. And I was sure it's a complete cholecystectomy has been done. In this case, normally I take a suture and put a clip over it. That becomes more secured for this. You can also do a dissection under color segmented or ICG guidance. You can very well see that there is blue color in avascular plane between the liver and the gallbladder. And in ICG mode, you can see that you are not entering much into the liver and all. This is a cirrhotic liver with contracted gallbladder. See, the yellow one is the bile duct. It's very well you can see. And this you can also do a dissection of the gallbladder, keep not injuring the liver. You get the proper plane between the gallbladder and the liver tissue, so you can go into that. That's the CVD. You go on dissecting away from the CVD. This is very safe, relatively. This is how you make the dissection of the liver bed, create the calyx. This is my experience. The total number 512 cases, and I didn't find last year no bile duct injury or conversion to open. Incorporating ICG system may not seem beneficial in simple cases in terms of surgical outcome, but routine we use will facilitate familiarity with the technology and more rapid progression along the learning curve, making it easier to use in complex cases without cognitive burden. It is definitely helpful in cases of inflammation, fibrosis, biliary and vascular anomaly. It reduces operating time and bile duct injuries in complex cases. Overall reduction in bile duct injury appears marginal. The clinical importance of avoiding single case of bile duct injury should not be understated, given the serious complication and complex surgery thereafter following a bile duct injury. Thank you.
Thank you, Shakti, for a nice demonstration of ICG in difficult gallbladder cases. So, due to paucity of time, we are avoiding question and answers. Please,
Thank you.
excuse me.
Thank you so much, sir. Moving forward, I would like to call Dr. Manas Ranjan Pradhan, sir, to speak on the topic Minimal Invasive Urology Recent Advances.
Good morning, chairpersons, my esteemed teachers, and dear friends. As Ramya told, like gallstones, prostate and renal stones are the bread and butter of urologists. So, as we are moving into minimal invasive procedures in each and every branch, as such in urology, minimal invasive surgeries were there since long time, like TURP. So with advent of good medicines, now the incidence of surgery in BPH has reduced to almost say 20%. Majority of the patients can now be managed with medicines. And BPH, open surgery for BPH, which is so common in our PG days, is now almost obsolete. The specimen, this one, probably I had operated more than 10 years back. For renal stones and prostate, probably the last open surgery that many of us did was more than 10 years back. So till now, TURP remains the gold standard surgery. But TURP, which was minimal invasive previously, now is being considered as more invasive. Now we are going into still minimalistic invasive procedures in BPH. And with the advent of lasers, holmium laser, thulium, KTP, the BPH surgery has revolutionized the treatment. So as I told, TURP is now maximal invasive. And the complications of TURP, urinary incontinence, erectile dysfunction and retrograde ejaculation, they are quite significant. So for sexually active males, especially in the age group of say 45 to 55 or 60, TURP is never the first choice for most of us. And majority of the surgeries, like say terminally ill patients or who are having cardiac ailments or other high risk comorbidities, normally we prefer to do surgery under local anesthesia or IV sedation. So the newer advanced method is holmium laser enucleation of prostate, otherwise known as HOLEP. What happens in TURP, we go through the urethra and cut the chips. So we proceed from center to periphery, because the prostate gets supplied by the penetrating or the arteries from the capsule. So we are cutting the same vessel again and again, so the bleeding is more. Whereas in HOLEP, we go from periphery to center. First you coagulate the penetrating or the smaller arterioles which are entering into the prostatic parenchyma. Then you enucleate, like in open surgery, we enucleate the whole prostate lobe, then push it into the bladder, morcellate it, and then take it out. So the bleeding is less, the clearance is better, and since it uses normal saline, there is no scope of TUR syndrome. I have included only animated things so that it will be easier for you and it will be short. So we enter into the prostate, we cut the prostate into 3 quadrants, median lobe and both lateral lobes. Then we go close to the capsule and enucleate the prostatic lobes, 3 prostatic lobes. Then the prostatic lobes are pushed into the bladder, they are morcellated and taken out. So patients who are on anticoagulants can be operated by HOLEP without stopping the anticoagulation. That is the beauty of laser surgery. So what happens in prostate, the symptoms are because of two factors. There is one static component, that is the mass of the prostate, which is compressing the prostatic urethra and causing the obstruction. And the another is the dynamic component. This is the smooth muscle in the prostate that contracts or the causes contraction of the prostatic urethra. So we take care of this dynamic component by giving various alpha blockers like tamsulosin, alfuzosin, silodosin, so many are there. But when the gland is big, you need to reduce the volume of the prostate so that the prostatic urethra dilates and makes a good passage for the passage of urine. So there is something called urolift. What happens? Here is basically stapling the prostate. You put anchoring sutures on both lobes of the prostate and you compress the prostatic parenchyma so that the prostatic urethra widens and the patient voids normally. So there is compression of the prostatic parenchyma. This is a day care procedure. Maximum takes 15 to 20 minutes. The patient can be operated under local anesthesia with IV sedation. And especially this is suitable for patients who are very high surgical risk and in sexually active patients because there is no retrograde ejaculation, there is no erectile dysfunction and no stress urinary incontinence. So you put anchoring sutures on both prostatic lobes. The number of sutures they vary as per the size of the prostate and the prostatic urethra dilates. This is a animated video. You go into the prostate and we fire anchoring sutures and compress both the lateral lobes so that the prostatic urethra makes a good tunnel or good channel for passage of urine. Normally 2 to 4 anchoring sutures are applied in the prostate. What are the limitations? This can be done for prostates only up to 80 grams. For bigger prostates, 100, 120 or 150 grams, this is not possible. The long-term result is unknown. The maximum duration is up to 5 years. The result is good, but beyond 5 years, the result is yet to arrive to us. There is no scope of tissue biopsy, and this is costly. Each anchoring suture costs around $800 to $1,000, say around 80 to 90,000 rupees. So if you are applying 4 clips, the only clips are around 3.2 lakhs rupees. Availability is an issue, though this can be done in our center or different centers, but the cost remains the main problem. So the next one is REGEM. All these things that I am telling, they are in clinical practice now. There are many experimental procedures, but these are in clinical practice, active clinical practice. So in REGEM, we put steam, heated water vapor into the prostatic parenchyma. And this water vapor, when converted to water, that releases a significant amount of heat, which causes coagulative necrosis of the prostatic parenchyma. So the necrosed part sloughs up after say 4 to 8 weeks or 10 weeks, and the prostatic urethra that dilates. So basically this is also a minimal invasive procedure. We put around 0.5 ml of steam at 101 degrees centigrade into the prostatic lobes, that is applied for 9 seconds in each injection, and total 4 to 6 injections are applied depending on the size of the prostate. You go to the prostatic urethra, then you spot the suitable site where you need to inject. You put a needle. These are the water vapor. They are injected into the prostatic parenchyma. Then this heat that causes coagulative necrosis of the prostate. And depending on the size, you can give multiple injections. The limitations are it takes some time to manifest because it causes necrosis, then that necrosed part sloughs up. The normal takes around 4 to 10 weeks. Longer catheterization is required. 5 to 7 days, sometimes it may extend up to 1 month. Similarly, for bigger glands, it is not suitable. No tissue can be obtained for biopsy, and very long-term results are not available now. Prostatic urethral stents, they have been tried since long, but they have failed miserably. The reason being, urine, whenever comes in contact with any foreign body, leads to encrustation, leads to stone formation. So now they have tried different material like stainless steel, titanium, nitinol. They are now being used, but in very less frequency. only in terminally ill patients. So complications they remain: tissue ingrowth, incrustation, blockage, and second procedure after stent stent placement becomes difficult. So they are used in very limited, highly selective patients, moribund patients having limited life expectancy, which can now the people who cannot undergo more aggressive therapy. Other modalities: aquablation, prostatic artery embolization, and intraprostatic chemical injection, similarly causing necrosis of the prostatic parenchyma. They are underway. Probably they will be coming to the market in few months to years. So renal stone disease, we know PCNL we do classically. We make a hole or we make a channel into the kidney through the renal angle. We locate the stone and break the stone into small pieces and take them out. The problem of PCNL is this is a blind procedure. You do the puncture under fluoroscopy. So there is chance of bleeding, there is chance of damage to the renal parenchyma, and if the major renal artery or divisional artery is injured, that may lead to severe bleeding and nephrectomy in few cases. So now we are trying to go beyond PCNL. We are trying to tackle the renal stones without puncturing the kidney. Now we are trying to go through the urethra, enter into the pelvic calyceal system and break the stone.
Dr. Manas, please take two time.
Just 1 minute, sir. So this is RIRS, basically flexible ureteroscope. You can enter from the urethra into the PCS and break the stone by laser. This is a short video. I'll be just. So we enter into the, because these are flexible scopes, they can be moved in any angle. You locate the stone in the PCS, then break the stone into small pieces, and the stone fragments, either they can be sucked out or majority of them they flush out, get flushed out in the urine normally. So now majority of the stones can be tackled by per urethral manipulation rather than puncturing the kidney. So no hospital, no need of puncture, short hospital stay and less morbidity. Limitation is not useful for very large stones, limited availability and cost. Thank you.
Thank you very much for enlightening on your method of BP and renal stones. So next, so no questions, please.
Thank you so much, sir. I would now like to invite Dr. Bikram Raut, sir, to speak on the topic Reviving the Form and Function Anal Overlapping Sphincteroplasty in Management of Obstetric Sphincter Injuries.
So the topic is a little bit long. So a very good morning to all my dear teachers and my colleagues. So I am Dr. Bikram Raut. I am from AIIMS Bhubaneswar. I will be talking about the anal overlapping sphincteroplasty in the management of obstetric sphincter injuries. Now, as we know, anal sphincter injuries usually the OSCs, whatever we call obstetric anal sphincter injuries, they include the third and the fourth degrees perineal lacerations that complicate vaginal deliveries, and most of them go unnoticed. The reported incidence is around 0.5 to 17%, and from these 17% of patients, 30 to 50% will go on to develop anal incontinence at some point of their life. The two different mechanisms of injury include the tear to the perineal striated muscles as well as neurogenic damage in the form of demyelination of sacral nerves. Now, we know the established risk factors that include the high infant birth weight and prolonged second stage of labor and instrumental vaginal delivery by use of forceps, and other independent risk factors like nulliparity, advanced maternal age, Asian ethnicity, and so on and so forth. But all of these are non-modifiable, as we know. We cannot modify them. And we should know what we are dealing with. We are dealing with the third and fourth degree of perineal tear, which include the 3A, which is less than 50% of the external anal sphincter being tore, and 3B is more than 50%. And 3C also includes the internal sphincter as well as the fourth degree, which includes the anorectal mucosa. This is how they look like in the grade 3 and grade 4. Now, we go to the sequelae. What happens? So up to 80% of the cases they go undiagnosed post at the time of indexed childbirth, and leading to short-term consequences that we have wound hematoma, breakdown, abscesses, rectovaginal fistula, perineal pain, and dyspareunia. But the time at which they are referred to as colorectal surgeon or a general surgeon is the time when they are already facing fecal urgency, incontinence of flatus, liquid and solid feces, and sexual dysfunction and emotional distress. Now, as a part of workup of such patients, we have in our armamentarium the endoanal ultrasound, the anorectal manometry, and the MRI. The endorectal ultrasound being the gold standard of the evaluation of such cases, being operator dependent, and it is portable and it can be repeated again and again. The experimental investigations that are under study, this include transperineal ultrasound, which uses a perineal probe in place of a anal probe, and the impedance spectroscopy, which uses an impedance spectroscope and an anal probe, and along with an AI-based module in order to diagnose the morphology and function of the anal sphincters. Now, these undiscovered sphincter injury risk development of anal incontinence long after delivery. So, there is involuntary passage of flatus to complete evacuation of liquid or solid fecal matter, which affects the quality of life with different degrees of severity. And the most widely accepted scoring systems to score these incontinence are the Wexner score, the St. Mark score, and the pescatory scores. This is one of the scores, that's the Wexner score, which uses incontinence to solid, liquid, gas, and other lifestyle alterations from a score of 0 to 4, the total score being 20 and the minimum score being 0. So now coming to the treatment, the first line is always a medical and behavioral therapy, followed by an additional complementary pelvic floor physical therapy, which includes manual therapy, biofeedback, electrical stimulation, and behavioral education. And the first line surgical therapy is sacral nerve modulation, which is a minimally invasive, effective, and sustainable treatment, but it does not treat the morphological damage that has been already done. The other treatments being perianal injection of bulking agents, the artificial bowel sphincter, and the fecal diversion. Now coming to the sphincteroplasty, the primary sphincteroplasty is the sphincteroplasty that is done at the time of index childbirth or 12 hours after the childbirth. And the secondary sphincteroplasty is done months to year after the index childbirth. Now the goal of the sphincter repair is same, both in primary as well as secondary, which is restoration of the functional anal canal by reconstruction of muscular cylinder that is at least 2 centimeter thick and 3 centimeter long. The procedures can include end-to-end and overlap repair in conditions of partial tear and complete tear. The absence of clear evidence to favor one technique over the other, there is absence of clear evidence to favor one technique over the other, but usually the overlap sphincteroplasty is preferred in secondary sphincteroplasty. Now this is just a chart of how to approach a case of OSS. So when it is diagnosed at the time of index surgery, we go for primary sphincteroplasty as by full thickness or partial thickness repairs for full thickness and partial thickness injuries. And if it is diagnosed delayed, then the patient usually has already had anal incontinence, which we are dealing with now. Now, this is a graphical representation of how to do. The left side shows the overlap technique and the right side shows the end-to-end technique of reconstruction. Now, we present a case of a 38-year-old female with fecal urgency, incontinence to liquid stool and flatus for 8 months postpartum with a singleton vaginal delivery. There was associated post-defecation soiling. The Wexner score was 15. There was partial improvement with supplementary fibers and pelvic floor exercises. And patient has had a previous diversion loop sigmoidostomy. Clinically, the patient had a 4th degree perineal tear. There was loss of perineal body and significant attenuation of anal canal anteriorly with cloaca-like defect. The manometry showed low resting and squeeze pressures with persistent rectoanal inhibitory reflux and no rectoanal incoordination and a functional anal canal length of 1.5 centimeter. The MRI pelvis showed a grade 4 tear of both the sphincters at from 11 o'clock to 1 o'clock positions with a longitudinal length of 2 centimeter. The defecography showed there was an anterior rectocele with mild diffuse atrophy of the levator and ani muscles. Now these are the pictures showing the morphological appearance. The MRI shows the grossly thinned out rectovaginal septum in both the views, in the sagittal as well as the coronal views. Now coming to the surgery, we gave a Corman's flap incision between the anal skin and the vagina. The anal skin and the remnant mucosa were mobilized from the underlying anterior fibrotic scar. A plane was developed circumferentially towards 3 o'clock and 9 o'clock positions to identify the retracted external anal sphincters. The free edges of EAS were mobilized to the level of levator ani cranially. There was limited mobilization of the internal anal sphincter for approximation. The thinned out vaginal wall was meticulously dissected off from the sphincter complex and anal mucosa to create a space for perineography. Now, the Corman's flap technique, as we talked about, incision was talked about is this incision that is given in the perianal skin as well as the skin around the vagina in order to leverage the flaps. So now, we went on to adequately mobilize the EAS for just a tension-free overlap, preserving the anorectal neurovascular bundle that was those who are present laterally. The IAS was repaired end-to-end with 2-0 PDS sutures, and the EAS was repaired with 2-0 PDS sutures in double-breasted overlapping techniques. Additional interrupted buttressing sutures with 3-0 PDS sutures were used also. And the anterior vaginal wall was repaired with 2-0 PDS. So this is the intraoperative picture. The first one is the picture of showing a sphincteroplasty. The second is a picture of showing posterior vaginoplasty. The third one is the completion. Now, as a post-operative course, there was minor superficial wound breakdown, and that was noted at 10 days follow-up and healed without secondary irritation at 4 weeks. Kept under advice for avoiding activities that lead to stretched perineum for 3 months. The patient's diversion sigmoidostomy was reversed at 4 months after ensuring adequate resting and CT stresses at manometry. Currently, the patient is under extended follow-up. Now, this is just a video of the morphology as well as the functional outcome of the surgery at 6 months of follow-up. She is able to contract her sphincter as well as have had a good continence. Now, traditionally, we have seen that sphincter defects underwent end-to-end reapproximation, but they were fraught with high failure rates. Parks and McPartlin introduced overlapping sphincteroplasty and published complete anal incontinence to the rate of 50 to 90%. Berg et al. In 2019 reported that there was improvement in anal incontinence in approximately 2/3 of patients at median follow-up of 44.5 months. And 61.5% had an intact anal sphincter on endoanal ultrasound, and demonstrated statistically significant mean reduction in the St. Mark's score. So studies evaluating long-term outcomes, those pair may pay for further evolution of the technique. And that's my view for today. Thank you for your patience. And these are my references. I'd like to answer.
Thank you, Dr. Raut. You have given a very nice and excellent presentation. No question, please.
Thank you so much, sir. Ending with this session, I would like to now invite Dr. Pratyush Ranjan Bishi, sir, to speak on the topic, our experience in management of colonic barotrauma due to transanal air insufflation.
Slide, please. So, thank you, organizing committee, for giving me the opportunity to stand before this August gathering. So, coming to the topic, next slide. So, colonic barotrauma, our experience in a tertiary care center. So, this is the outline of my presentation. If you look to the colorectal injury, the barotrauma is the less frequent etiological factor.
Before that, solid object injury and blunt injury and parent injury are the prevalent. But if we look at the barotrauma, the colonoscopy incidence is the less than 1%, and due to high pressure ZAR insufflation, these are the very less frequent. So this may be due to practical job or physical ulcer or cleaning of dirty cloth in the industrial area. So this may present as a perforation or at time may present as a tension pneumoperitoneum. So this is a case, a 21-year-old from Nagarangpur presented to us with pain all over the abdomen, distension of the abdomen and difficulty in breathing for 2 days. The patient is conscious, disoriented, there is a distended neck veins, and patient is hypotensive with the tachycardia, and respiratory rate is also high. There is a saturation of 86% in Robier, but patient is dyspneic, but there is no cyanosis. On examination of the abdomen, it is grossly distended, and there is tenderness and rebound tenderness all over the abdomen. Liver dullness is obliterated, and all over the abdomen is tympanic on percussion. The blood sound is sluggish. On digital rectal examination, no perianal injury was noted. Collapsed rectum and fingers stained with blood. Proctoscopy revealed there is mucosal hemorrhage with blood coming out high up from the rectum. The rest of the systemic examination is within normal limit. So, with a diagnosis of acute abdomen with peritonitis due to hollow viscous perforation in septic sac, we proceeded and we done the chest X-ray and abdominal X-ray, which revealed there is a huge gas under both the diaphragm covering all over the abdomen, and there is a ground glass opacity in the pelvis. There is a leukocytosis, neutrophilia, and mild increasing urea and creatinine. So, after seeing this X-ray, what we have done a needle paracentesis just below the umbilicus, and after that, with patient vitals is improved, and we proceed for exploratory laparotomy. On exploration, it is revealed that there is 550-100 ml of blood mixed feculent collection, and there is a perforation of size 1.5 centimeter into 1.5 centimeter in the transverse colon with a longitudinal serosal tear of length around 20 centimeter in the transverse colon and descending colon, and there is a 3 centimeter serosal tear over the sigmoid colon. So this is so what we have done is there is thorough peritoneal toileting, then primary repair of the serosal tear, and there is a transverse loop colostomy. We put a bilateral adequate drain, and the post-operative period was uneventful with the stoma function within 24 hours, and drain removed on post-operative day 5, and the patient is discharged on post-operative day 7. So this is a similar case. There is a huge gas under diaphragm with a perforation, the stool coming out from the side of perforation. Next case, there is another perforation in the colon with a huge gas under diaphragm. And there is another case 4, which is there is huge gas under both the diaphragm, and this is the regular sign. And in this case, but we did not notice any gas under diaphragm, but there is a distended colon and there is a ground glass opacity in the pelvis. So summarizing all the cases, these are from 2022 to 2024, and all of the cases are transcellular air insufflation by others in 5 cases, cell by 2, and between the age of 20 to 30 years, all are male, and the time of incident and surgery is more than 48 hours, and one patient has been presented to us within 6 hours, which we have managed conservatively, and feature of tension pneumoperitoneum was present in 4 cases, and the site of perforation most commonly it was found in our series, it is transverse colon in 5 cases, 1 sigmoid colon, and there is no perforation in 1 case. So in all cases, if there is a late presentation, we have done transverse loop colostomy. Coming to the discussion, the first cases of air circulation to the anal canal and resulting colonic injury was described by Stone in 1904. So barotrauma can be caused even without a direct contact between the source of compressed air and body of the being, even with cloth on. A pressure of 0.48 to 0.86 bar can cause perforation of the colon. Air can from a colon that acts like a solid body and forces of the anal sphincter over the resting anal sphincter, then entry of air into the anal canal, and there is a even the colon may rupture that may lead to tension pneumothorax. And rectosigmoid junction is the most common cause, but in our series it is found to be in the transverse colon. The cause of death in this patient of colonic barotrauma is shock due to peritonitis. tension pneumoperitoneum, and air embolism at time. So accepted treatment protocol at literature is resection and anastomosis or colostomy, but we have done transverse loop colostomy in all cases. So to conclude my topic, high pressure jet insufflation is potentially fatal even if spray from a distance of over the cloison. Most of the patients affected are the young adults who work in industrial workshops. As patient unwillingness to give correct history of the insufflation of air through anus, the diagnosis as well as the management is usually delayed, and needle abdominal paracentesis and decompression is helpful in cases of tension pneumoperitoneum. These are my reference. Thank you.
Thank you, Dr. Pratyush. Very nice presentation.
Thank you, sir.
I would like to thank all the chairpersons for this session. We'll move ahead with our panel discussion, for which I would like to request Dr. Rashmi Ranjan Sahu sir, Professor, Department of General Surgery, IMS in SUMS Hospital, to moderate the session. I would love to call upon stage Dr. Debashish Patnaik, Dr. Ramji Khetri, Dr. Shakti Prasad Sahu, Dr. Srijoy Patnaik, Dr. Shrikant Patro sir, Dr. Tushar Sudarshan Mishra sir, to be his moderators in this panel discussion. To be the panelists in this panel discussion.
Good morning, delegates and my teachers and esteemed faculties. And good morning to my panelists. So I am very much happy to get the this session because this is the most difficult thing what we are managing in our hospital, and the very good panelists who are my teachers and mentors and my seniors are there. So they will guide us in all the steps what we should do. And this is a discussion actually. This is not a question answering session. It's a discussion about the cases and what to do in a difficult situations. So CJ sir is my mentor in AWR. Devashish sir is a very renowned surgeon in AWR. Shakti sir, whoever doesn't know him, he is a very good renowned surgeon in Cuttack and Bhubaneswar. Tushar bhai is a HOD in AIIMS and is a very good AWR surgeon, and Ramji Khetri sir also is a very good AWR surgeon. And Shrikant is a very renowned doctor in Bhubaneswar, and now is a in PGIMR associate professor and very good AWR surgeon. So this is all these things why I am discussing this, because the AWR surgery is coming and the complex hernia is very difficult to manage, and we are afraid of doing this surgery. Many surgeons are referring this type of cases to us for doing these surgeries. So I'll show some cases, case capsules, and I'll discuss about the things how to manage this. So these are the slides of some of the cases what we have done in our hospital, and we will discuss about that cases. Before going to that, first we should know about the definition of complex incisional hernia. So we are all doing incisional hernias. So what is complex incisional hernia? So these are the things by which we can define this. Dr. Shrikant, can you tell what is complex incisional hernia? How to define? Going to go for the size, means what size should be there, so that you can tell it is a complex incisional hernia according to you and according to the guidelines.
Okay. A complex hernia, any hernia that is more than W3, that is more than 10 centimeter of defect, if there is tissue loss, and if there is some, like there are different scenarios that you have already given, more than 10 centimeter defect, I can tell it as a complex hernia.
According to location?
Location, abnormal locations like subcostal or like close to any bony prominence, and those things actually, yes, there's a lumbar hernia. Okay, so
Lumbar,
those are
parastomal, lateral
parastomal, yes.
Devashish sir, any other conditions where we can define it as a complex hernia?
Yes, this is one thing. Second thing is what is the size of the incision.
because the defect will always revolve around that. Number three, is it a redo surgery where previously you have a mesh previously present, that the dissection plane is very difficult. And then along with it, LOD or loss of domain more than 20-25% is there. Any vascular injury, muscle injury is there. Sometimes you may have a loss of muscle injury is there. Then creation of the 3 layers of the muscle. Then
There may be some gap in the muscle,
Well,
and there will
where
loss of
the-
substance will be there. So
well,
that we can
anterior posterior component separation, posterior component separation, both will be very difficult with loss of mesh.
Yes, sir. Yes. Shakti sir, anything about the patient history and clinical scenario? Anything?
In the patient history, if there is a high risk like obesity, morbid obesity, uncontrolled diabetes, smokers, and all, hyperproteinemia, malnutrition, these are the patient main and
Comorbidities we should
comorbidities
take
are
care.
there.
So
And
these are the important things we should think that is a complex hernia, and any other recurrent hernias also.
recurrent hernias and multiple defects, previous repair, mesh repair. These are the scenarios one can.
Yes, yes. So this is the definition actually what we should define whenever we are thinking it is a complex hernia. These are the things, and already the panelist has told about these things. Then we should, this is the paper what already described in 2014, and all the guidelines, EHS and American Hernia Society guidelines, they've accepted this definition criteria. And this is the size of, this is the criteria of definition, and this is the complexity, this minor, moderate and major complexity where we are facing this hernia. So then now we are going for classifications, sir. So sir, anything about the classifications? Because many people are not writing about the, also I have not written in these classifications. So many people are not aware of this classification. Is this important or?
Yeah, classification is definitely important. There were times when we had all sort of bender with classification, NIAS classification, everything we have read during our studentship days. But as of today, the standard is the EHS classification, and let us understand why. It's so easy to plan, to sort of reproduce. Like you can suppose somebody wants to make a research on it, or somebody wants to give an idea about where exactly you want, because epigastric hernia where, so that always there was a gray area. Now it is well defined. So there is the M1 to M5 starting from the sternum to the symphysis pubis. So if you can see here, it's very nicely written. So within 3.5 centimeters of the Ziphy or on the umbilicus. So in between is the M2. So and again similarly to the to the symphysis pubis, again in between is the M4. So it's quite easy. And similarly you can just extend those lines and you get L1, L2, L3 and then L4. So this is the way you should be classifying, and it is not difficult. And if you go to the W, less than 4 centimeter, 4 to 10 and more than 10. That makes it W1, W2,
So
W3.
this is the classification they have written, M and L
So it
classification.
becomes very easy to sort of plan.
Only problem is when we are facing multiple defects, how we should count the defect. That is more important.
Actually, it's not about a problem. It's a question of you have to see the topmost, the superior margin of the topmost and the inferior margin of the bottommost, the lateral margin of the the rightmost and the lateral margin of the leftmost. So that makes it the entire thing. So suppose the multiple defects are there, your top, bottom, and the sides.
Yes.
Then you plan. So that is the size. Then now you plan the mesh size.
Another thing, if this hernia is covering all the midline and lateral part, how we will classify that? Means if they are covering the midline side and also lateral side.
So you can write it
the
like
big
that.
hernia.
So you can actually like suppose a hernia is covering so M1, M2.
Yes.
So you can write M1, M2, W says something.
Right,
So you have to write similarly. Suppose M1, L1. So accordingly you have to write. So we can classify it accordingly.
So if it is a big incidental hernia, we can write it as M1, M2 and L1 or L2, whatever is there. So you have to write all these classifications in a same hernia. So it's a big hernia and having a defect in all the regions. Okay. So this is about the classification of incidental hernia. Anything about classification? Any panelist? Anything about any extra things?
Yeah, I will just. I always have something in mind. Suppose the patient has 2 incisions, like say appendectomy incision, and the patient has a cholecystectomy incision, or suppose splenectomy incision left subcostal.
Yes, yes.
There, the EHS class is not very clear. Can we really say like it is L like left side L1 and right side it is coming to as say L3, and we now see the size. Yes. That is not very clearly mentioned in EHS.
Okay.
So you cannot say that I will join the 2 saying then I'll plan the thing. That we cannot do.
Right. Okay. Thank you. Anything? Any other panelist? Anything?
I just want to add. Actually, when we are the primary surgeon, writing this classification is okay.
But suppose you get a redo surgery, a re-hernia, recurrent hernia.
Yes.
If in the previous OT notes you don't know what hernia was there, it is suppose it has been written epigastric hernia and it has recurred. It is the epigastric hernia which has recurred or a newer hernia, you never know. You always know there will be a suture right in, suppose some IPOM has been done. Lateral suture margin may also have. So if all the primary surgeon, secondary surgeon, if there is a principle that everybody writes the classification in the OT notes or the OPD notes,
Right,
it will
right.
be easier for the subsequent.
This is our purpose for doing this panel discussion actually. All should write this about this. And this is a classification here is recurrent incisional hernia. We should write every times it's a recurrent or it's a primary hernia. This should be there. Okay. Next is investigations. This is very important. Nowadays, people are thinking of what investigation we should do in hernia. So, do all patients with incisional hernia require imaging? CJ sir.
I don't think so. Smaller hernias, say umbilical, primary umbilical hernia. We are talking about incisional hernia definitely, and we are not talking about primary ventral hernias.
Right, right.
That is very clear. And
Smaller means how much smaller, sir? You are
smaller, say 2, 2.5, up to 4 we can.
Less than 1 centimeter.
Less
they
than
are
1,
telling.
we don't require a CT.
Sir.
Ultrasound is enough, but CT is mandatory in all complex hernias when you go much beyond 10 centimeter or even 6 centimeter, because we want to know what is the content of the sac and what we also want to know what is in the sac. Content means either it might be bowel or it might be fat or it might be colon also. Plus, you also understand the anatomy of the structures, and you will see the what you can measure the rectus width also.
Yes.
You also can identify the muscle layers, the sheath, posterior rectus sheath and anterior rectus sheath, whether it is deficient or not, because it has been operated earlier. Plus, also you will also plan your surgery accordingly.
Yes, sir. And the last point is it possible to predict from imaging whether the fascial closure will be possible? Is it possible?
Definitely. Every surgeon should learn how to read a CT scan before jumping in. Before jumping in for. Hello. Before taking up any this complex hernia surgery, one has to know how to read a CT scan.
Okay. So, for any other panelist about the investigations?
So first of all, I like to specify. So why do we investigate a hernia? A hernia is investigated for two reasons. One for diagnosis and one for planning. Planning, Sujit has already told very clearly, so I don't want to elaborate further. Now, when do you diagnose? We always have been taught hernia is a clinical diagnosis. And we have to persist with that. Hernia is a clinical diagnosis. We would not diagnose because nowadays I'm seeing the trend. Okay, there's a hernia, send for a CT scan with no logic. The question is, we have to understand hernia is only investigated for diagnosis if there is a diagnostic dilemma. So if I have to cut it short, you investigate for a hernia if there is a diagnostic dilemma or a management dilemma. Diagnostic dilemma from the point of view when, suppose there's a obese patient, small hernia, history is typical. The patient is having something, he's saying something like bulging out, something is coming out, some pain during say, standing or working, and because they're lying down.
There should be a guideline, means up to how much size we should investigate.
No.
And after that we should investigate.
This is not to do with the
and
size.
It's a complex incision hernia.
No, trust me, this is nothing to do with the size. This is first when the diagnostic dilemma. Is there a hernia or not? You're not sure. A huge obese patient, BMI 40, 45. There's a ventral hernia, you're not sure. There's a Swiss cheese, you're not sure.
Yes.
That is when you have to do a CT scan.
Yes.
That will help us decide, okay, there's a hernia, there are Swiss cheese defects. So that is a diagnostic
Means you
dilemma.
are telling if comorbidities are there, we should investigate.
It may be comorbidity, yes. You can put it as comorbidity.
Sir.
Even if in all complex hernias, actually we need CT is a must in all complex hernias. But whatever sir has told, like even if it is a primary hernia also, if the comorbidity like obesity is there, you should always do, because you may find in a simple umbilical hernia, you may find 2-3 defects of epigastric hernia also.
Okay.
You need to take care of
So
that.
comorbid conditions, sir. Sir.
One more thing, we also come across diastasis recti also.
Yes.
If you land up with a huge patient and with a diastasis, you are mistaken also. For that, you need a proper CT scan to assess whether it's a diastasis recti
Comorbid
or a
conditions and
heart.
diastasis recti. Anything
Sometimes you may have a situation where a patient may come to you for a hernia surgery. A previous surgery scar is there, but there may be an impulse on cuffing. But if you go and investigate, you may not find a defect. what happens in that? There's only muscle weakness, and
Yes.
because of the weakness, so sometimes to exclude that it is, or that you need not operate on such a case. So in such a case also investigation is needed.
So we should
And
do in some conditions, and very smaller
should-
hernia without comorbid condition we should not do imaging. And if other comorbid conditions are there, and with bigger hernias and complex hernia, we should do investigation. MRI is there any role of MRI?
Yeah, MRI is definitely helpful when you have a doubt in CT scan. Definitely, when there is a resurgery, like suppose a previous hernia surgery is done, there is a mesh. So mesh, to delineate a mesh on CT scan is very difficult. You will just find a hazy line there, and MRI will help you to come to a diagnosis.
So MRI is important wherever there is radiation risk, and CT and MRI are comparable in
Incomparable.
incisional hernias. So this is the guideline
Even
what they have.
like occult hernias, you can do a dynamic MRI.
Right.
But you cannot do a dynamic CT in those cases. You
So
can
this
do
is
a
the guideline, EHS guideline. They have shown that the CT and MRI needed for preoperative planning in complex hernias. It was agreed that young patients with small incisional hernia may not require imaging. Only these two lines they have written in the final guidelines.
One thing I just want to add, in the CT, IV contrast is not necessary.
Non-contrast CT you are telling.
Non-contrast.
Unless it is an
Oral
obstructed hernia.
That is oral contrast. IV contrast normally we don't.
Okay.
I'll just beg to little clarify on this. Is that sometimes in an acute setting, like yesterday I had a slide where there was with contrast, you had a small gut which was completely opaque, and there were small black spots on it. And I had the post-op picture also. There, it was there that that segment was strangulated and gangrenated. Here you could, with the CT, you could exclude that I need not do a laparoscopic surgery, go for open, where the results and outcome may be better.
So contrast CT or non-contrast CT? What you are saying?
Contrast.
Contrast CT.
Contrast. You may
Okay,
sometimes.
contrast is better than non-contrast. But if it is obstructed and strangulated, what to do? We cannot give contrast sometimes.
And when you are having
IV
a
contrast
colon,
again.
you get an idea. Content of the gut is when a sac is a colon. There, you see, all of you know that it is a contaminated field, large gut. So when you are doing a CT and or a contrast CT, you know very well, and you prepare the patient accordingly, like giving laxatives previously, and you should be mentally prepared. I may not be able to use a mesh also in such a case.
Any contrast CT and non-contrast CT, anything in there?
So
then-
I'll just, we are talking about. We are talking of two different things. So now, what is the dilemma about contrast and non-contrast? Now come back to the diagnosis. If it is an uncomplicated, I'm talking not about complex. So uncomplicated in the sense it's not a.
Now we are discussing about complex hernia.
No. Let me come. Whatever be the hernia, that's not an issue here. Complex, non-complex doesn't matter. Complicated, uncomplicated. The patient you're having a diagnosis of obstructed hernia or a strangulated hernia, do a contrast CT. If the patient is having just it's a routine patient walking in to you, go for non-contrast CT.
Okay. All the panelists are agreeing with this? Okay. So non-contrast CT is acceptable in all the complex hernias. Okay. So next is what are the important modifiable risk factors? Means before operation we should take care of the patient because complex hernia is very difficult to manage. So what are the important risk factors we should optimize before surgery? Without optimization we should not do surgery. You can defer the surgery, but you should optimize this condition. What are the important risk factors? Khetri sir.
Sugar, which is common nowadays. So HbA1c should be at least 6.5 to 7.
Yes.
Hypertensive, obesity, BMI if it is high. So these and smoking, these factors should be taken care of.
So these are the four conditions like high BMI, poorly controlled diabetes mellitus, smoking and malnutrition. These four conditions and this cutoff value should be like this.
Correction of albumin also important, and chest physiotherapy is very important.
Improved pulmonary fitness. So with the smoking cessation, we should improve the pulmonary fitness by doing spirometry exercise and other things we should do. So this is the level actually they have given in the guidelines. BMI cutoff should be 40 kg per meter square. HbA1c should be less than 7%. Smoking should be 1 month prior to 2 months after operation, and goal should be serum albumin should be more than 3.25 gram deciliter. This is the grading of complex hernia what they have given, ventral hernia working group and Cantor grade. So according to the comorbidity and the infection and contaminated wound, they have graded it to 1, 2, 3, 4 and 1, 2, 3 like that. So this grading should be there whenever we are thinking of counseling the patient about the complexity and the complications. Then the most important thing is CSR chapter is loss of domain. So what is loss of domain, sir? Please.
Loss of domain actually is something where the contents of the sac, which are outside the abdominal cavity, it's becomes difficult to put them back. Just like you can't put a 2 kg rice into a 1 kg bag.
Right, sir.
So that is called loss of domain, and it is calculated in volumetric calculation done through CT scan, through the two indexes, that is Tanaka and one is Sabag. Sabag is actually described in terms of decimals. It is hernia sac volume divided by abdominal cavity volume, and whereas Sabag is hernia sac volume divided by total parietal volume, that is expressed in percentage.
Okay.
So that will tell exactly whether you require some other modalities to manage these
So
cases.
what is that percentage, cut line percentage, anything is
More than 20%.
more than 20% is the
So
loss.
either you go for either a chemical component separation like Botox or a progressive pneumoperitoneum.
Yes. Which is the best method? Sabag method or Tanaka method? Which is the best method?
I think both are still controversial because loss of domain was actually depicted in 2019 by the Delphi consensus in Greece.
Right.
That's why they've come out with this loss of domain theory, hernias, and where they're still lacking on this, both the methods, it's still controversial. I think we follow almost Tanaka method.
So Tanaka method we are following, but they are telling Sabag method is the most best method according to the guideline they are telling.
But in Sabag, you have to have good knowledge about radiology.
Right. Okay. So the all panelists are agreeing with this. All these things, all methods we should do in a complex hernia. This method, CT volumetric analysis, we should do. All panelists are agreeing. Okay. So then already sir told these things we should do in preoperative preparation in loss of domain, that PPP, progressive pneumoperitoneum, Botox injection and some tissue expander they are giving sometime inside the muscle. So this is in my patient what we have given in the after PPP, you can see the gas inside this and the content is already reduced. Half of the content is reduced to the abdominal cavity. I'll tell about this when we will discuss about the case. So this is about the Botox injection where we are giving. Sir, can you tell about the Botox injection? Where to give and how to give?
Actually, it is given in all the three muscles each side. So around 75 ml. You start from the internal transverse abdominis, internal oblique, then external oblique. Both sides, 75, 150.
Botox is coming in powder. How you are doing this? Any special things?
I think it comes in powder. You have to dissolve it.
And dissolve it in the normal saline, and we have to
8
divide
ml,
it in 6
8 ml,
parts.
8 ml, just like that. You have to inject into each side.
We have to divide it in 6 parts, and we have to give in all the oblique muscles. Internal oblique.
But you should start with transverse abdominis.
Yes, from the deeper
Because
side
once
to
you give in the
superficial.
external oblique, you can
Right,
identify because it's done through ultrasound.
From deeper to superficial we should give. Okay. And this is about all the materials about the PPP and Botox, and they are telling PPP, tissue expanders and botulinum toxins are safe and feasible methods for abdominal wall expansion prior to complex incisional hernia repair. In combination with the existing technique for repair, these methods may help provide the crucial extra tissue mobility required for achieve primary closure. So this is about the PPP. Tushar sir, anything about PPP?
Just I'd like to add there, like PPP has its own set of like problems there. So like including the patient could have pneumothorax, could have surgical emphysema, some bowel injury can be there. So all those things are there. Now the problem here is alone PPP may not be of benefit. Sometimes combining both in large complex hernias would always be better than using only PPP.
Large hernias we should do PPP.
Both. Do both.
Large and complex hernias.
Complex
PPP
hernias,
and Botox, both.
Yeah.
Okay. So all panelists are agreeing for this. How many of the panelists are using PPP
You
nowadays?
should start with the Botox, then give 4 weeks rest, then you start pneumo. I think it's around 1000 ml per sitting.
It depends. It starts from 300 to 1200.
1200. Then you do again a CT, see the correction, what is done, then proceed for surgery.
Yes.
Because this Botox is a chemical separation technique. It's a chemical which does the component separation.
Yes. Botox should relax the muscle and PPP will expand this muscle again after that. So this is about the PPP, how we are giving, and these are the complications and these are the preventive measures we should do whenever we are doing PPP. Prophylactic heparin, antibiotics, everything we are giving whenever we are doing PPP. And any other things about PPP? And Srikanth, anything you want to add? Nothing.
PPP is a little bit cheaper as compared to Botox. So in our setup in Indian scenario, everyone should try doing PPP actually. It is easier and there will be little bit of discomfort, but should start. It is really a like a helping hand in this
Yes.
large hernias.
Okay, thank you. Next is principle of reconstruction.
Nothing is costly now, since the BHUBANESWAR scheme is going on and Srikant is heading the Department of Surgery in Bhubaneswar
Botox is
capital.
not available in BSK. I tried for my patient.
For
It is
complex
not,
hernias, you can try.
right.
I think Botox is not very
Botox is
costly.
available
I
in
think
BSK.
150 units cost around
They are not
30,000.
giving us. Okay, okay. So about this principle of reconstructions means how we should repair in these cases. So we select the correct patient, optimize their modifiable risk factor, select the correct procedure, pay special attention to skin and subcutaneous tissue, and careful post-operative management. Select the correct patient means we should modify the risk factors. If the risk factors are not modified, what to do? Tushar sir. We are not able to modify the risk factor in a complex incisional hernia. Patient is not having any complaint on, except that large sec and the loss of domain is there. No other complaint. We should operate or we should not operate? Sir,
I'll wait.
you will wait.
Yeah, if
So
it is
that is
complex.
the most important. Don't operate until they are absolutely ready. Don't operate any complex incisional hernia. Let them stay like that. So if you operate, you will suffer. The patient will suffer and surgeon also will suffer. So
Sometimes the patient will not suffer.
okay, okay, right. Then select the correct procedure. What is the correct procedure in this type of complex incisional hernia? Khetri sir.
Actually, there is no perfect procedure. The surgeon is also not perfect, the patient. So, you have to do a good fascial closure and tensionless repair.
Yes.
Appropriate suture has to be used and mesh has to be appropriately fixed.
Yes.
So, this is the ideal.
All, if fascia closure is not possible, then any other methods we are doing.
Momentum, you can bridge with the momentum. You can use the biodegradable meshes.
Peritoneum also we
Yeah,
can use. So peritoneal flap, omental flap we can use to close that, and just to have to extra peritoneal is the mesh. That is more important. And about the skin and subcutaneous tissue. So sometimes we are facing the problem in the skin necrosis and other things. So what special care we should give whenever we are raising a flap or we are doing anterior component separation. So what we should do in that condition?
Raising the flap should be in the correct plane without jeopardizing the vascularity. That is most important. And the second part is you can also check on the fluoroscopy, ICG. You can see the viability of the flaps before closing it, and you can revise the flap as well.
ICG we can use. Okay.
Even we can plan pre-operatively regarding the vascular anatomy of the abdominal wall, as well as we should have a knowledge of the. Do we have a slide about the vascular anatomy of the abdominal wall?
No.
Okay, so that knowledge is also important, where the perforators are, if we are going like in anterior component separation, open anterior component separation, if someone does, there is very high chance of flap necrosis.
Yes.
And those hernias that you have.
In that condition, we should do endoscopic anterior component separation. That will be safer and the vascularity will be preserved. Okay. And last part is post-operative management. Devashish sir, post-operative management.
I would prefer that during surgery only you start with the preventing the thrombolysis by venous pump.
All patients, complex incisional, because it will take long time. So we should do
Because
thromboprophylaxis.
any long surgery, it is better to have a venous pump. Then, apart from that, at least post-operative ICU care should be, if you don't have a ICU, at least meticulous care with continuous monitoring, 3 per hour, 5 per hour monitoring for at least 1 day is ideal.
Yes. So prevention of
Chest
thromboembolism,
physiotherapy is another
arterial ectasis and pneumonia we should prevent by doing a spirometry exercise preoperatively. All these things. So this is already we have discussed plane of mesh placement, where we should give the plane. What is the proper plane in complex incisional hernia? What plane we should use, Srikant?
Retrorectus.
Retromuscular repair.
Retromuscular repair. That should be the
Retromuscular
ideal.
repair is the best place.
That should be the ideal. All the panelists are agreeing with this?
It has to, complex is no one particular place. We also are talking about lateral, we are also talking about large, so it's not always retrorectus or not retromuscular. It depends. It depends what you're doing. So it may be the ultimate answer for anything. If one answer you want, it's a posterior component separation, because that is one plane which is common to all. But rest places, we have to say, customer where the hernia is, and customer will decide. The best
What is
plane
the best? What is the best plane?
in the midline, if I'm talking about M hernias, possibly the retrorectus stopus plane.
Retrorectus.
If it is lateral, then and it's large, I'll go for the posterior component separation. Posterior component separation.
Posterior component separation. That is retrorectus with component separations. Okay. TAR versus peritoneal flap. Is it any differences there, or whenever we are doing TAR, sometimes we are not able to close the TAR. We have to use the peritoneal flap
Yes,
also.
yes.
So is it okay, or
Always plan with a peritoneal flap incision.
Yes, sir.
Preserve both the peritoneal flaps. Go ahead and do the whatever you could post a PCS closure. Once you are not able to achieve, you do a TAR. After that, still you are not able to close the anterior aspect, then you can use the peritoneal flap.
Right. We should not close the posterior flap or PRS with tension. Always, if peritoneal flap is available, we should preserve this and we should use this, and it is safe for us.
You preserve till the last when
Yes.
you close.
Right, sir. So this is the paper for principle of complex abdominal reconstruction. This is one 4 case capsules are there. 4 cases are there. So this is a case recurrent hernia. Recurrent means the patient is undergone only mesplasty for epigastric hernia. After that, patient has somebody has done AIIMS plus also, and after that again recurrent. So recurrent hernia. So what to do in these conditions? Khetri sir.
In recurrent hernia, if you are planning a laparoscopic, you do a diagnostic lab. If you are comfortable, try to do the posterior component separation, because
Already mesh is there,
No,
sir.
mesh is there, but if you go, it is possible.
Yes.
And it is a safe plane.
Yes.
The PRS, if you can remove it, is a safe plane, because whatever the bowel will be contact, it will be below the PRS.
You are telling retrorectus.
Yeah, I'm telling retrorectus.
E-tap RS.
E-tap RS.
Yes.
In E-tap RS, all the adhesions will be below the PRS. It
Yes.
will not be. So
Yes.
if you are in the proper PRS plane and in the epigastric region, the falciform will help you down. So it is possible. So this will be ideal situation.
Sometimes cackers will be there, maybe peritoneal breach will be there, air leak will be there. Is it okay for you, or we'll do
No,
go for
it's
open?
not that it will be okay for me. But if you diagnostic lab, if you are confident enough, because whenever there will be a recurrent tooth, there will be adhesions. Bowel
Yes.
adhesions will be there, which will be less in retromuscular dissection in E-tap RS.
Okay. Any other things? Any other panelist? Any additions?
I think E-tap RS is most preferred site, and in cases of problems in facing there, you can change the type of the mesh if you get multiple injuries or perforations. That's the main thing, and
So in experience,
not
hand,
necessary to take out the mesh of any other side.
Okay.
That is
This patient actually there is a W2 defect in epigastric region. So for that region you may have needed TAR for that maybe.
Yes.
Either unilateral TAR or bilateral depending on the thing.
actually we have done open operation in these conditions, and only retrorectus was sufficient, and fascia was
Okay. At times it is difficult to oppose 5 to 6 centimeter defect in only retrorectus dissection. It is difficult in the this upper abdomen.
Yes. So we should do retrorectus. Whether you are expert, you can do E-tap RS. Otherwise, you can go for open retrorectus repair. Right?
One question to the
Endoscopy or
panelists.
open, it doesn't matter. You have
If the
to
moderator
give a good
allows,
repair.
can I put one question?
Sir.
If the posterior rectus is not able to close,
Yes.
what will you do?
So that's what we are telling. We can go. We should go for TAR, sir.
If you have done bilateral TAR is not able to close, what you will do?
Then we can use peritoneal flap or that.
No, posterior rectus I am talking.
PRS. Huh.
Not able to close. There are multiple
You can
defects.
put a like vehicle.
Defect, multiple defects. Multiple defects, sir. You are telling.
No, that defects are not able to close completely. First, you have to put in the momentum, as Sirkan said, vehicle mesh, followed by polypropylene mesh.
Vehicle mesh is available, sir, in
Yes,
our.
yes.
But tie and available, na?
First momentum,
Okay.
over that vehicle mesh, then you can put a.
So if you are not able to oppose, you can use vehicle mesh, and after that we
First
should use
momentum, vehicle mesh over that polypropylene.
Okay.
One thing is that when you go for such huge and complex hernias, you should have multiple types of mesh in your OT. You may use a simple mesh, but sometimes you may have to change from a simple mesh to a vicryl mesh or a biosynthetic mesh. If that is there, counsel the patient and try to put the mesh which is most comfortable, not where only you have got one mesh and one size. Sometimes it so happens that you may have to two meshes.
Multiple mesh we
Multiple
may-
mesh
Yes,
may
yes,
have.
sir.
That is there.
So this is another case. Because of lack of time, I am skipping one case. This is another case. Is a big hernia. Actually, multiple only mesh plasty. After that, patient was afraid of doing the surgery, so he left like that. She left like that, and the size is like this. And loss of abdomen is around 50%. So defect of size is around 12 into 10 centimeter. What to do in these conditions?
Right? So basically, this is definitely, it's not rocket science to understand that the patient is having a domain loss. We have to go for with a PPP slash the Botox slash both. So possibly with 50, I'll think of both. This patient is optimally we have to go for the chest physiotherapy also. The skin care, the skin doesn't look good. All of these things have to be taken care of because I would not like to put in a
One thing
mesh
in
inside.
this case, pre-operative optimization is needed. So
Definitely.
before how many days of operation we should admit that patient, so that we can start our procedures and other things, or we will do OPD basis.
No, that depends. Like if you're doing the PPP, you can do on OPD basis as well. But yes, when admitting, I do not know the days wise. I will not be able to say. But yes, once for I'll be needing for a Botox. If I'm admitting it, otherwise we'll have to do both anyway.
This is the city picture, city video. What we are seeing, all the contents are going outside. This is after Nemo, and this video is actually this photo is before Nemo, and this is after Nemo. You can see the 50% of the sake is contained air. So
what was the correction done?
that was the correction done.
How much? What percentage?
Around 20% decrease. 20%.
Suppose you are not able to close apart that you can go in for omentectomy. What to go? You total
Omentectomy I have done.
Even you can go in for hemicolectomy. Also people have done.
Yeah. So that's exactly what I wanted to raise. So surgically also we can debulk.
Yes.
But the problem is this, like for omentectomy is fine, but for the colectomies and all, and then putting the mesh in this such a hernia, I'll be skeptical.
Yes.
So if I'm doing it at all, I have to do that, then I will do it in 2 sittings. It will not be done in the same sitting. So we have to be very clear about that. That if you're going for a surgical correction, that has been tried, literature there to prove we can go for hemicolectomy. But personally, I would not recommend doing it in the same sitting.
In this condition, we have in this case we have done omentectomy, and this Botox injection we have given. This is the last part of Botox injection given in the external oblique, and also PPP we have given in this given by central line. So this is the procedure what we are doing, and you can use like central line we can give PPP, and various needle and by central line we can give PPP, and accordingly we have increased the input up to 1000 ml. Means daily initially we have started up to 200 ml started, and after that we have increased up to 1000 ml. This is the operative picture. This is the adhesive lysis, and after that we have given the peritoneal flap over this tar area, and we have given mesh, and this is the closure what we have given. And this is the initial before operation, and this is the after operation. You can see the video. What other things we can do in these conditions? Any other extra things we should do, or it is okay for this condition?
You may do the post-operatively?
Pre-operatively.
Pre-operatively.
We have given PPP 1 month before. Yeah. PPP and Botox injection 1 month before, and they are telling around 4 weeks you should leave for that. After 4 weeks you should do the operations. So unluckily that PPP has come out after 20 days. Means they are continuing, but PPP has come out. The central line has come out, but we are okay with that. The already abdomen was expanded and air was inside it. Now after that 5 or 10 days we have done the operations. So what, any other things, or you are
the remaining everything, because the patient is taken as a whole, not only in the abdomen.
Yes.
The chest also have to be improved. We have to go for good chest physiotherapy, and we have to see that the skin condition, as I already highlighted, is to be good. Skin ulceration, I'm very skeptical of putting the mesh inside when the skin ulcer is there.
Yes.
So preferably, even if you can, if it is reducible, then you can try to reduce it or do whatever, but that ulcer should not be there, to my understanding.
Yes, yes.
You should take help of a plastic surgery.
Right.
For a flap.
For a flap.
Plastic surgeon's help is always required.
See, next case I am telling you that I have taken the help of plastic surgeon in this case. So this is a Whipple's operation they have done, Mercedes incision, and the right subcostal, huge subcostal hernia. And this was my worst case. Chemo completed 1 year post-operatively, defect size 10 into 8 centimeter with significant thinning of muscle. Muscle was not there. So this is the thing I have faced. After doing tar and repair of the muscle, all these things I have seen. This skin necrosis, muscle necrosis. After that I have given vacuum, the vacuum therapy, and then the plastic surgeon help like flap. So what to do in these conditions? Anything preoperatively we should do to prevent all these things? Any operative procedure we should change ourselves to change the thing. I want to change this happening. I want to go back or reverse the time. So what to do in this condition?
Well, for the muscle necrosis, I will not be able to say what best we could have done. We'll have to look, have a visit over the. I mean, I've not seen the technique actually what we have done there. Why should muscle necrosis? Because that is beyond my comprehension. Because
Muscle was in tension. So I have done anterocomponent separation.
So that's what I'm saying. So if the technique is a problem, then muscles should not be under tension. Because
so we are not able to oppose the muscle. What to do in that condition?
I'll do a sandwich therapy. In the sense like one.
You can give a bridging mesh.
Yeah, bridging mesh. We can
bridging
give
mesh.
one from inside.
Right, all panelists are agreeing for the bridging mesh. No problem will be there in the bridging mesh, sir. No.
The other point I would like to make.
Second thing, due to this muscle was not coming, I have done an anterior component separation, which is compromise the skin also.
Skin, yes.
So
I will
that was
just
the problem.
add to it. It's not only the anterior components which compromise the skin. Here, this acute angle on the skin there. So there should be no acute angles.
No acute angle.
When you're doing a skin like this. So there the vascular is bound to go. You do a bilateral sinus flap surgery, anything you do, if there's acute angle there, it will definitely go. So it has to be obtuse.
Sir. Ramji sir, anything you want to add?
Skin necrosis, if it is a good flap, and ideally a plastic surgeon in the primary setting is better. Than calling him for a complication.
Right. Okay. So we should take the help of plastic surgeon whenever we are doing these complex hernias, these big hernias. So we have taken the help of the plastic surgeon. They have given a flap. After that flap also slightly necrosed. Again vacuum therapy. At last we have closed this.
So this flap can be planned in the first surgery itself.
Flap.
If we are getting that there is a vascular compromise, we can plan this flap
We
in
should
the
tell
first
the
surgery.
plastic surgeons to stand by our side. If it is not possible, they will help us.
Yes.
Right. We should take the help of the plastic surgeons. So to conclude, select the correct patients, optimize their modifiable risk factors, select the correct procedure, careful post-operative management, be prepared to handle the complications. That is more important because these complex hernias are more prone for complications. Then we may get success in complex hernia surgery. Anything more in that? Anything we left?
So I want to give two messages only. One is a complex hernia is already a complicated patient, a already suffered patient. So you should be very much of deciding whether you are okay with doing this surgery or you will refer to someone who is better in that. Second thing, if at all you are dealing it, you should take help whenever it is required in the planning as well as in the management.
I'll just add to what Shrikant has just said. So let us understand about the component separations. This looks a very fashionable surgery, and it gives a lot of adrenal surge, and it's a lot of kick, and we are so happy to show it around. But I need to tell one thing to the people who are not doing it. Please don't venture into it. You lose patients. The patients die. Nothing short. So we have to be very clear about such patients. Like Dr. Rashmi will agree with me. And all my panelists, of course. So it is a difficult surgery, and it has to be custom cut. You have to have a reasonable amount of experience in managing such patients. Otherwise, just leave it to somebody else. It's not necessary that every case we have to do. And a patient is bad for you, also wait. Don't operate. The question is now, if a patient has been subjected at the wrong time or by the wrong surgeon, the mortality is a must.
Thank you for the good discussion about this and guide to also me and also for audience. I am telling these are the cases what we have done, and these are most difficult cases. Any questions, sir?
No, I am not question any question. I am rightly agreeing with him. If we are dealing this sort of complex and difficult hernia, it is not only the major. I mean, the surgeon should be expert. You should have all the arms with you, like component separation technique, pre-operative Botox, pneumoperitoneum, as well as you should have today the arms, fasciotons should have.
Yes, fasciotens. Yes.
That should also be.
We have not discussed about fasciotens in this.
Is the last, it should be as far as possible, this should be the first and the last surgery.
Yes.
That is the very important.
Yes, thank you. We have summarized our all the topic is summarized by all the panelists, and also sir has summarized all these things. Thank you all for good guidance. And sir, anything?
One announcement: if people are interested, those who are surgeons are interested to know more about AWR, abdominal wall reconstruction, we are having a World Congress in Chennai the coming February 7th, 8th, 9th. And we are having almost 90 international stars there will be present. So those who want to register, they can contact Rashmi or me, and that will be one of the best because it happens to, almost bi-yearly, not every year.
Today discount rate is there, 5,000 discount.
Just show that. This is that's Deep Impact AWR. It's happening in Chennai, ITC Grand Chola, and it's one of the best conferences. One should not miss it. The last happened in Delhi, and there are a lot of international stars there. Those who are doing pioneers in hernia surgery. Thank you.
I'll add only one thing, sir, that in this hernia, there are a lot of pre and post-op workshops, including fasciotense, E-TAP, and also component separation, and lot of new things which are going on all over the world. You can have a view on that. You can enroll and take advantage of this AWR. Pre and post-op workshops.
Thank you, sir.
I express my heartfelt gratitude to Sir and all the panelists. We'll be starting with the next session of invited guest lectures. I would like to invite Dr. Ajit Gopal Samal Sir, Dr. Ashok Acharya Sir, Dr. Ravi Narayan Mishra Sir, Dr. Surajit Patnaik Sir, and Dr. Sushil Kumar Sir to grace the dais as the chairpersons. As the first speaker, I would like to call upon stage Dr. Arun Kumar Chaudhary Sir to speak upon reconstruction of post-burn defects, a surgical challenge to surgeons.
Can I start? Chairpersons?
Sir, please.
Thank you very much. Good afternoon. Really, it is a big honor for me and also a great privilege for me to be on the dais. Well, I have been involved with the Odisha State ASI for a long decades. And we used to have in every district headquarter hospitals a CME on burns. And burn is very much close to my heart. The reasons being, ignorance is no excuse for law and also for the burns. Now today morning, if you see the Times of India headlines, there have been an incident in the NICU of Jhansi, and there are about 21 patients, small babies, out of which 10 have already, they have succumbed to the burns. And a person, Mansoor like, who want to save, because he had a twin daughters, he has lost, but he has saved about 10 babies from that. So such things are happening. In Orissa also we had such mass burn casualties. I think many of the senior periphery doctors must have seen all that. How mass injuries, even one of the private hospitals, it happened in 2019. So burn is, nobody is immune to burns. So being one of the burning issues, the Government of India statistics shows that 7 to 8 millions of people every year they get burns. This is second to the road traffic accidents. So its importance and utility is too big for our with 1.4 billions of people. So I think as a general surgeon, as a plastic surgeon, I go to little higher up, but for a general surgeon, burn is not your choice. Burn patients will be your compulsion, either you in the periphery hospitals or any hospital, private, corporate, anywhere. So I think the basic doctor is the general surgeons. So I request all my residents and junior surgeons who will definitely encounter burns, whatever other cases you may see or not. And burn is for the general surgeons to treat first. And first is the best treatment, where you have to render the first aid and also to give the best possible treatment to the patient to save the lives and to prevent the morbidities and the mortality mostly. Because more than 50% burns, I remember 3 or 4 decades back when I was doing my postgraduate in SCB in early 80s, any patient admitted to SCB, we take it granted the patient is going to die. But now things have changed a lot. And as I'm mentioning here, wisdom lies not on the amount of knowledge acquired by you, but on the degree of its application. So we get a lot of knowledge in our academic activities, festas, but how many we really apply, that is what is more important is. So today my presentation will be on some few cases, but I have told by the organizers, sir, we are shortage of time, so it is not possible to really discuss such a big subject here. But at undergraduate level, it is a requirement of NMC to have a burn unit, and also for higher specializations, you need to have a burn center, which should have a ICU and all that. Fortunately, I am lucky. From the day one of this institution, I have been attending most of the meetings here. So I am lucky to see Dr. Manas here and the HODs and all panel discussion as a brainstorming exercise of discussion on hernias. So obviously this is an academic institute of excellence. Now, I think everybody having the experience are the excellent people. So excellence comes from your inside, how you are interested to learn the subject and go ahead. Well, I am putting up the reconstructive ladder. Well, with the time constraint, it will not be possible to talk about details. But I have to just tell that any general surgeon should have the basic knowledge of right from ground floor to the top floor. And the elevator, what I am talking is the whole scenario of algorithm of the treatment of the different type of defects, especially in burn wound defects or the big, large defects. The elevators are mostly the free tissue transfers we are able to perform by microsurgical methods, and tissue expansions, stem cell. Professor Mahapatra is very much there, I think. From Burla, I was doing on burns also for the stem cell use, and robotic surgery and AI tools. Now AI has taken over everything. So now I am not going to talk about details. This is for the residents to know about details. But one thing I have to tell, all these treatments depends on what type of burns it is. So it is not similar to a thermal burn, you get a scar burn, or you get an elective burn. All are different in its management. But one thing I have to tell now, there was a meeting of National Academy of Burns in Ranchi. 2 surgeons from US, 95% burns with 50% above deep burns, they are able to achieve, and the patient used to live with a little morbidities and can have a normal pursuit of life. So this is the recent trend. It's been possible to treat a burn patient, and the surgery as a surgery, we think after the wounds have opened up, once the scar or the scar gets off, then we go for a skin grafting or a flap. But now the recent trend is from day one, we think of doing for an early excision, taking off the scars, then putting off biological dressings, where the role of like other banks like bone bank, blood bank, we used to have a skin bank in any of the institutions or tertiary institution. I think in AIIMS, we are going to have a very good burn center where you have ICU care for inhalation burns. It is not just a skin burn, but in inhalation burns, most of the patient dies. In Calcutta, one of the Amri hospital, 90 people died, and most were from inhalation burns. So you need to have a dedicated ICU for the burns which were there in SCB Medical College, Cuttack. Well, This is one of the interesting case I want to show in SCB. 70% burns. A child of 5 years, Sukanti from Kalahandi, and the patient was, anybody can see and tell about this patient fed. But fortunately, we are lucky enough to utilize little modern technology in treating this patient. This is the patient. This is the area of burns. After doing a fluid electrolyte management properly with a proper dressing, and all dressings in a burn patient has to be monitored and done by a senior surgeon rather than leaving it to residents. This is our teaching. I think from SCB about 30 MCH are passed out, and among many are faculties of the AIIMS, not only in Bhubaneswar but in other places, that stored their interest not only for the surgery itself, how to organize. Organizing a burn unit is also a challenge for us. So this patient, what we did, such a big area, about 65% raw area is there. Other rest area, about 5 to 7% healed up with, because they are first degree burns. And this area, what we did an autograft and made it to stump sizes you are seeing here, and do it a meshing on that. And that mesh was taken from the mother also. So this is a homograft, and the patient, the patient went home, and this is on the elective burn reconstructed with an pedicle flap, a myocutaneous flap. This is another elective burn case where you see the dura is exposed. Then you have to go for a defect with a free anterolateral free flap in reconstruction with the microsurgical procedures. Well, Baripada, I think I have just reminded it, mass burns are possible in any place in the country. Now, as a general surgeon in the periphery, I remember in Baripada in 97, unluckily or luckily, I was heading the department. Dr. Manesh was there also very much. I went there, I was completely nervous. So many patients, the RDC, Chief Minister, the Prime Minister were on physically available, what to do. So general surgeons, they all came down that time, and they help us in managing all these patients. We put all the cannulas on the femoral veins without thinking of a periphery vein. And many patients, out of 250 patients who came, whole surgical unit, urology, cardiothoracic, all departments are full with only burn patients. And 4 months, with hardship of all the general surgeons, the patient went home, only 9 deaths were there. So that is our credit. I think it goes to the credit of the government, definitely. That's why I tell you not to be a physician only. You have to be a little politician, little pleader, like a lawyer, you have to be little logic, and nevertheless leave the press people. So 4 P's are very important to be a good surgeon. So what is the take-home message? Decision making for post-burn defects are crucial for motility and morbidity. Consideration of vascular supply, while lastly, hernia we are talking about, vascularity is very, very important for anything. To take up a graft, to put a flap, having the flap liable, all that is required is your good vascularity. Post-operative results in function, not only patient want a function, but also a cosmetic results. So all composite tissues to be reconstructed in single stage to get maximum effect with different modalities of surgeries followed by physiotherapy. I remember that hernia case last, I was very much pleased. I think why not you put a abdominal binder? So physiotherapy itself starts before the surgery, I hope. It is not after the surgery. So for every universally, and these post-burn contractures that develop is because of we don't prevent the contractures. That also requires a very good physiotherapy. So thank you very much for your patience hearing.
Thank you, sir, for your nice presentation.
As we are having sort of time, the questions may be discussed in the launch hours, I think.
Thank you very much.
Thank you, sir.
Thank you so much, sir. Now I would like to invite Dr. Ramesh Chandra Das, sir, to speak on the topic, to live or not to live, a surgeon's perspective.
Chairman sirs, my seniors, teachers, and affectionate junior colleagues and students. This is, I want to talk, may not be related, you may not think it is related, but it affects all of us. Yesterday, we have heard Professor Banamishra about empathy, and our Puri Sangsad has told how to connect with the society. And I am standing here because of the advice by Dr. Sakti, Dr. Professor Banamishra, Prakash, and many other surgeons who has helped me to stand here because I was sick 6 months back. The question arises, it struck to my mind, are we living properly? You are godly people, God-given hands, and you are reconstructing the parts, curing patients, but are you happy? Most of you are not happy. If you go deep into most of our senior colleagues, our teachers, we have found how tragically, ultimately, we have suffered. So, demography is a thing that is less taught in our medical colleges, but it is so vital. Countries are divided. You see, in front of our eyes, we have Pakistan and Bangladesh. We may be creating another few Bangladeshis in our own country. So surgeons have a great role, and I will cut it short because Giri has advised me to cut it short. I have taken out technical slides, that is how we perform. I have not gone to it. So I will gradually you operate. If you are not happy, can you operate? If you are not coming to the OT or to the OPD with a smiling face and don't connect with the people, do you think the patient will be happy? You will not be happy because my professor used to tell, what will happen? Now, he answers, if the knife is this side, you will be okay. Otherwise, if this side, you will die. So, your happiness is connected to the happiness of the society. Family life is very important. If you have not a happy family life, so disturbances will come and society will be disturbed. And you see, born, as Dr. Chaudhary has told, how many people are dying? Road accident, how many people are dying? COVID, how many people have died? How many families are destroyed? So, that is so important. Demography is so important in our life in every aspect. We are producing little emperors, and we don't live soundly. Most of the families, even in Bhubaneswar, we see most of the houses are empty, most of the families are unhappy, and it is unhappiness epidemic everywhere. If you go deep into their history of the patient, you will find everywhere there is unhappiness. As doctors, as hospital is hospitality, but doctors really in fact slain more people than anywhere or any Maoist attack or war between countries. And the principle of surgeons is do heal, not only heal the parts or the surgical taken out a tumor, do a cancer surgery or any branch of surgery, but healing is our primary importance, healing of the mind, healing of the body, and money, fame, name automatically comes. If you run after money, then there will be no success. How many people we have eliminated from our country because since the family planning program came into picture, you see the amount of this last year, around 1 crore we have sterilized. Let me be a gynecologist or surgeon, whoever is doing this. And abortion is more than 1.5 crores or 2 crores. How many people we have eliminated in these 30 years? This is the amount of people we have not allowed to come. And the amount of disease burden we have created by giving antara, giving contraceptive pills, diabetes is on the rise, cancer, breast, and all these cancers are also related to the demographic situation in our family or in the country. Now people have realized all over the world to have more children. Even in developing states, they are now planning to have more children, otherwise the country will go to dark. Say about Japan or South Korea, even European countries, Russia, everybody, even China is suffered a lot, and there are only little monarchs are there, single child or little monarchs. And I will tell few examples why these people say Elon Musk. I have taken his picture recently. He has written, is an existential threat. Every country now, developed countries, is facing existential threat. He has 12 children. Suppose he is the richest man in the world. What he will do with money? Charity. Whom you give charity? Why not your children? Why not your own people? So that will give the existential threat is eliminated. His concept is like that, and he has preserved his semen for further use. And recently, you must have heard our Andhra Chief Minister in a meeting has told that you have minimum children in Andhra. Tamil Nadu Chief Minister also reciprocated, have as many children as possible, because economically the South Indian states are going down. Central fund is reducing. The demographic demarcation of the number of parliamentarians are reducing. So it has a very dangerous effect in all aspects of our life. This is Brad Pitt and his family, and he has adopted 3 more children. And working woman, the girl who is not married harms herself. Those who work and have children, they harm the children. Most of our family suicide and all these problems are occurring due to the lack of mother's care. The child needs the mother care 24 hours. I will quickly go through it. Infertility is on the rise, 20%. You will see in Bhubaneswar, in every unit, there is an infertility clinic. It's 20% already. And late marriage has become a fashion. No, I will do job. If you ask a patient of yours, he will tell, no, I will do job, and I am very small child, 25 years old girl, tell me, I am not that old to marry. So the concomitant result and the danger of coming to the hospital is so frequent in infertility. We are treated as animals. This is a mass sterilization camp. The human beings are treated like animals. And separation. Divorce is 30 lakhs in our country. 30 lakh driver cases are coming in the family court. Kama Sutra came into picture when there is disturbance in the reproduction and demographic problem. It is a Boston we see is a scientific method to stimulate the people to have more children. Cesarean section. Now, in my experience, I have motivated to undergo 4th cesarean section. So we are motivating these obstetricians to go for as many, because you surgeons stand by, they will not fear to go and will advise the patient, no, more, not less than 3 children, because the total fertility rate should be more than 2. Most of the houses in Bhubaneswar will see 2 let houses, empty nest syndrome and Ding syndrome. Ding syndrome means double income, no child syndrome. That is a common disease occurring in our families. Asa, they are getting 1,000 rupees, doctor getting something, and our family is desperate. So I will not go to the procedural problems. The message is very clear, and procedure is a bit of magnification. You can recanalize the tube. 35 cases we have done, and I have motivated those who are having 2 children again to undergo recanalization and have kids.
Sir, please conclude.
People are becoming conscious also gradually.
Sir, please conclude.
That's the end of the slide. Thank you. In conclusion, you must live. If your family doesn't live, your wife doesn't live, or your husband doesn't live, alone you cannot live. That's the very clear message, and country will ultimately be destroyed. So we have the power as doctors. It is God-given power. You can motivate and save our country. Otherwise, in Orissa also there will be problem. In all over the country there will be problem. Thank you very much, sir.
Thank you, sir, for your nice presentation.
You can ask any question because I have got slides because Giri has warned me to cut it short.
Sir, we will having the question answer later on.
Thank you.
Thank you, sir. Next, we have Dr. Lakshmikantra Mishra, sir, presenting on comparative analysis of reduction mammoplasty in 2 methods, superior medial and inferior based pedicle.
Respected Chairperson, my teachers and my dear friends, today I will present a comparative analysis of reduction mammoplasty in 2 methods. There are a lot of methods are there, but I will speak the common methods which the plastic surgeons and cosmetic surgeons are doing, superomedial and inferiorly based pedicles. Thank you, organizing committee, you have given this opportunity, and I will speak my experience in this August gathering. We know breast reduction is defined as the surgical reduction of the breast volume to achieve a smaller, aesthetically shaped breast mold with concomitant relief of the potential symptoms of the mammary hypertrophy. This is the breast anatomy we know. I don't want to speak thoroughly. This is the blood supplying from superiorly, laterally, medially to this nipple area. And depending on these circulations, these flaps are we are doing these flaps accordingly. Superiorly based, inferiorly based, superomedial based, lateral based, and bipedical also helpful. This is the venous drainage. According to the arterial supply, the venous drainage is there. We do the surface marking usually in the standing positions, starting from these clavicles, from the mid-clavicular point and the nipple. These are the preoperative measuring tape should be taken. Accurate measurement is essential, otherwise asymmetry will be noticed in the features. These are preoperative marking, standing positions, mid-sternal line. This is one of this one. This is this equilateral triangle of pen. Usually it is calculated from this mid-sternal line to both the nipples, and it should be equilateral triangle, 21 centimeter in an average Indian lady. It may vary from the height of this ladies also. And the nipple should be at the level of this 2 to 3 centimeter of the mid-inguinal point, which is known as petango points. It is very important for the nipple positions at the 4th intercostal space essentially required. The common indications for this reduction mammoplasty, we know the personal embarrassment and psychological problems. Usually this reduction mammoplasty is not considered in the insurance group, but most of the patients presenting with functional problem, they have a lot of pain while in the movements, and there is some severe brachydactylic pains, neck pains. They have also cervical deformities. I think insurance people should include this is rather than considering it an aesthetic group. And this grooving of the soft tissues, shoulders by the bra straps, chronic inflammatory skin breakdowns, inability to engage in the vigorous exercise. Symptoms of this brachial plexus compressions is a very rare conditions, but is a very grave conditions where indication for the surgery is there. We do this treatment planning, history, physical breast examinations and indication for the surgeries, proper preoperative counseling, preoperative assessment, and proper selections for these techniques. Ideally, the breast reductions to be lifted to its natural youthful positions in proportions to the rest of the body. Two breasts should be symmetrical in positions. Nipple areola complex to be translocated to the new positions. Blood supply to the NSE should not be jeopardized. Function of the breast should be preserved. Aesthetically, this scar should be acceptable, and procedure should be in the all forms of the enlargements, those who are suffering from pain, and it should be done in a single stage. We have a lot of different techniques are there. Early horizontal and combined scar techniques, wise pattern, short scar techniques, liposuctions, assisted reductions. But most of the plastic surgeons, we follow this wise pattern, inverted T-shaped reduction mammoplasty. This is the wide pattern. You can see the schematic diagram before and after. These are the results, inverted T-shaped there. This is the wise pattern marking. We use this keyhole instruments, and there is also cookie cutter to for the approximate tissue reductions, and also helpful how much tissue should be excised by this the instruments. These are the reductions according to the excision of this breast tissue from one side of the breast. 150 to 500 gram per side is a small to moderate reductions. 500 to 1500 gram reductions is major reductions, and more than 1500 grams per side is massive reductions. So these are two types of the ptosis of the nipple. Nipple usually mild, moderate, advanced, severe type of ptosis. We follow these techniques. I told you this schematic diagram: superior, lateral, medial, inferior pedicles, supermedial techniques. And coming to my techniques, actually, usually I started this practice since 2007 of these breast reductions. Initial part of these reductions, I follow most of this surgery by inferiorly pedicle reduction mammoplasty. And up to 2013-14, when I attended all these conference, plastic surgery, cosmetic surgery conferences, where all were talking about supermedial pedicle vertical reductions. Then I follow most of this supermedial pedicle technique. I got also good results, and few cases of this I will discuss in the next slides. I shifted to also to this inferior pedicle. This discussion I will go through in the next slides. This is the photograph supermedial technique. We follow this. This is the supermedial technique. This pedicle is mostly in the intercostal branch there. We follow this axial pattern 3:1 or 2:1 length and breadth, and this is the reason. This advantage is it's a reliable circulation from preservation of the nipple areola sensations, eliminations of the nipple areola hypopigmentation. It's an very aesthetically looks wise very good, nice. This my experiences. Supermedial technique of the reduction mammoplasty in the front view. You can see this. Then you can see another lady in the lateral view. Projection is fine, and the nipple areola sensation intact, and long-term result also very nice in the supermedial technique. This is another lady. This lady I will discuss with. This is a macromastia. It's a very huge size breast. I did this supermedial technique where the nipple areola complex was translocated to this level of this fourth intercostal space. Here you can see this marking, and this whole of this flap was rotated to the level of this new nipple area. Here I have noticed in the lateral phase there is necrosis of this partial necrosis of the nipple, and there is also some portion of the wound dehiscence. And here I have also gone to the literature, and I read articles, I discussed my seniors. Then I modified again the inferior pedicle technique, where a large breast of there. Then I have switched about the macromastia, specifically macromastia with huge resections like massive resections, massive to resections, more than 1000 gram in each breast. 1000 gram means 1 kg. And I planned for inferior pedicle reductions here. These indications also I told you medium to massive reductions, where the pedicle I usually kept 6 to 10 pedicle length. This is the schematic diagram of this reductions mammoplasty of this inferior pedicle. This is the view, and I follow this massive reductions. You can see most of the breasts are found in the level of this umbilicus level up to the umbilicus. Here I have planned for inferior breast reduction mammoplasty, where I didn't found any complications. These are these photographs. Big size mammoplasty, reduction mammoplasty, inferiorly best. This is another lady, you can see. This is another lady. Photographs with different views. This inferior best reduction mammoplasty. Here you can see this lady. This lady, you can see, he got my number from internet or somewhere else. He was NRI staying in Australia. She came to Apollo Hospitals in 2019, and I did the surgery of the same inferior pedicle without touching to this, means without going for supermedial. Though supermedial was included everywhere. It's a very popular technique in cosmetic surgery practice. So I found, this nipple sensation found, and long term also found it good. You can see this photograph. I have this is the photograph. Here you can see the supermedial technique where there is a chance of kinking of these pedicles while turning to this level of the neonipple. Whereas in the inferior pedicle flap, you can see this nipple can be this NSE and the pedicle is not jeopardized, as we can move directly to this level of the neonipple region. So my conclusion, breast reduction is a common cosmetic surgery procedure. It is an indication for the functional rather than an aesthetic surgery. And twisting and or kinking of the flap can cause ischemia and necrosis of this nipple and also sometimes wound adhesions. In small to moderate, I prefer supermedial pedicle technique is a very definitely follow. And in massive reductions, I usually like this one's inferiorly best method is helpful. Thank you very much for your kind attentions. I request all my delegates and all my friends to attend the Odisha Plastic Surgeons Annual Conference we are doing in Puri in Hotel Holiday Research, 11th, 12th January 2025. And if you anyone interested, please come and register this conference. Thank you again very much.
Thank you, Lakshmi, for your elaborate presentation.
Thank you. Any questions?
Shortage of time, we will discuss the questions.
Thank you.
Hour.
Thank you very much.
Thank you.
Thank you so much, sir. I would now like to invite Dr. Bishwajit Mishra to speak on the topic locoregional flap for foot and ankle defects.
Respected esteemed chairpersons, my respected teachers, seniors, and my dear colleagues. Locoregional flaps are appropriate for the defect of a dorsum of foot, medial malleolus, lateral malleolus, and Achilles tendon areas. They are proved by their long-term follow-up. Out of 50 cases, there are 12 cases of medial malleolus defect, 10 cases of lateral malleolus defect, 20 cases over tendo-Achilles regions, and 5 cases for proximal dorsum of the foot defect, and the whole dorsum of foot, 3 in large defects, we have used locoregional flaps. According to etiology, the cases are separated with post-traumatic in 36 cases, post-burn 8 cases, venous ulcer in 4 cases, and diabetic foot ulcer in 2 cases. The problem with these defects are the foot is being a weight-bearing area, and there is limited availability of the soft tissue around the defect, and always associated with exposed bone, joints, and tendons, and there is always repeated soft tissue infection as well as osteomyelitis, and there is always a poor skin elasticity surrounding the defect. The criteria for an ideal reconstruction is always a durable, the reconstruction should be durable, it should cover stable, thin, good contour and resistant to friction by footwear. You should cover with such a flap, and there should be post-reconstruction, there should be normal joint excursion, should have adequate sensation, and the reconstructed skin should have non-hairy skin, should allow good tendon gliding, and it should be aesthetically acceptable with minimal donor side morbidity. So we have reconstructive options like split thickness skin graft, local flaps, intrinsic foot muscle flaps, regional flaps, or free tissue transfer. So locoregional flaps, usually these are fasciocutaneous flap, adipofacial, facial, tenosynovial, or the first layer foot muscles like adductor hallucis, flexor digitum brevis, and adductor digiti minimi. Free tissue transfer is always the flap of choice for a larger defect. So first, now coming to the muscle flap, intrinsic foot muscle flap. The small to moderate size defect of 6 to 6 centimeter usually is covered by this intrinsic foot muscle flaps over the heel, malleoli, or front of ankle, and should not have any adjacent tissue trauma. And you should also manage the primary cause of the disease, cause like diabetes or venous ulcer, like that. So why choose a muscle flap? Because of its reliable vascularity. Muscle flap always better control of infection. It maintains the contour, fills the contour deformity, should have a better skin graft take, and it withstands the shearing force over the plantar foot, and minimal functional and aesthetic donor site morbidity. So these are the three muscles of the first layer of the foot. The flexor digitum brevis can be combined with either adductor hallucis or abductor digiti minimi for a larger defect. These three muscles can be covered different aspect of the foot according to their site, and usually the vessel enters medial aspect of the muscle of the three first layer muscles. Now coming to technical details, this procedure is executed with a parasole plantar incision. Tendon is identified at its incision and divided. The muscle is dissected till its hilum. Then it can be transposed or hinged to the defect and sutured. Then a split thickness skin graft is applied. Donor site usually primarily closed. Coming to the regional flaps. Most of these flaps are perforator based, and the mode of transfer may be retrograde peninsular or skeletonized island flap, or tunneled flap through a skin bridge, or a hinge flap adjacent to the defect. The smallest, for a locoregional flap, the smallest size of the defect is 6 into 4 centimeter, and largest being 18 into 12 centimeter. The reach of the flap is compared with a cadaveric dissection. You can see the cadaveric dissection, we have raised a flap along with its perforator. Same thing we have applied in a case also. Some clinical cases of intrinsic foot muscle flaps. This is an anterior ankle defect covered with abductor hallucis muscles and a split thickness skin graft. A case of trophic ulcer over the heel covered with abductor digiti minimi muscle with skin graft. Another case of abductor hallucis muscle transposed to anterior ankle defect. Another case of abductor digiti minimi muscle with an unstable scar over the heel, excised, then covered with a split thickness skin graft. Same abductor digiti minimi muscle covering a heel defect. Abductor digiti minimi for another diabetic foot ulcer. Same abductor digiti minimi muscle for another unstable scar over the heel. Abductor digiti minimi for trophic ulcer. And some clinical cases of regional flaps. This is adipofacial flap covering a defect over the medial malleolus. Another case of adipofacial flap with skin graft over the medial malleolus. This is retrograde perforator based retrograde fasciocutaneous flap covering lateral malleolus defect. Yes, perforator being isolated and the flap is covered. Tendo-Achilles region defect with fascial or adipofacial flaps. This is case of fascial flap with skin graft over tendo-Achilles region. And another case of defect over dorsum of foot with a requiring a large flap covered with a perforator based retrograde fasciocutaneous flap. Same person. Tenosynovial flap covered for anterior small ankle defect. Only the tenosynovium of the tendon is dissected out and covered with a split thickness skin graft. So the actually long-term follow-up of all these patients proves the optimum suitability of these flaps. The follow-up period is being 1 to 15 years. These are the long-term follow-up photographs. Then why should you select a locoregional flap? Because it is easy to execute based on strong rationality, no need for microvascular expertise, less functional and aesthetic donor site morbidity, reliable, the muscle flap particularly has a reliable vascularity. These are durable with adequate sensation mostly, and these procedures are single staged and long-term follow-up is excellent. But the prerequisite is always the availability of optimum dimension healthy tissue surrounding the defect. Preoperative Doppler confirmation of the perforator is a must. The limitation being the shape dimension of the flap depends on the constituent of the flap and the incorporator perforators. The dimension decreases, the fasciocutaneous flap being the largest, you can take a larger fasciocutaneous flap, but intrinsic foot muscle flap should have a small defect to cover. So to conclude, we unhesitantly conclude that locoregional flaps provide resurfacing of non-weight bearing areas of the foot with definite rationality and appropriate results. Hence, this should be the flap of choice whenever feasible. Thank you. Thank you for your kind attention.
Thank you, sir, for your comprehensive and informative presentation. And we can have any discussions during our launch hour due to paucity of time.
Thank you.
Thank you, sir.
Thank you so much, sir. I would now like to invite Dr. Jayant Kumar Das, sir, to speak on the topic current modalities for treatment of gynecomastia.
Respected teachers, my seniors, and my dear friends. So the topic is gynecomastia surgery, which has become a very common surgery in our day-to-day practice. So gynecomastia surgery, as a general surgeon, we started with mastectomy. Then when I joined plastic surgeon after learning the liposuction, so it has become easy. So gynecomastia, it's a two different scenario. It's an asset for someone, and it is a thing to be assumed. So it is more of a psychosocial stigma than a disease. Everybody is concerned about their body image because of the social media. They want a flat, masculine chest. Sometimes there are parental support, the parents support for this surgery, but because of the orthodox thinking, parents object also. And in the most of the cases, there is no specific etiology. It is idiopathic, up to 99% cases. So these are the theoretical factors which are responsible gynecomastia. As I said, idiopathic is the most common cause because most of the cases there is no specific cause, there is no specific hormonal abnormality. It does occur during the puberty, but it does not subside, which should subside within 1 year or 2 years. Simon classification, it's the standard classification. It's a very old classification. Still we follow, though there are different presentations of gynecomastia like puffy nipple, which is not mentioned in Simon classification. So grade 1 is small enlargement without skin excess. Grade 2A, enlargement, mild enlargement without skin excess. Then grade 2B, moderate enlargement with skin excess, and the grade 3 like female breast. So what is the indication for surgery? If it does not subside within a specific period, that is 1 year of puberty, or failure of medical management. So, in spite of taking tamoxifen, it does not subside, then you have to do surgery, because as I said, the patient is more concerned about the body image than the disease. But we know the cause is idiopathic. We should not forget the basic thing. We have to take the history, development of the secondary sexual characteristics, proper physical examination of the patient, hormonal assay if you are suspecting, then ultrasonography of the breast to know whether the breast is mostly the fatty component or glandular or mixed. So, with the advent of liposuction, it has become very popular. So, during our initial stage, we thought the only liposuction will do our purpose. Is it so? Is liposuction enough for gynecomastia surgery? The answer is no. There are three components of gynecomastia surgery. One is gland excision. We have to excise the gland. If after liposuction there is residual gland, we have to excise it. I'll show you the different methods of excision of gland. Then skin reduction, like grade 3 Simon classification, tubular breast, we have to excise the skin. Unless until we'll excise the skin, it will not be all right with secondary contractions or over the period of time. Then there are certain devices which will help in skin contraction, like aggressive subcutaneous liposuction. It will induce fibrosis, there will be contraction of the skin. There are energy devices available you can use before the liposuction, like laser or radio frequency after the liposuction. Pressure garment does play a role. The patient has to wear for 3 months. Sometimes post-operative radio frequency energy. So it will help in skin contractions. So gland excision, skin excision, and skin contraction. There are three things you have to address while treating a case of gynecomastia. A famous quote in plastic surgery: failure in planning is planning to fail. You have to plan what you are going to excise, which area you are going to do liposuction. So patient has to be marked before the OT in standing position with a permanent marker. In gym going person, there will be pectoralis muscle. You have to identify the breast tissue with the pectoralis bulge. You have to address the lateral chest wall also. It's a 4D contouring. So you have to address the chest as a whole, not only the gynecomastia area. And if there is any asymmetry, it has to be pointed out before. And size of the nippule-areola complex, if it is very large, you have to excise, you have to decrease the size of the areola complex. Puffy nipple has become very problematic. Patient will not be happy after your liposuction or surgery. So, tumescent solution is infiltrated. You have to wait for 20 minutes. Liposuction is the core entity in all gynecomastia surgeries. So initially, it is started from deep to then superficial. And remember, the on-table result is final. Don't believe in magic, that it will contract, it will be all right, nothing will happen. Whatever you are seeing on the table, that is your final result. So squeeze out all the collection, try to pinch the skin. If there is residual glandular element, then you have to remove the gland with a pull-through technique. Through the same port of the liposuction, you can pull the gland, you have to cut it. Then, if it is very large, then give an incision over the areola and excise the glandular tissue with a 1 centimeter cuff of gland underneath the areola complex. To prevent scar, you can excise the gland through the nipple also. So that is transnipple glandular excision. So there will be no scar on the nipple areola complex. But sometimes in grade 3 or tubular breast, there is skin excess. Then you have to do de-epithelialization, circumareolar de-epithelialization, and then excise the gland tissue, then apply a purse string suture to close the defect. So this is like you can see a tubular breast, circumareolar de-epithelialization has been done. Gland tissue has been excised through the same de-epithelialized area, then purse string suture is done. So gland removal is a must. If after liposuction you are palpating glandular tissue, definitely you have to remove the glandular tissue. It will give a long-term result, satisfying result, both for the patient as well as surgeon. Never hesitate to put a drain because seroma is a very common complication in gynecomastia surgery. And after the surgery, patient has to wear the pressure garment for 3 months, which will help in contraction of the skin. Always be careful about unilateral gynecomastia. Most of the time it is glandular, fibrous, very hard tissue. So liposuction will not be enough. You have to excise the gland tissue. If possible, send a specimen to rule out malignancy. So the final aim is to have a uniform, symmetrical result with a flat masculine chest. Sometimes complication does occur. So you have to be very careful while doing the liposuction. Don't be very aggressive underneath the nipple areola complex. It will jeopardize the blood supply and there will be necrosis of the areola. We can compare the traditional mastectomy with the liposuction. So hospital stay is more asymmetry, nipple areola complex depression will be there if aggressive excision has been done. Seroma is more prominent scar, but in liposuction, it is almost scarless. Hospital stay is almost like a daycare procedure. In the morning, patient will be operated, patient will be discharged in the evening. And it is quite symmetrical, and you have a flat masculine chest. So to conclude, the aim is to have a flat masculine chest. Don't focus only on the breast tissue. You have to do liposuction of the lateral chest area also. And in all cases, liposuction has become the core procedure or the gold standard thing for treatment of gynecomastia. And gland removal, if you are palpating, you have to remove the gland tissue. Don't think that it will be all right after the surgery. And excess skin also you have to remove by de-epithelialization and purse string suture, and always put a drain. So thank you the organizing committee, Manas sir, Dr. Sanjay, for giving me an opportunity. Thank you.
Thank you, Jayant, for your informative and elaborative talk regarding the speech. I will discuss the question in the lunch session.
I thank the chairpersons for this session. For the next session of guest lectures, I request Dr. Ashish Pradhan, Professor Surgery, Bolangir Medical College, Dr. Biranchi Narayan, Professor, High-Tech Medical College and Hospital, Advanced Laparoscopic Surgery, Dr. K.T. Subudhi, Senior Consultant Surgery, Dr. Sham Prasad Mishra, Senior Consultant Surgery, and Dr. Tarun Kumar Sahu, Consultant Surgeon and Angul, to kindly grace the dais for the next session of guest lectures. As the first speaker, I would like to invite Dr. Jayant Kumar Biswal to speak on the topic Anterior Component Separation, a good technique for large ventral hernia.
Good afternoon, respected chairpersons. This one. Okay. So, respected chairpersons, very good afternoon, and to other delegates. I bring the greetings from SCV Medical College, Cuttack, and I welcome you all for the next year's OSASICON in our institution. And I'll be talking on anterior component separation, which is a good technique for large ventral hernias, because most of the discussions, as Rasmi had concluded in the session, that we talk about posterior component separation, a retrorectus placement of mesh, and though that is very ideal, but also technically challenging. And for hernias which are not so big and not so complex and beginners, it's a very good technique, and also gives good medialization of the flaps, and that too up to about 10 to 15, 16 centimeters medialization in the umbilicus level are also possible. So these are some of the large hernias, large ventral hernias. As he very well discussed, they are more than 10 centimeter defect size, and with a loss of domain, a large amount of bowel outside the peritoneal cavity, and these are complex ventral hernias, which are, as Rosmi had described, they are hernias which are large in size, also nearer to the bony prominences, and in atypical sites, which are also recurrent in nature, sometimes with infections where mesh erosions or ulcerations and other things, stoma, near the stoma, all these, anyone can be described as a complex hernia. And also parastomal hernias, all these are recurrent hernias, complex hernias. Many times people confuse between complex and large hernias, because complex hernia, one of the entities in the complex variety is a large hernia. Different methods to deal with large hernias, different component separation techniques, anterior, posterior, and peritoneal flaps, and as you already described, like progressive pneumoperitoneum and Botox injections. And the component separation means, by definition, it is dismantling the layer of the one of the layers of the abdominal wall, lateral abdominal muscle, from its insertion, which allows a well innervated and well vascularized musculofacial component to be mineralized along the over the defect, so that a closure is possible without any tension. This is a publication by Ramirez in 1990, which where it was this first idea about a anterior component separation, and in 2006 by Yuri Nobisky about posterior component separation. These were not there when we were students, and the mostly recent concept about the hernia repair process. A technical aspect about the anterior component separation, where it can be seen from all these pictures that the anterior component means the external oblique muscle. External oblique aponeurosis is divided from its insertion at the linea semilunaris. After you mobilize the flaps, the flap containing skin and subcutaneous fat up to the linea semilunaris, you reach the external oblique aponeurosis and divide it, and then go between the external and oblique and internal oblique, which is a very avascular area, does not contain any neurovascular bundles, because all the neurovascular bundles are present between the internal and external transversus abdominis muscle. So this very well, you can insinuate your hands up to the anterior axillary line, where these flaps can be mobilized well in advance up to the 8 centimeters in around the region of the umbilicus on each side. So some of the steps, most of the surgeons who know who do these procedures, they know about it. So the first one is the resection of the scar tissue. It should be excised, and thinned out skin also should be excised. And that next is the the this one, that where you release the all adhesions very carefully, avoiding any injuries to the bowels. And this is a very important step where you pack the abdominal contents so that you can perform the procedure very nicely. And this is very important. Very perfect packing is important before attempting it. Then you mobilize the skin and subcutaneous fat up to the linea semilaris and palpate the rectus muscle and the lateral wall muscles from below, and incise the external oblique aponeurosis 1 to 2 centimeter lateral to the linea semilaris. Here sometimes confusion occurs when you can incise the rectus sheath instead of the external oblique, but you cannot insinuate a hemostat beyond the linea similaris if you have inside the anterectus sheath. So again you can go laterally and inside the external oblique where you can get the plane easily. And then incision and abdominal okay, this development of the plane between the external oblique and internal oblique. And then so this is a small video where the external oblique aponeurosis is being divided. You can see the lower already divided, and then the upper one is the insinuation of the fingers between the EO and IO, and the flaps are being divided. So it's not very difficult technically. And then closure the defect and put a mesh in the onlay fashion below the mobilized external oblique muscle. It can be below the muscle or it can be stitched along the borders of the divided lateral part of the muscle. But sometimes the skin that looks like the first one while closing may give way, like these pictures, because of the skin and subcutaneous infections, which are about 20 to 35% in incidence in this. For that, this is the vascular anatomy of the this abdominal wall, where it is zone 1, 2 and 3. So zone 1 is the medial most part, which is supplied by the superior and inferior epigastric vessels, like this is shown here, perforators. And these are the perforators. They are injured. Zone 2 by the iliacs and external iliacs, and zone 3 by the diaphragmatic and the intercostal vessels. So the zone 1 vessels, they get injured while mobilizing the flap. So different modifications are like open anterior perforator sparing technique, open perforator sparing with minimally invasive approach without any laparoscopy, and then using the laparoscopic instruments. So the open approach, where you just see these pictures, where a tunnel is developed between these, the periumbilical perforators are spared here. The 3 centimeter around the umbilicus, the flap, this flap is not mobilized, and the upper and lower flaps are mobilized, and the external oblique is divided. So the mesh is put in the retrorectus plane. After this reduces the injuries to the periumbilical perforators, which are the major perforators supplying the flaps. And the open approach with like this technique, where these are the 2 incisions. The flaps are not mobilized, but the incisions like here, and then the external oblique can be divided up and down, and it can be mobilized. Here the entire perforators are preserved. And endoscopic technique with a hybrid technique, like combined open upper incision with endoscopically dividing the, laparoscopically camera inserted between the either in the subcutaneous plane or in the intermuscular plane. Okay. Subcutaneous approach where the subcutaneous fat and skin remains on the top and the external oblique remains on the bottom, and it is divided. And in the intermuscular plane, the camera is put in between the two muscles laterally, and the external oblique is divided on the top. And this is a completely endoscopic approach where a IPOM is done with endoscopic anterior component separation. You can see these are the three ports where the IPOM is first attempted, and then this port is converted into a camera port. With this is a lateral port, the anterior component separation in this line and that line, and then after the mobilization, these two flaps are opposed and the IPOM is completed. So advantages are this is very easy, safe and quickly done procedure, safe to learn. Any complications can be handled also easily. Bag therapy is also easily done, and explantation if necessary also is easily done in comparison to posterior component separation. Disadvantages, this is the skin and soft tissue component infections are very high, and other like abdominal compartment syndrome and other things, they are also there. These are the two publications where it is seen that the perfect sparing technique is equally comparable to posterior component separation with regard to the skin and soft tissue infections. And about 16 patients, we have 5 infections, skin and soft tissue infections, without any recurrence in 2 to 6 up to 2 years of follow-up. So this is a good technique, should be learned by others along with the posterior component separation. Thank you. If any questions, you can ask. Or
which one you practice? Hello.
yes.
Which one you practice and which one you prefer now? Anterior.
We do only open and perfect sparing open. No endoscopic approach we have not attempted. And it's also very good technique. In also practice posterior component, but technically it is difficult and also time taking. This is done within minutes and very quick also, and good mobilization, especially for periumbilical hernias and not for upper and lower epigastric or hypogastric region, but for periumbilical region it's a very good technique. Thank you.
Hello, sir, one question. Have you encountered any skin necrosis following anterior component separation?
No, that's the only problem with this technique. Because of that, this is not very well practiced. And another one is that mesh is placed in the onlay fashion. The sublay fashion, placement of mesh is a better area for the mesh to be incorporated into the body tissues. However, skin necrosis is about, as I said, it is about 5 to 6 patients, but they all could be saved by conservative methods. The dressing and other antibiotics, they take a long time to heal. It may take up to a month also, from 1 to 2 weeks to a month.
Thank you, sir.
Thank you.
Thank you so much, sir. I would now request Dr. Ranjan Kumar Patel, sir, to come forward and speak on the topic, role of interventional radiology in GI emergencies.
Good afternoon to one and all. I would like to thank to the entire organizing team for giving me the opportunity to present here. Today I'll be talking on role of interventional radiology in gastrointestinal emergencies. So interventional radiology provide different kind of minimally invasive, life-saving and elective procedures, and in certain conditions these are the surgical alternative also. So we'll discuss in detail. The emergency intervention can be of vascular or non-vascular complications. So among the non-vascular intervention, the most common one are the drainage of the collection and abscesses, also biliary drainage, and rarely we also do decompression procedure like decompressive cecostomy in patients with eminent cecal perforation. So this is one of the bedside procedure. Patient presented with sepsis, and on imaging it was found out to be a large liver abscess. On the bedside, this was drained, and patient subsequently improved. This is another patient who had a history of recurrent acute pancreatitis, and this time patient presented with features of severe SIRS. And on imaging, patient has a large pancreatic walled up necrosis, and due to the comorbidity and poor general condition, surgery was not possible, neither the endoscopic drainage. So this patient was shifted to the CT room, and CT guided drainage of the collection was done. And this is another patient with severe cholangitis. Previously, patient had undergone left-sided percutaneous biliary drainage. Now presented with severe cholangitis, and on imaging, patient had multiple liver abscesses with dilated biliary system. So a patient was taken to the cath lab, and we did a right-sided percutaneous biliary drainage. And you can see there is also pus coming out of the right-sided biliary system. For PTVD, I would like to point to three points. It can be a salvage procedure when a patient have failed unfeasible ERCP, and in patients with biliary dilated system, when no endoscopy or no surgery is possible, PTVD can be performed as a bedside procedure even in the ICU. And with improvement in the hardwares, PTVD is not at all contraindicated in patients with non-dilated and minimally dilated system. So presently, with a success rate of more than 80%, we can perform PTVD in patient even with non-dilated system. So this is another simple but salvageable procedure. A patient with severe septic shock, on ultrasound there was gangrenous cholecystitis, and on CECT you can see there is distended gallbladder, thickening and irregularity of the gallbladder wall, and there is also a fundal rent. So basically patient had acute gangrenous cholecystitis with biliary peritonitis. So the patient was taken up for the percutaneous cholecystostomy. We approached the distended gallbladder, and we inserted a drain into the gallbladder, and you can see there is also a additional drain placed in the pelvis for the biliary collection. So patient over a period of 3 to 5 days improved, and after 2 months patient underwent elective cholecystectomy. So another case with severe cholangitis. Here patient had distal biliary obstruction with high TLC count. Initially ERCP was attempted, but it failed. Patient didn't have any dilated biliary system, so we initially attempted the PTVD, but we also failed through the percutaneous transhepatic approach. So presently now we had only one option left. We entered through the gallbladder, crossing the cystic duct, and then place a drain into CVD. So what we did, we punctured the gallbladder through the transhepatic route. Then we crossed the cystic duct. We took a run from the CBD. You can see there is distal CBD obstruction. Then we place a stent through the gallbladder into the CBD. And this is the post-procedure CT, which also show the placed stent. So after the non-vascular interventions, coming to the vascular interventions, in an emergency, either any arterial or venous complications do happen, and intervention radiology has a salvage role in patients with arterial or venous bleeding. In case of bleeding, in an emergency basis, angioembolization is done. But in patients with also vascular occlusion like acute venous or acute arterial occlusion, intervention radiology can have an eminent role in immediate recanalization using thrombolysis, mechanical thrombectomy with or without stenting. So this is one of the example. Patient is a post-Whipple's patient, ongoing melena with a drop in hemoglobin. Initial CT was negative, but the patient had ongoing bleeding, so a repeat CT was done, which shows a small pseudoaneurysm arising from the common hepatic artery. And this is the initial patient was taken up for the emergency embolization. This is the initial DSA run. You can see there is common hepatic artery bifurcated into right and left, and the aneurysm was originating from the common hepatic artery. So the ideal approach should be occluding the parent hepatic artery, or placing a stent graft through the artery to seal the rent. but stent graft placement was not feasible because the origin of the celiac trunk was tortuous. So in these patients, we cannulate the aneurysm per se using different catheters and wells, and then we pack the aneurysm sac with different size of coils. And this is the end embolization run. You can see there is preservation of the hepatic artery with exclusion of the aneurysm. Another patient, again post staples, but this patient had bleeding from the abdominal drain. Initial CT was negative. We took the patients for the angiogram, and we found a small aneurysm from the SMA branch, which is subsequently coiled using microcoils. And you can see the end, there is exclusion of the aneurysm. And this is another patient with pancreatitis. This patient had hemosuccus pancreaticus and also had a pancreatic pleural fistula, and this patient also had hemoptysis. So emergency CT was done. You can see there is a pseudoaneurysm because of the pancreatitis originating from the inferior epiphrenic artery, and subsequently this patient was embolized the aneurysm. Then coming to the venous emergency intervention, this is a case of periampullary carcinoma. Because of the anatomical distortion, there was difficult ERCP, and during the endoscopy, the plastic stent was wrongly placed into the portal vein instead of CBD. So this is the ultrasound image. You can see there is a linear stent which is placed inside the portal vein. This is the CT image. This is the CBD. This is the portal vein, and you can see the stent is passing from the CBD into the portal vein. And patient had on-table bleeding immediately after placing a plastic stent. So what we have a stent in CBD as well as in portal vein. So we planned an hybrid procedure. What we did, we placed a portal vein access from the jugular to through the transhepatic route and into the portal vein. Then through the endoscopy route, we placed a endoscopic stent, leaving the previously misplaced stent in the portal vein. Then we removed the portal vein stent, and simultaneously placed a balloon in the portal vein. So this what we did. We approached the portal vein through a transjugular route. We placed we cannulated the CBD and placed a CBD stent through the endoscopic route. We removed the misplaced portal vein stent, and simultaneously we placed a portal vein stent. And this is the end angiogram. You can see there is the CBD stent, and there is sealing of the portal vein rent. This is another complications. Again, patient had gallbladder carcinoma post right hepatectomy, and on the day POD day 5, patient had elevated AST and ALT. On CT, it was found out to be a segmental portal vein occlusion, and because there was impending hepatic failure, we thought it is due to portal vein narrowing. So we approached the portal vein through the transhepatic route. This is the angiogram. You can see there is severe stenosis in the portal vein. We initially did a balloon, and in the end we placed a stent. And this is a last case, a patient with chronic pancreatitis. Patient presented with severe GI bleeding. On imaging, there is splenic vein thrombosis, and there are multiple varices in the stomach. So this is basically because of the chronic splenic vein occlusion. There is left-sided portal hypertension leading to gastric variceal bleeding. And so we didn't have access through the transhepatic route, so we took a transsplenic route. We punctured the splenic vein directly through the transsplenic route. Then we took an angiogram. You can see there are multiple varices, and we embolized with glue. And this is the final glue cast. And in the end, we embolized the transsplenic tract using the glue. So to take home message, IR not an competitive. Basically, it's an complementary to the surgical procedures, and in several emergency situations when upfront surgery is not possible, IR can be a salvage tool, and it should be an integral part of an emergency care unit. Sometimes not only the IR, not only the surgery is the best, sometimes the combined approach should be followed to have a best outcome. Thank you.
Thank you for a very nice presentation. Any questions from the audience? Thank you.
Thank you so much, sir. Now I would like to call upon stage Dr. Debashish Samal, sir, to speak on the topic retrorectus mesh repair, transforming the landscape of hernia surgery.
respected chairpersons, my seniors, and my friends. Actually, my topic is is basically on retrorectus mesh repair. Uh, Retrorectus mesh repair, basically transforming the landscape of the hernia surgery. I'll not go into the details of the operative procedures and all. Basically, my take-home message will be, I want to bring a message that all surgeons should go for a retrorectus mesh repair and encourage their juniors to go for a retrorectus mesh repair. Now, I'm not going into the definitions and all. Sometimes we get hernias which are maybe small, like these hernias, and later on in our career we may get big hernias or complex hernias, as we all discussed, like this. Now, classification has already been discussed here. Now, since the beginning of the hernia surgery, all surgeons basically are trying to basically achieve the peak. That means achieve a best method for the hernia surgery. Now, if you go to the history, it has started, hernia surgery has started from Susruta over the Roman period, and all the Romans, they also did it. Then came around 1300 and all. Some of the surgeons we know by name, not their procedures, but because their at that time their surgery was considered to be the best, so we know their names. If you go, Medal, everybody knows, Quinu knows, and the first documented hernia surgery was basically for an insel hernia, was preferred by this person, Dr. Perry Nicholas, and it was in 1836. Then came the era of the simple suturing. We just sutured it, and it was basically popularized by Dr. Medal and Quinu. We know Dr. Medal. And then these simple suture repairs progressed till the grafts started coming. Initially, we had autografts, then came the allografts or prostheses. Initial prostheses that were used were silverware braided meshes, then tantalum gauze. All these have been documented well, had its advantages at that time, had its own disadvantages and complications. Then came the modern era of the mesh that we now see. Now, since the development of the meshes, the journey for the mesh plasty has actually started in earnest. The approaches may be open, may be laparoscopic. We are not going to those. Different types of meshes started coming and are coming. Basically, the products are never ending. Coming to the positions. Now, we had all these positions are now being practiced. Onlay, inlay, all these are being practiced. What is important for the surgeon is basically the mesh position gives a good night's sleep to both the surgeons and the patients. So, what is the best mesh position? Now, this is basically the EHS recommendation of all hernias. Less than 2 centimeter only suture closure, and more than that, basically all the mesh reinforcements along with the component separation will come into play. Now, going to the onlay, basically I want to take this opportunity to tell to the surgeons, please try to avoid this onlay mesh plasty. Rather, go for a retrorectus mesh plasty. Initially, what happens is because of lack of time or whatever, or we think onlay is easy, we put a onlay mesh, but we have to deal with the complications sometimes later on. And my request to the surgeons are, if you start doing retrorectus and if you do it after a particular duration of time, the time taken for a onlay and a retrorectus will be almost same. I am not talking about a complex hernia. Now, these are initially when I started, I was putting this onlay mesh, and you can see quite a big mesh. 2 meshes have been sutured together. I was not using a 30-30 mesh at that time. And The advantages of a onlay is the learning curve is very short, ease, less time, less complicated dissections, all these. Now, what about the disadvantages? The disadvantages are quite a huge, and the patient will be a burden on you for the next 1, 2, or 3 months. Now, these are what we encounter. Might be a small or might be a massive skin necrosis. This is exposed mesh, and this is a huge seroma. These are all complications, some of the complications of a onlay mesh plasty. Now, if you go for a comparative study, we have a wide number of studies. You'll see only all the mesh related complications are quite huge. Any quotation from any journals will show you a onlay mesh, the complications, mesh related complications are quite larger in number than a sublay. Seromas, hernia recurrences, SSIs, all these. Till the advent of Reeves and Stopa, who started the journey of the retrorectus. Surgery is quite easy. If we start from a small hernia, basically, it is quite easy to go into the retrorectus space, where the posterior rectus sheath is basically incised around 0.5 centimeters from the midline linear. This one, this is the edge of the rectus, is 0.5 centimeter from its medial edge, and you create the plane. This is the PRS complex, posterior rectus sheath. Is very quite easy to do once you know. I'm skipping all the dissection is carried out towards the linea semilunaris till we reach the neurovascular, this perforating and the nerves. This is the linea semilunaris. We have to stop our dissection at that point. You can get a good amount of mobilization here, and after closing the PRS complex, we can put a mesh, measure the mesh, put it here. For a very small start doing for a small hernia, then you can gradually progress to a large hernia. Time taken is very less. Now in the retrorectus, we have done around 56 patients. I have not updated now, and the complications you can see is quite less, especially the mesh related complications like seroma and SSI. Seroma is very easy to deal because we have a drain in place, Romovac drain is in place. SSI, there were 3 SSIs which were comparatively easier than an onlay mesh. So my take home message is retrorectus mesh is ideal, better than an onlay mesh, and basically for the surgeons, young surgeons, it is a stepping stone. Stepping stone means whatever surgeries for complex hernias you do, it will be a retrorectus plane or a subplane, be it a laparoscopic, be it a open. So if you don't start seeing the retrorectus plane from a very early stage, you won't be able to go for all the complex hernias that were discussed nowadays. And so basically, this may be the retrorectus, but this may be the onlay, but this is basically the newer procedures that are basically being started to be defined. All surgeons basically want to go for treatment of the complex hernias, basically, be it laparoscopically or onlay. So once you know what a retrorectus is, you can start this. So my conclusion is component separation techniques may be powerful, but we have to know the anatomical orientation of the abdominal walls and dissect in the correct plane. And the correct plane for all advanced surgeries for a complex hernia or for any hernia in that statement, be it a laparoscopic procedure or an open procedure, is a retrorectus mesh plasty. Thank you.
Well done, Dr. Samal. Sir, the case you showed that you attached 2 meshes together.
Yes.
In that case, did you follow up what happened next? I mean, after
So-
6 months or 1 year?
No, there were no recurrences, but
Uh-huh.
that patient landed up with his skin necrosis. No recurrences at that. For 2 years, the patient was coming, 2 or 3 years around. For 1.5 months around, we had skin necrosis. Actually, these 2-3 patients actually made me realize that I should go for a retrorectus rather than an onlay.
Thank you.
Thank you, sir.
Thank you so much, sir. I would request Dr. Jyotirmoy Nayak, sir, to kindly contact backstage. Next, calling upon Dr. Prakash Sasmal, sir, with the topic Bariatric Surgery is a Cosmetic Surgery, Myths and Reality.
So, good afternoon, everyone, and respected chairpersons. So, I'll be discussing something interesting because patients do ask me the first question, I require to lose weight and to look beautiful or handsome. So, is it really a cosmetic surgery? Then many of the doctors do ask, why are you doing this cosmetic surgery? Because they are probably not knowing exactly why a metabolic surgery or a bariatric surgery is done. So to just allay all this confusion, I'll be presenting the metabolic or bariatric surgery. Is it a cosmetic surgery or what is the result actually in my series over here? So all the patient photographs in the presentation are with consent and for view in a closed academic group only. So if you see the recent publication in the newspaper Times of India, it is alarming. 30 million Indians are obese. And still more alarming are the 20% of the school-going children are overweight. And if we go to the malls nowadays, you'll be not astonished to find really 20 to 40% of the population sitting over there, munching over the all these healthy diet so-called are obese. Now coming to why obesity occurs. It is increased energy intake and decreased energy expenditure overall leading to increase in fat stores and weight over years. So obesity, if you see over years, every day if we go on munching extra calories around 100 calories, it has been found that average 2 kilogram will be just increased in your weight, basal weight every year. So we need to take care of that every year. We need not add that extra weight. If you are adding, then definitely obesity will be there in 5 or 10 years. Asian paradox is that Indians tend to have increased waist circumference. For any waist circumference, they have increased body fat accumulation. And for any given body fat, they have increased insulin resistance. So what is that concept actually? If we see, if compared to that of the Western population, same BMI, same weight, they do have more muscle weight as compared to that of the Indian population, they have more fat weight. So we'll be telling that we have the same BMI probably, then we are at less risk or same risk as compared to Western population. No, it is not the fact. That is why if you see the OSI guideline of Obesity Surgery Society of India guidelines, so all the BMI range for the different these operations are 2.5 less as compared to that of the counterpart, Western counterpart. Now coming to obesity classification, I'm not going to details. We know that what is a morbid obesity, more than 40 BMI, if present with or without any complications, clear indications for a bariatric or metabolic surgery. And in case of Asian population, it is 37.5 and more than 35 for the Western and more than 32.5 for the Indian population. If with a major metabolic disease like diabetes, hypertension, or osteoarthritis or obstructive sleep apnea if present, and majority patients do have osteoarthritis even. So why do we treat really obesity? We know that it causes type 2 diabetes mellitus or the major cause for that, and dyslipidemia, hypertension, NASH, cirrhosis and cholecystitis, pulmonary again diseases and obstructive sleep apnea, hypoventilation syndrome and osteoarthritis and strokes. And last but not the least, it is the major predisposing factor for all the cancers in the human body. In case of females, we know breast, colon, and also the endometrial carcinoma. And in case of male, all the cancers are increased predisposition is present because of obesity. Who is eligible? I have already told regarding that. So let me come to the current surgery as of today. What is done and what we do over here. It is the sleeve gastrectomy. It evolved to ruin by gastric bypass, and now the majority chunk done is the one anastomotic gastric bypass, or it is called as the mini gastric bypass by Rutledge. So if we see the commonest procedure which was done 2 years, 3 years back was the sleeve gastrectomy. Now it is slowly evolving towards the mini gastric bypass at the other end. So because it is a procedure which is having both restrictive component as well as the malabsorptive component with a very good result, sustained result. And if we see the metabolic components, the results are excellent in this. That is why I have also switched over now majority of the cases, as I will be showing that. Now, little concept about how the sleeve gastrectomy do really help. Sleeve gastrectomy, we know that from the theoretical knowledge, the fundus ablation is done, so ghrelin reduction is there. So ghrelin is the only orexogenic hormone in the human body which increases the hunger. So if we ablate that fundus part, then probably the patient will be feeling early satiety. That is one of the. But sleeve gastrectomy, if you see in the series also, they do have resolution or remission of the metabolic components like diabetes, hypertension, and all those. So something extra is there. That is, some malabsorption do occur because of the hurried gastric emptying in case of sleeve gastrectomy, which also works in resolution or remission of the metabolic components. Now, if you see the gastric bypass procedures, little different. That means we must be knowing from our physiology knowledge that when the food just goes to the small bowel, that is the jejunum and the ileum, the L cells present over there, they do secrete the GLP-1, which are incretins, and those will be just stimulating, knocking the doors of the beta cells of the pancreas to release the insulin, and that causes a good control of the diabetes in case of these gastric bypasses. So, great example of a teamwork, the bariatric or metabolic surgery. As you can see, usually the senior most anesthetists, they do take around 1 hour to do a slow induction of the patient, and we are in no hurry on the day of a metabolic surgery. And we usually operate in the French position, as you can see, and the extra, you need a wide OT table for the bariatric surgery because the flanks will be falling off the OT table. So it is a real challenge to tackle. And challenges in surgery because we need the extremes of the reverse Trendelenburg position. So we need to perfectly wrap the patient to the operation table so that what happens in the extremes of position, the patient should not be falling. If the patient will be falling, it will be a catastrophe. So, if you see the details of patients undergone the laparoscopic metabolic surgery at AIIMS Bhubaneswar, the first case was done on November 18th, 2015. She was a 48 years old female, I remember, 104 kilo, was carried on a wheelchair to the OPD with all the problems, but she was referred from all the departments because of one reason, that is bleeding PR. After orthopedics, after the pulmonary, after the cardiology, everything. But I found that only the root cause was obesity and treated her with a sleeve gastrectomy those days, and she got relief of nearly 90% of her problems. She was unable to walk. Now every day she is walking around 3-4 kilometers without any help. So with this again the journey continued. We operated nearly with 2 years follow-up around 50 patients of bariatric surgery or metabolic surgery. The youngest was 16 years and the eldest was 58 years. And the 67 last we have added, and the weight range was 92 to 189 kilogram, and BMI range maximum was 65, excessive weight was 110 kilo. We never operate for cosmetic reasons only. So if you see the result now, so comorbidity resolution, if you see, it was a resolution in all the patients. They had some other again metabolic component or disease, and the least concerned is the low self-esteem, which we underestimate. So this low self-esteem in the patient, after 6 months of follow-up, if you see, they will be always confident, their personality changes, and they usually go to all the parties, social functions in the just beginning of the social program. That is the amount of this self-esteem which is increased. Types of metabolic surgeries done. Majority of the cases which I was telling you nowadays is the gastric bypass. That is almost 60 to 70% of the group of patients. Now the weight reduction, if you see, 6 months we found that 29% of the patients do have a good excessive weight reduction of 20 to 25%. Thereafter it goes on increasing to be static almost at 2 years, but still the patient will be losing some weight by 3 years and 4 years of follow-up. Now, comorbidity resolution, if you see, diabetes, one thing I'll show you over here, those patients who had diabetes were on insulin, they had the remission of the diabetes just in the first month of follow-up. That means a good resolution was there in the first month of follow-up. Thereafter, if you see all the comorbidity, the OSA was again the next comorbidity which resolved in 1 to 2 months, and the patients on CPAP, BiPAP, they do not require any machine. And if you see the PCOS in case of females, a very good resolution in the first month itself. They had a regular MH, and infertility for which if we are doing, they had again this, their fertility also increased, and they also were they had child in after 2 to 3 years. And these are the group of patients which got resolved or remission of the diabetes which occurred. And this is the youngest patient, 16 years, requiring around 80 units of insulin every day. And for osteoarthritis basically was operated. Now she is able to walk. And these are the group of patients with again PCOS disease. And these are for the hypertension and also OSA and leg ulcers, mostly chronic venous hypertension. So these are the series of patients, and he also suffered from again hepatitis B and also hypertension, OSA, chronic venous hypertension with leg ulcers, which got completely resolved. And the journey still continued, and if we see, he is the heaviest patient which we operated, 190 kilo. Now he is hovering around 78 kilo. He was just lying on the couch in his home, and now he is employed as a security officer in a multinational company in Chennai. So, friends, if we see he is from a village background, so he was not going to jail. He went, he also toiled at night, just just reduce the weight along with the surgery. So, friends, bariatric surgery is not a cosmetic surgery alone. It provides a disease-free and good quality of life. So, it is better ascribed as metabolic surgery, and looking good is a side effect of the surgery. So, let us just think that it is a metabolic surgery means wherever comorbidity is present, we should think of considering a metabolic surgery. Thank you all.
Thank you, sir. It is a very comprehensive, well-projected presentation.
Thank you.
Thank you.
Thank you, sir, for your informative insights. I would like to thank all the chairpersons for gracing the dais. Moving on to the next lecture session, I invite Dr. Bikash Bihari Tripathi, sir, Professor Pediatric Surgery in Bhubaneswar, Dr. Saroj Kumar Sethi, sir, Dr. Panchanan Nayak, sir, Consultant Surgeon, Sanjeevani Hospital, and Dr. Saroj Kanta Mohanty, sir, to chair the next session. For the first lecture in this session, calling Dr. Manas Ranjan Das, sir, on the topic Optimizing Functional and Aesthetic Outcomes in Hypospadias Repair, a modern and comprehensive review.
Dr. Manas Das is a very well-known pediatric surgeon in Berhampur and Cuttack. Welcome, Manas, to present your topic on hypospadias.
Like this. Yeah. So, good afternoon to all senior faculties, dear colleagues, and my students, also some delegates. So today it's a topic of hypospadias repair. Everybody tells it as a badnam surgery. Don't do it. It will recur, and it will recur. But things has been changed. So every parents wants their child to be like this. But unfortunately, some children, they never able to pee like this, and they pass urine from the under surface of the penis. That's called hypospadias. So what are the etiology? If you see, the incidence is quietly now increasing. Why it is increasing? It's the late marriage, it's the obesity, phytoestrogens, use of plastics, use of cosmetics, these all, and placental insufficiency due to smoking, use of energy drinks. This is causing now the increase in incidence of hypospadias. It's from 125 to 4,000, but some centers it is 50 also in babies. So, what are the most common anomalies associated mostly undescended testes? Hypospadias is the second most common anomaly seen in children next to undescended testes, and these are associated anomalies with prostatic utricles, that is in severe hypospadias, that's persistent of the uterus that remain in the urethra attached to the prostatic part of the urethra, and this is called prostatic utricles. And DST is entirely a different chapter. So next, what is the mechanism, how the development? It is the double zipper technique where both urethral folds they unite to form the penis from the perineum to the corona level, and from the tip, the meatus level, there is a groove develops and they both united at the corona level. So maximum hypospadias are coronal. So there are a lot of classification depending upon the position of the meatus. But practically speaking, if you see this diagram, you can see the meatus at the glance. But whenever you see put a feeding tube, you can see the hypoplastic urethra and it is up to the mid-penile or proximal penile region. So the on-table decision. So Duckett has defined this is an on-table decision. So plan accordingly. So whenever you do hypospadias. So now this child is urinating nicely, having some issues of distal penile hypospadias. But what to do? Whether to operate? When Gallen defined this hypospadias, he used to tell to just to amputate at the level of penis. But it's not, you require surgery. So what is the purpose? In these cases, reduce psychological impact and increase in self-esteem is the most important one. UTI is in case of severe stenotic hypospadias and normal urinary functions. These are to be achieved. At the best stage, it is 6 to 18 months. So these are the varieties of hypospadias. That is the glandular, you can see a pinhole meatus. That requires surgery. This is the second type, is a megameatus. When prepuce is covered, but you uncover it, you can see a large meatus. This is a mid-penile hypospadias. This is a penoscrotal hypospadias with a small gland. This is caudy without hypospadias. Skin is covered, only there is a crooked penis. And this is a severe perineal hypospadias, appear as a female type, but when you see it, it is a severe type of perineal hypospadias. So all these cases, even Mr. Bean can tell this requires surgery. So goals of hypospadias repair. So whenever we are going for circumcision, most of time I see the patient's circumcision at the level of corona, there is no tissue loss is there. But in case of perfectly circumcised penis, there should be a frillet collar. That collar means that inner prepucial skin always give a 40% sensitivity during sexual intercourse. So that collar is radically excised during circumcision. So that collar gives a cosmetic appearance. So you can see the hypospadias repaired penis with a fillet collar. Okay, and this picture, and there is no collar, and these are the post-op PIP repair. You can see a vertically slit meatus with a cosmetic fillet collar. So whether we have achieved, so these are some complication of somebody's or mine also. So these are the things we have not achieved. So the meatus is a tip, but the cosmesis, second is a failed process. The surgeon has told it's done. It's all right, you can pee, no problem. Third is a failed repair, persistent caudy. Fourth is a presence of a lot of skin tissue, no meatus. Second is a torted penis. So whether these are acceptable, so we have to go to achieve this. So what are the procedures? So granular procedures, we have MAC-PI, drag procedures, distal hypospadias, Helix duple, then is granular approximation for the procedures like TIPs, and there is snort graph, these procedures are there. And for the distal penile flap procedures, like we have that Matthews, transverse prepucial and flaps. Proximal hypospadias mostly require two-stage surgery, like Asopa Duckett tube, that is single stage, or two-stage like Bayer's flap, or by BRCA, which is a mucosal flap, buccal graft flap. So this is a case of, these are the cases we can, this is a megameatus, This is a coronal hypospadias. This is a different type of hypospadias. This is a mid-penile. This is a penoscrotal, and this is a severe proximal hypospadias. So before going to surgery, we need some instruments, which a study shown that if you not proper in instruments, the success rate comes from 10% failure rate to its failure rate increases to 27%. So your scissors, your customized instrument is a must. Loops is a must, and bipolar cautery, and that should be keep minimum with 10. So these are techniques that is in case of urethral mobilization is the most is a granular hypospadias which I choose. This is the prepuce preserving repair with meatus at tip. Second is a megameatus case. This is a covered prepuce. You can see the meatus large. Then it is deglobed. Then the glans approximated, fillet collar created, and this is the appearance in C. This is the follow-up after 2 years. Second, this is a hooded prepuce. In this case, the meatus is normal, mildly retorted. The only spongioplasty has been done, and it is repaired. And this is also a glans approximation procedure in which, and this is a typical case of distal penile hypospadias. You can see the white structure is the plate, and this is the incision. Penis is deglobed. You can see the divergation of spongiosa, and the spongiosa flap has been raised from the tunics. Now the glans being created. The TIP means tubularized incised plate. The plate is incised, and erythroplasty started. The erythroplasty done in double layer, and the dartus flap is repaired. So this dartus cover gives a very good coverage to prevent leak. So this is the dartus cover. Then fillet collar is created. Fillet collar is created, and this is the collar created. Then the prepucial excessive prepucial skin done. That's the final appearance of hypospadias. And this is the follow-up patients with GIPs. You can see the meatus tip with a good coron, with a fillet collar and good cosmesis. And the lower pictures are there from small infants, 1.5 years of age, and they have seen a best cosmetic outcomes. So these are prepuce preserving TIP repair, where you can see a normal penis with a good prepuce. If you retract, you can see the meatus at the tip. So this is at the mid-penile hypospadias. You can see this is a long TIP repair with spongioplasty. So final appearance like this. So proximal hypospadias, we can go for a single stage. This is only repair. The flap, prepucial flap is prepared and it's sutured. So its final outcome like this. It is a transverse flap and it's a vertical flap. Whether vertical flap also can give a good cosmetic results like this. These are single stage procedures. Next, in perineal hypospadias, we can go for a Baer's flaps, putting skin grafts. Then this is the second stage where after 6 months, this looks like this. Then we have to go for a the tubularization of the skin, and this is the tubularization of skin, and this is the TBT flap, which covers the anastomotic area and that prevents leaks. And this is the final appearance, and the patient after 1 month of follow-up looks at the tip, penis at the meatus at the tip with a good cosmesis. This is another repair of perineal hypospadias, second stage. So this is a case of failed hypospadias repair or crippled hypospadias repair with persistent caudy. We have put a graft, that is buccal graft, and this is the appearance after 1 year, and after 6 months this required tubularization. These are the complications, some of mine and some of others. This is the most common. Is first one is the fistula. Second one is you can see a meatal stenosis with a, and third one is the discharge of pus or infections. And this one is a rotation, penile rotations is a partial glans dehiscence. The corner one, that one is having that is a case of prepuce preserving hypospadias repair with a fistula in the skin. So final one, this one, the total skin necrosis. So this may happen also in case of hypospadias repair. So these are I have done 210 cases from 2016 to 2024 with a proximal 35 cases and distal penile 175 cases with fistula in proximal at 7. Around 20% we have fistula rate, and in distal hypospadias it was around 13% fistula rate. So what we have observed that the results were fantastic between 1 year to 1.5 years, and the cosmesis was good, the infection was good, infection was least. But in later age, where adolescent, I have operated 20 years adults also with hypospadias, and the results are very difficult because the chance of infection is very high. So summary, from this to a child to be like this, it relieves the stress from parents, but it's a great pleasure for a surgeon because to achieve this require a lot of years of training. And so early intervention, that is the ideal repair between 6 to 18 months are the best outcome, should be operated by expert surgeon doing hypospadias, not by an occasional surgeon. Choosing the ideal surgical technique, that comes from repeated surgeries where they can learn which technique is applied to this case or not. Ideal instrumentation, surgical loops, good tissue handling, ideal sutures. I use PDS, and a good assistant always helps you to do a good surgery. Constantly working on same repair. There are 200 repair techniques, but if you do repair on the same techniques, you can get good results. So to be a hypospadias surgeon, assist at least 50 to 60 cases to start with. So thank you. These are during my training period. Thanks my mentors, Dr. B. Shipati, and he's a Snodgrass, who inspired me to do hypospadias surgery more.
Thank you, brother, for your nice presentation. And due to shortage of time, there will be a question hour in the end of the session.
Thank you.
Thank you.
Thank you, sir. For the next lecture, I'd like to invite Monica Gore, ma'am, on the topic Open Abdomen Dissecting Surgical Rationale and Innovative Management Strategies.
Good afternoon, everyone. So today I'll be speaking on open abdomen, dissecting surgical rationale and innovative management strategies. So basically, open abdomen is one of the very commonly encountered problem which we encounter, but yes, it's one of the ignored problems. So what is basically open abdomen? It is the abdomen which is intentionally left open by the surgeon, and it exposes the abdominal viscera to the atmosphere. So there is a classification for open abdomen. The name of the classification is amended jog classification. So basically in grade 1A, it's a clean open abdomen without adherence between the bowel and the abdominal wall. In 1B, there is contaminated open abdomen without any fixity. In 1C, there is enteric leak with no fixation. In 2, there is development of the fixity. So 2A is clean abdomen with development of fixity. 2B is contaminated open abdomen with fixity, with development of fixity, and 2C is enteric leak, which had started developing fixity. 3 is open abdomen, and 4 is established anteroatmospheric fistula. So the things which I'll be discussing is when to open the abdomen, how to keep the abdomen open, when to close the abdomen, and how to close the abdomen. So how basically we arrive at the open abdomen? Basically the conditions in which we can't close the abdomen. Suppose there is intra-abdominal hypertension, there is grossly dilated bowel, or there is contamination. So in severe contamination, so in those cases we cannot close the abdomen. And some cases in which we should not close the abdomen, like damage control surgery, or if we want to go for relook surgery. Why do we basically why we are discussing open abdomen? Because it can lead to multiple complications. It can lead to bleeding, then it can lead to intra-abdominal collections, then paralytic ileus. It can lead to water and electrolyte imbalance and nutritional abnormalities. The most dreaded complication, it can lead to anteroatmospheric fistula formation, and last but not the least, it can lead to incisional hernia formation. So what will be our goals in management of open abdomen? Basically, first thing is we want to protect the abdominal contents. Then we want to prevent the evisceration of the abdominal contents. Then basically we want to close the abdomen. We want to remove the infected fluid and collection, and we want to prevent the fistula formation. So what are the management options we have? How to close the abdomen? There are temporary temporary abdominal closure methods, and there are definitive closure abdominal methods. In temporary abdominal closure methods, we have static abdominal closure methods and dynamic closure methods. And in definitive closure methods, we all know primary facial closure, and ultimately we can go for planned ventral hernia repair. So what are the different static methods we have? We all know this is basically Eurobag, which we use to cover the bowel loop to protect the bowel and to prevent the evisceration of the bowel loop. Second thing is we can use the towel clips, multiple towel clips. Third thing is this is basically zipper method. We suture this zipper to the facial edges and then we close the abdomen. And this is basically Whitman's patch. In dynamic method, we have VAC therapy. Then this is Whitman patch. This is ABRA, abdominal reapproximation anchor device. And this is basically botulinum toxin, which lead to flaccid paralysis of the muscles. So it basically aid in closure of the abdomen. Then the hybrid method. It's basically Apthera, in which we will be putting, first of all, we will be putting a gelonate. Over it, we will be putting the sponge for VAC therapy. Over it, we'll be putting a mesh and we will be covering it with the VAC therapy. Over the period of time, what we will do is, we will we will take the patient to OT, we will bring the mesh closure and we will try to close the abdomen. Now, new kid in the armamentarium, the fasciotins, in which basically we will be passing the sutures through the facial edges. Then we can see this fasciotens device basically. So graded traction will be provided over the period of time and it will help in closure of the abdomen. Now, according to EHS guidelines, what we should follow, static methods or dynamic methods. So according to this article, for open abdomen closure method, the dynamic methods, they should be followed to close the abdomen and they lead to basically better closure of the abdomen. Now, when to close the abdomen? Patient should be stable. Then patient should be well resuscitated. We should the source should be controlled well. Then the bowel, it should be viable. There is no risk of abdominal compartment syndrome and there is no, we do not want to do any exploration in the future. Now, my take-home message, open abdomen, it saves lives. So it is not like we won't be keeping the abdomen. There are situations in which we have to keep the abdomen open, but it should be a balanced act. And we should keep into consideration basically how we are going to manage the bowel. Multiple methods I already discussed, and importance should always be given on the facial closure. So the closure of the abdomen, it should be early basically, and basically we have to close the abdomen as early as possible. Thank you.
Thank you, ma'am.
Thank you.
And very well, nicely you have presented. I think the photo you have presented, that is a burst abdomen or?
Open abdomen, sir, basically.
I see.
Thank you.
Thank you so much, ma'am, for that wonderful presentation. I would now like to call upon Dr. Ashok Kumar Sahu, sir, on the topic of impact of artificial intelligence on colonoscopy and early cancer detection.
Good afternoon, respected dignitaries on the dais and off the dais, and my colleagues and beloved delegates. So today my topic is the impact of artificial intelligence on colonoscopy and early cancer detection. So what is AI? What is artificial intelligence? That is studying the principles of human intelligence activities, constructing and through an artificial system with certain intelligence, and studying how to let computers completely work that requires human intelligence in the past. So the AI that has been applied to, they have been divided into virtual branches and physical branches. That is, one of them is the machine learning, the essential sub-branch of AI. So they are again divided into subsets like deep learning, supervised learning, then semi-supervised learning, supportive vector machine learning, random forest, and convolutional neural network. These are all the components of this AI system, which we are subsequently going to talk in my subsequent talk, that how they are going to interpret, they are going to incorporate this AI in the early detections of colon cancer. So they usually the most successful algorithms which are used in the medicine, it is the DL and CNN, central neural network, which play a role in data management, information control, diagnosis, and drug delivery. So these are the some of the examples where outside the healthcare system, where using the how we are using the this AI system. That is your as already I have showed in the this previous slides, deep learning, this traditional supervised and all those things. And in healthcare system, like in medical imaging, patient safety, surgery, mechanical ventilation, in this way, these are the this deep model system that how we are going to apply this artificial intelligence. So colorectal cancer screening, how we are going to do? Usually, what are the traditional methods through which we are going to do the screening? That is colonoscopy, the gold standard, then sigmoidoscopy, the most recent that liquid biopsy, stool DNA test, and fecal occult blood test, and CT colonography. So stool-based testing, that is fecal occult blood test, usually that will detect if the blood loss is more than 2 ml per day. So but the problem is there will be false positive results if the patient's diet includes red meat, fruits, and or medications like NSAIDs. So the guidelines regarding the guidelines, the ACS 2018 and the other guidelines, this suggest to annual testing with this fecal occult blood for cancer screening. But the ACP 2023 guideline that suggests that biennial testing with the fecal occult blood testing. But the ACG 2021 guideline, there is no recommendation for fecal occult blood test. And this fecal immunohistochemical test, usually this overcomes the limitations of fecal occult blood test. So there is no dietary limitation, and they require fewer stool samples than fecal occult blood, and the sensitivity and specificity also higher than that of fecal occult blood. And usually the annual screening is needed, which reduce the overall cancer detection rate by 80%. And this multi-target stool DNA test, in this, that is FDA they have approved in 2014, and here they are usually detect the genetic alteration like DNA mutation, microsatellite instability, this altered DNA mismatch and all, and the specificity and sensitivity, usually they are having higher specificity but lower higher sensitivity but lower specificity than fecal occult blood test. This multi-target stool DNA test, according to the guidelines in ACS and ACG guidelines, they told for to do the testing every 3 yearly. But the ACP guideline, they don't recommend for this mitochondrial DNA test for stool. And this serum test, what are the serum tests? That is, in this comes the liquid biopsy, which has been FDA approved in 2016. But there is no recommendation now till now to implement this test in the screening of colorectal cancers. And now coming to the direct visualization like colonoscopy, which is the gold standard for the ages. And usually among screening tests, the total colonoscopy obtains the greatest reduction in mortality, which is 68 to 88%. And this colonoscopy, ideally, the primary quality indicator for colonoscopy, which will tell that the colonoscopy has been done perfectly, that is your adenoma detection rate. So the proportion of screening colonoscopy detecting at least one adenoma, and this is ideally should be at least 25%. And this adenoma detection rate depends upon the cecal intubation rate, withdrawal times, and quality of bowel preparation. So in this, all the guidelines, they suggest colonoscopy every 10 yearly for screening of colorectal cancers. And this flexible sigmoidoscopy, that is the better acceptability than colonoscopy, This allows the visualization of left colon, removal of polyps, and referral for colonoscopy if at-risk patients are there. So what are these at-risk lesions? Like multiple adenomas, at least one adenoma with high-grade dysplasia, or a villus component of more than 20%, or at least one polyp of more than 1 centimeter in diameter. So sigmoidoscopy can be used as a screening test for colorectal carcinoma. So this flexible sigmoidoscopy that already guidelines are there. This 5 yearly we can do, or 5 to 10 yearly also we can do. So this CT colonography that evaluates the 3D colonic imaging through which we can able to detect. But here it is we cannot do any therapeutic investigation. It is only diagnostic. So capsule endoscopy, as again, it is only small pill has to be taken, and the sensitivity and specificity that will be for colorectal polyps of more than 6 mm also it can detect. But again, there will be no consensus guideline for the screening of colorectal cancers. So how AI assist in colonoscopy? Like these are the various intelligence systems like GI Genius, EndoBrain Eye, and EndoAid. All those things they are already has been in market for assisting the gastroenterologist doing colonoscopy. So this endoscopic diagnosis, this is the gold standard procedure. The variations of detection in polyps and adenoma in early colonoscopy screening that is highly operator dependent, challenging, and high loss of work production. So this computer detection systems, these DL algorithms, they usually incorporated in the colonoscopy, and that will improve the detection of polyps which has already been previously not diagnosed due to the variability during the gastroenterologist. And this and another term is that adenoma miss rate, that is the difference between lesions detected by consecutive endoscopy. So this the study they have done by the Kamba et al. They have shown that this adenoma detection rate has greatly decreased with the assistance of artificial intelligence. And if the AMR was more sensitive in detecting the lesions there than the ADR indicators. So this combination of AI and colorectal endoscopy, it is the future. And how this is going to help in usually the histological prediction of colonoscopic colorectal polyps. And this machine learning, how it is, it will improve the reliability of medical images, then reduce the empirical errors, objectively provides the reliable and comprehensive reference opinions, and help the doctor to make more accurate clinical diagnosis. This is the basic workflow of the CNN, how the colonoscopy we are going to integrate the artificial intelligence. And accordingly, the non-invasive tests like CEA, FOBT, there also we can incorporate the this AI system. This bioinformatic tools and all, the non-coding RNAs, this NcRNAs, then this ligands that will detect the metastasis also it can detect through the incorporation of AI. And this now the new term is the digital pathology technology. Here the mechanical learning and deep learning both has been incorporated through the for diagnosis through the histopathology. So what is the future? Where we are looking at in this radiology? There is through radiology also we can integrate the radio mix, which is the prediction of locally advanced rectal cancer. Through MRI and CT also we can use the AI. And what are the challenges? Usually the significant improvements in ADR and the standardization. That is the most important challenge, the incorporation of AI in colonoscopy. And what is the future? That is generative AI and this photo interrogation. These are the now future which will be coming in a big way, which can be possible application in ileus, obstruction, hypertrophic pulmonary stenosis, and IBS. Thank you.
Thank you, doctor. Now it is a good news that the AI is assisting diagnosis of colorectal cancer and all this and assisting these procedures, endoscopy procedures. But is it covered by insurance, present insurance or not? If it is not covered,
yes,
then there should be attempt so that these procedures should be included in the insurance.
Yes, sir.
BSKV and others.
Yes, sir.
Because most of the patients, they come from poor family, poor status.
Yes, sir.
So, and they sometimes fear to go to bigger institutions to whether it can be covered or whether they can afford it.
Yes, sir.
So I hope this should be attempt to cover this by insurance policy.
Yes,
Thank
actually,
you.
yes. Thank you, sir.
Thank you so much, sir. Moving towards the last lecture for the day, I'd like to call upon Dr. Shantanu Sahu, sir, presenting on surgeon burnout, time to address the silent strain.
Good afternoon, all. As we are concluding this conference, we had a lot of academic feast and lots of learning, lots of experiences, personal touches. One thing I want to stress here, one topic, this is the last topic we have got. I have selected this topic because this is one topic which is coming out very frequently. That is the surgeon burnout. It's a time to address the silent issue. As I was searching the literature, I found a very alarming data that around the incidence of 37% to 53%, we are encountering this topic, that is a surgeon's burnout. As I searched more regarding the specialties, I'm not blaming any specialties, I found a still alarming incidence of 69% of incidence of surgeons burnout. So what is the end result of this burnout? So the surgeon burnout usually manifests as these three symptoms, mostly depersonalization, emotional exhaustion, feeling of reduced achievement. So these are the three parts the surgeons are encountering. So let us discuss each part. So coming to the emotional exhaustion, the surgeon feels drained out or emotionally depleted. As a result, he may lose interest or enthusiasm for the work, and there is a decline in the patient care. Coming to the depersonalization, there is detachment of the surgeon to the patients along with the colleagues, and as a result, the surgeon starts to view the patients as the cases as not as individual, as cases. So there is an impact between the doctor-patient relationship. There is also a feeling of reduced achievement. In spite of adequate knowledge, the surgeon feels that the sense of ineffectiveness or incompetence. Then he becomes self-critical, and he has the symptoms of surgeon's burnout. So as you go, so these are the three symptoms described in psychiatry, that is massless burnout inventory. So we are going to have these three symptoms because of this surgeon's burnout. So what to be done? So we need to stress upon that. We should not ignore this class of symptoms we are encountering nowadays. So we should not ignore the unseen. So why these things are happening? Because the surgeons are emphasizing on a near perfectionism because of high pressure environment requiring long working hours, intense patient care responsibility, and dealing with critical situations. So these are the emphasis of a surgeon. And the trap of a burnout is the constant need for precision, the weight of responsibility, and because of that, the significant workload. So these are the trap for the burnout. So what are the risk factors of a surgeon burnout? First common is the work-life imbalance. So that is the commonest cause of surgeons burnout. Younger age, female surgeons, night on call, long working hours, pressure to meet performance metrics, need to make critical decisions quickly, complexity of the procedures, and potential complications. Now we have got a fear of litigations, and of course, with the advent of social media, we are having a fear of missing out or a fear of in comparison. So there is another point we're coming out, that is the social media. Most common is the work-life imbalance and the fear of litigation. So as a result, the surgeons burnout results in substance abuse. These type of surgeons, they go for substance abuse. There may be disruptive behavior, absenteeism, attrition. There may be strained personal relationship leading to divorce. The surgeon can go to depression, ultimately can also go for suicide. So these are the literature showing it's happening gradually. That's the end result of this consequence. So there's a time to break free. So there is always a time out. So what are the factors which are responsible? So we can deal on those factors. So these are some factors which can be modifiable to prevent burnout. We can have factors at the workload setting. We can emphasize the physical health or mental health. We can focus on the demand, the stress, the work environment, and of course, the personal or physiological factors in the family. So these are the few modifiable factors which can prevent this burnout. So coming to workload, so the factors are increase in workload, family, those surgeons who are single or having unsuccessful marriage can have burnout. The work environment, conflict with patients or with higher patient expectations. So that is one of the cause of burnout. Administration, lack of, if you're going for some administrative job, there is lack of time for patient care or the administration will be unsupportive. There is anxiety of personal incompetence. There's lack of personal health and well-being. There's lack of extracurricular activity. And sometimes to add to that, there will be depression leading to substance abuse. Also, this type of factors, the neuroticism, there may be excessive negative emotions. It is found that these are the factors which has caused lower surgeons burnout. Those having children, those surgeons having family and children, having a supportive work environment, working with a mentorship, having good physical activity, having a good emotional intelligence, and having good academic work. And lastly, not the least, of course, it is a bit of concern, that is the surgeon have less concern for income or finance. So these are the factors which carries a low risk of burnout. So to prevent that, we should develop appropriate working conditions or patterns. We should develop some creative interests and hobbies. We should allocate times outside of work for some family and social activities, and have a balance between personal and professional life. So that is the prevention we can do to prevent this surgeon's burnout. Thank you. With this, I want to conclude the conference. Thank you all for participating in this conference. That is the 39th OSASICON 2024.
Thank you very much, Doctor. In my opinion, the more important factors, the factors which you have enumerated, two most important factors are the litigations and social.
So that is, it has been found in literature now,
those
sir.
I think, in my opinion, it is a very important factor for the surgeons to consider, that surgeons usually, surgeon burnout may be.
And in pediatric surgery, only 15% burnout. I think this is a myth.
So I'm not blaming any specialties. These are the letters I got from a journal. So I'm not blaming that. Just to show that this is the incidence we have got now with all specialties.
Okay. Thank you, Professor Sao. You have chosen a very nice topic. Thank you.
Thank you, sir. Thank you all.
Thank you, everybody. Now it's a time for a valedictory function. We'll start it and end it with, please.
As we embark towards the culmination of OSASICON 2024, we gather to celebrate the remarkable achievements of our delegates who have all worked tirelessly.
I would like to begin by calling upon stage our distinguished dignitaries, Dr. Jagadananda Mishra Sir, President, ASI Odisha,
Professor Dr. Manas Ranjan Sahu Sir, our chief guest for the occasion today, Vice Chancellor, Odisha Medical University,
Our guest of honor, Dr. Bijay Kumar Mahapatra sir, Director Health Services, Government of Odisha.
Dr. Prasanna Kara sir, President-elect.
Our organizing secretary, Dr. Sanjay Giri sir and Dr. Shantanu Sahu sir.
And Dr. Sudhanshu Sutar sir, Honorable Secretary, ASI Odisha.
I would request Dr. Sudhanshu Sutar sir now to proceed for the garlanding of medallion and to preside over the meeting.
Can we have a big round of applause, please? Thank you, sir. I now request our guest of honor, Dr. Bijay Kumar Mahapatra sir, to kindly address the gathering.
Good afternoon, everybody. Respected President ASI, respected Vice Chancellor, Odisha Health University, and all other dignitaries. I want to be very short, and all the delegates. Really, it is an honor for me to be a guest of honor in a conference of Odisha State Chapter, which reminds me our involvement in that ASICON in our PG days. Though I was not able to be here for the whole day, but the 3 days deliberation were very qualitative. And one more focus on the first day, the competition between the postgraduates, which was not earlier there. But second thing is, they will be more happy to see more gathering in these sessions. If you see that the crowd is few with presenters, and it will be better if we can motivate people to attend these conferences. I'll be very short and special request because Vice Chancellor is there, ASI President is there. The focus of ASI Odisha chapter on rural side. There's 2 specific requests from my side because to give the facilities and provide healthcare services, specialized care in rural areas which are not accessible, like Kalahandi, I have discussed with you also, Kalahandi, Nuapada, Navrangpur, Malkangiri. We have, the government has set up a specialized unit there with all advanced like laparoscopes, endoscopes, and good equipments for OT. I'll request our president to adopt 1 or 2 districts. We are conducting programs and taking faculties from different hospitals and making camps there so that advanced surgeries will be there. But I request the proposal should come from the our state chapter to adopt 1 or 2 districts in rotation so that our faculties will go do their specialized surgery. It will be hand-holding for general surgeons also. The last topic, Professor Sahu, what he enumerated, I think Saroj sir told regarding litigation. I will tell that it is a overburden on the single surgeon taking care of everything at a district headquarters hospital. The single surgeon needs to attend OPD, IPD, deal emergency, everything there. And gradually the component of the qualitative thing and the new upgradation in surgery, and we should handhold the rural surgeons so that it will be a pan surgical. Thank you.
Thank you so much, sir, for your wise words. Now, I would request our chief guest, Professor Dr. Manas Ranjan Sahu, sir, to kindly say a few words to the gathering.
Dignitaries on the dais and off the dais, all participants, faculties, students, surgeons from every part of the state. When actually the committee gave this authority to hold the conference in AIIMS Bhubaneswar, we were privileged. But halfway through, I had to leave for some other assignment. But all the time, I was in touch with the very vibrant team that was actually doing this conference. So it is the team that matters. It's not the person that matters. And the team has really shown how a conference should be held and what should be the quality of the paper. Yes, I accept your words that attendance was a bit low and we were also upset. The PG day was attended with the very less number of postgraduates for whom the day is manned. Yes, the modalities will surely change. We are also learning, and every time we are learning newer things. Maybe next time you will see the hall on the PG day will be packed with postgraduates, and that will surely happen. So thank you very much from the executive committee, the organizing committee, each and every one those who were involved in holding this conference. All is well that ends well. Thank you very much.
Thank you so much, sir. Now, as is custom, I request Dr. Jagadanand Mishra, sir, President ASI Odisha, to kindly say a few words and pass on the medallion to the new president.
Dignitaries on the stage, in the auditorium, delegates, members of the press and media, my dear students, staffs, and everybody concerned with this 3-day program. This 3-day program was not simply a OSASICON annual function. It was many things. It has many other things added to it. The touch of sincerity, the touch of love, the touch of affection, the touch of academia, and overall the touch of extravaganza, academic extravaganza, will make this function definitely an entity to be remembered for long. Scanty attendance in this type of conferences are a present phenomenon. As our Vice Chancellor of Odisha Health University, Professor Sahu, promised, he will definitely look into the modalities to see that in the future this issue is attended in a very, very positive manner. So let us not be very pessimistic about this scanty attendance. Let us still go on with our job of doing academic excellence and serving the community. As Vijay Babu, our dynamic and ebullient DHS, told, to mark something or to have something from our ASICON Odisha State Chapter as far as the aspirational districts of Odisha are concerned, like Navrangpur, Kalahandi, Koraput, etc., etc. This will definitely be done in the future, but that depends on also the matching initiative from the government of Odisha. ASI is always open to that, but we also expect a very, very welcome gesture from the government of Odisha also, and this thing will also be looked into. As Professor Sahu told, all's well that ends well, and the 3-day deliberations have ended very well. all the deliberations, all the academic presentations, they are of a very high caliber, high voltage. It was high voltage. It was a high octane conference. Everywhere things were moving on, this, there. The type of academia, the atmosphere, the subject matter of discussion was not very small. It was a big conference. So it gives us grandeur, everything to rejoice. With these things, I again thank you all for attending this conference, participating in the deliberations, and I again give my heartfelt thanks to everybody who has contributed for the success of this OSASICON, 39th OSASICON. Thank you all.
Thank you,
Bande
sir.
Utkal Janani. Jai Hind.
Thank you, sir. Now it's a time to exchange the medal and to Dr. Prasannakar, the new chairman ASI Odisha. Also, the changing of the seat also.
Thank you, sir. I now request the new president, Dr. Prasannakara sir, to say a few words and announce the result of the vice presidential election.
Now I request our Vice President, that is elected President of the ASI, Dr. P.K. Patnaik, to please come to the stage. Not that. So let me continue with something. First problem. DHS, Dr. Manas, Dr. Girian Manas, and Dr. Mishra, my friend. So I'm really delighted to hold this post of president of such a prestigious organization like the ASI of Odisha. Actually, I had been working in the ASI for the last 40 years, and I have had already been in different posts of the ASI, but this post is very dear to me. Now, I have got some 1 or 2 points. I'll just tell in short. Without increasing the number of members, it's difficult for the ASI to be called as a strong association. So our first priority will be increasing the number of ASI members. That can be done from the start level, and every ASI member to contact and bring somebody else as a new member. Number 2 is a security scheme that's being provided to the ASI doctors should be accepted by more number of people so that it will be beneficial for everybody, for the doctors who are in the ASI association. And number 3, the most important one I would like to say, yesterday I had a talk with the Vice Chancellor, Dr. Manas, and he said, sir, you suggest and we'll proceed. And DHS is also here. Yesterday the Minister of Health had come. He had suggested that we are going to have a robotic surgery in SCB Medical College. Very nice. It's a very good proposal. But sir, the technicalities that are being taught to our young students, young surgeons, are being there in the medical colleges and the corporate hospitals. Let's make some plan, as DHS said, let's make some plan so that this technical knowledge of our members can be transferred to the periphery level. Periphery level, I mean the district headquarters. As he said, this is the age of laparoscopy. We all are, any talk you see, there will be laparoscopic surgery. So a number of our members are being trained in that way. So if you don't have in the periphery, in the district headquarters at least, laparoscopic facility, 2-3 days back I read somewhere that one of our doctors has had a laparoscopic surgery in a PSC. So I think it is not impossible to have such type of laparoscopic facilities in district headquarters hospitals, because the main aim of our ASI, one of the main aim is to exchange of technical ideas and to send it to the peripheral level. So I think DHS will represent, and I think DHS and Dr. Manas will help us to how it can be worked out. We'll plan out something, and I think it will be done. And thank you. And as regards the conference, it was a wonderful conference, wonderful conference. I thank Dr. Giri and Manas and Dr. Manas Sahu, Vice Chancellor, and all the organizers, everybody who was involved in that. I thank them to have been such a wonderful function, and I hope in future we'll have such type of functions in this institute and other institutions also. Thank you so much. Thank you.
Thank you so much, sir. Now I would request our new president, Dr. Prasanna Kar, sir, to felicitate Dr. Bijay Kumar Mahapatra, sir, Director Health Services, Government of Odisha, Professor Dr. Manas Ranjan Sahu, sir, Organizing Chairman, Dr. Sanjay Kumar Giri, sir, and Dr. Shantanu Sahu, sir, the Organizing Secretary.
Can we have a huge round of applause, please?
Now I request our newly elected Vice President to speak a few words.
मेरा टाइम भी आएगा. No, respected dignitaries on the dais and off the dais, both the presidents, the Honorable Vice Chancellor, Director Health Service, good afternoon. Firstly, thank you very much for reposing faith on me to be one of the presidents in the coming years. Compliments and congratulations to the outgoing president. Best wishes to the new president. And Professor Manas and his team has set a benchmark by this conference in quality, quantity and hospitality. Things will grow. Surgeons, after burnt out, they rejuvenate. And such conferences organized by the team has rejuvenated us for at least a couple of months or till the next year. Director Mahapatra sir, we have taken your advice. Self-visiting, I will recommend that a core team of competent surgeons will adopt a district or a subdivisional hospital for 3 months and handhold the surgeons to mitigate their difficulties. And PG we will definitely look into. And thank you very much. I wish the incoming president all the best in the coming year. Thank you very much.
Thank you so much, sir. Now, one of the most awaited events of the ceremony, as we proceed to celebrate excellence and contributions of our postgraduate scholars who have shown exceptional knowledge and dedication.
First, I'd like to announce the Best Surgeons Club Award being awarded to Bhubaneswar. I would request Dr. Amaresh Mishra sir and Dr. Sushil Dwivedi sir to kindly collect the award.
I would now like to request our dignitaries to kindly step forward for the award distribution ceremony.
Next category of award is ASI Odisha is awarding traveling fellowship for rural surgeons. This year, Dr. Subhranshu Shekhar Lenka of DHH Kendrapada and Dr. Trishul Senapati, CSC Bikepada, District Gajapati. But unfortunately, both are absent today and they have requested to hand over the awards to them and they will collect from our office, ASI office. Yes, sir. Yes, sir.
The Best Thesis Award for PG students. The first prize goes to Dr. Sindhuja Chakraborty, MKCG Medical College. Second to Dr. Gaurav Bhupati, KIMS. And third to Dr. Medhavi Sinha, AIIMS Bhubaneswar. Can we please have them on stage, please? Dr. Sindhuja Chakraborty, MKCG Medical College. Dr. Gaurav Bhupati, KIMS. Dr. Medhavi Sinha, AIIMS Bhubaneswar. Dr. Gargi is collecting the award on behalf of Dr. Medhavi Sinha. Dr. Gaurav Bhupati, KIMS. Dr. Lavanya is collecting the award on behalf of Dr. Sindhuja Chakraborty, MKCG Medical College.
Coming to the best three among PG case presentation, Dr. Mona Lisa Sethi, MKCG MCH, gold medal. Dr. Rajendra Kumar Sahu, Vimsar Burla, silver medal. Dr. Saba Alfat Rupani, KIMS, bronze medal.
Please put your hands together for our scholars. Dr. Lavanya will be collecting on behalf of Dr. Mona Lisa the gold medal. Please put your hands together for our winners. For silver medal, we have Dr. Rajendra Kumar Sahu, Vimsar Burla. For bronze medal, we have Dr. Saba Alfat Rupani, KIMS Hospital. Next, for paper presentation, we have first Dr. Biswajit Rautre, MKCG. Second, Dr. Ramakant Mohanty, Vimsar. And third, Dr. K. Ramesh Bhargav, SCB.
If you get the first prize in the national conference. All the best. Thank you.
Second, Dr. Ramakant Mohanty from Vimsar.
Third, we have Dr. K. Ramesh Bhargav, SCB.
Dr. K. Ramesh Bhargav from SCB. Can we have a huge round of applause, please, for our winners? Moving on to the Surgery quiz results. First, Dr. Akarsh and Dr. Ankit, AIIMS Bhubaneshwar. Second, Dr. Aravinda Kumar and Dr. Yash Chauhan, IMS in some hospital.
Present in the national conference again. So all the best wishes, Ankit. Do it well.
Third prize being awarded to Dr. Abhishek Janamani and Dr. Somdeep Patnaik from High Tech Medical College. Second. Dr. Aravind Kumar and Dr. Yash Chauhan from IMS in some hospital are being awarded the second prize for Surgery quiz.
Can we have a huge round of applause, please? Please put your hands together for the third prize winners, Dr. Abhishek Janamani and Dr. Somdeep Patnaik, High Tech Medical College.
Coming forward to the best three in poster presentation, Dr. Deepshika Avdesh Tiwari, KIMS Gold Medal. A huge round of applause, please.
Dr. Anshuman Rath, SCB MCH for the silver medal. Dr. Vidush Kumar, AIIMS Bhubaneshwar for the bronze medal. Dr. Anshuman. Bronze medal, Dr. Vidush Kumar, AIIMS Bhubaneshwar. Dr. Anshuman Rath, SCB MCH, being awarded the silver medal for the poster presentation. We also have 6 special mentions. Dr. Anisha Ganguly, AIIMS Bhubaneshwar. Dr. Deepak Kumar Sahu, High Tech. Dr. Shibananda, IMS in some hospital. Bronze medal being awarded to Dr. Vidush Kumar, AIIMS Bhubaneshwar. Can we have a huge round of applause, please? All the 6 special mentions to kindly gather on stage. Dr. Anisha Ganguly, AIIMS Bhubaneshwar, Dr. Deepak Kumar Sahu, High Tech, Dr. Shibanand IMS and Some, Dr. Dhanlakshmi, AIIMS Bhubaneswar, Dr. Priya Ranjan Mishra, PGIMR, Dr. Shakti Bhushan Patnaik, UIMSR. WIMSR. All 6 special mentions to kindly come on stage and receive their prizes. We had around 50 poster presentations. Out of these, we have the 3 winners and 6 special mentions. Kindly put your hands together for the winners. The 6 special mentions are Dr. Anisha Ganguly, AIIMS Bhubaneswar, Dr. Deepak Kumar Sahu, High Tech, Dr. Shibananda, IMS and Some, Dr. Dhanalakshmi, AIIMS Bhubaneswar, Dr. Priya Ranjan Mishra, PJMR, and Dr. Shakti Bhushan Patnaik, WIMSR. A big number of free PG paper presentations, out of which the 3 best are to be awarded to Dr. First Prize, Dr. Anisha Ganguly, AIIMS Bhubaneswar, and Dr. Punati Spruha, AIIMS Bhubaneswar. Please put your hands together for them.
For the silver medal, Dr. Shantanu, AIIMS Bhubaneswar, and Dr. Surya Yashashvi, AIIMS Bhubaneswar.
For the 3rd prize, we have Dr. Anshuman Pradhan, AIIMS BB Nagar, and Dr. Sushil Kumar Sahu, WIMSR.
Moving on to the prizes for e-video presentation. Gold medal, Dr. Harshad D. Murgankar, AIIMS Bhubaneswar.
These are the prizes for e-video presentation. The first prize goes to Dr. Harshad, AIIMS Bhubaneswar. Second, Dr. Shweta from KIMS. And third, Dr. Spruha from AIIMS Bhubaneswar.
Second, Dr. Shweta, KIMS. Third prize, Dr. Spruha, AIIMS Bhubaneswar.
Can we have a huge round of applause for all our winners again? I would now like to request Dr. Sudhanshu sir to kindly conclude the session with a vote of thanks.
I'm just requesting Dr. Sanjay to speak few words, then I'll tell. It will take maximum 2 minutes.
Because this conference, whatever we have observed and whatever we have celebrated for this last 3 years, due to some special people who are in the backgrounds. So we just want to felicitate those people. First of all, I would like to thank Manas and team from meetings and board events who was working hard for last 1 month and to making this event. So Manas and team, please come. Second is the audiovisual, whatever we have seen to this academic. I will ask Subudhi and team to come. Just take a. Yeah. Then the food, whatever we are taking for last 3 days, the caterers, SS caterers, I would ask him to come and to just Biswajit, Mr. Biswajit, please give a big hand of applaud even if in the. Then his photographer, you must be knowing Prasanna. So Prasanna and team, the way they are taking the photographs. Then I would request this our LCD and Rajani Samal, Clark and his team, they are doing also a lot of work in the grassroots level. So I would ask them, Rajni Babu and your team, please come to the stage. He was helping a lot of work is there and they have done it in a grassroots level. So then I would love to tell the anchors, four of them, Dr. Anisa, Dr. Gargi, Dr. Ria, Dr. Spruti. So they all, through these 3 days, they are in this anchoring. So they should be given a big applause.
Thank you, everybody. It's just end of a mega academic show of this year.
Fabricator, I just forgot the
Another
fabricator.
okay. Thanks to the organizing team.
They have made all those things, and scenes behind it is our.
Thank you, everybody. Thanks from my core of heart to the organizing team led by Professor Dr. Manasanjan Sahu, and I'm also thanking all the delegates for their presence. Thank you, everybody.
But last but not the least, the persons who are really to be thanked are all the wives of all the organizing team. They actually need to be congratulated that they sacrifice so much to have a wonderful conference. Thank you, everybody. Thanks, everybody, for joining. We'll be meeting again next time in SCB Medical College, Cuttack. Thank you. Thank you.
Thank you, everybody.